So next, if you have a patient presenting with a decreased level of consciousness, um, how are you going to manage this patient? So decreased level of consciousness is a collective and non-specific term referring to a change in cognitive function, behavior, or attentiveness. So it can include delirium, dementia, the patient being lethargy, the patient be tubal or coma. So it involves all this five criteria. So coma is a sleep-like state, not arousable to consciousness. And when the patient is lethargy, they have a state of decreased awareness and decreased alertness. But patient may actually appear wakeful. So when we're looking at coma, we're looking at a GCS of lesser than 8, and you have a majority of causes is due to metabolic or toxic causes. So we're going to use the mnemonics metabolic. So the major causes are your major organ failure, electrolyte or endocrine, your toxin, your temperature. It could be hypothermia. It could be acid disorder. It could be base disorders. It could be decreased oxygen level. It could be lactate, increased lactate, insulin, too much insulin, too little insulin. It could be infections. It could be cardiac causes or hypercalcemia. Okay, so if a patient presents with a decreased level of consciousness, you want to try and figure out if they have any of the above. Okay, another way to remember the possible causes, it could be acidosis or it could be alcohol. All right, it could be epilepsy, it could be infections, oxygen, uremia, it could be temperature, trauma, especially trauma to the head. It could be insulin, too much insulin or too little insulin, psychogenic, it could be poisoning, or it could be a structural or space occupying lesion in the brain. So the first thing you want to do, you want to actually rule that out. So if you do not find anything on the major causes of coma, then you can check for the other causes, usually your primary central nervous system disease or trauma. So if you can, the patient could be having any brainstem involvement, uh, such as a compressive supra or infratentorial tumor or an sub or epidural hematoma that is compressing the brainstem, or they could have a direct brainstem or infarct or hemorrhage, or it could involve your hemisphere, your cerebrum hemisphere. So in a form where you have diffuse lesions or you have diffuse trauma or ischemia to your cerebral hemispheres, and then now this is affecting cognition. All right, now the person comes presenting with GCS of lesser than 8. Okay, so how would you now manage a patient with altered level of consciousness? You want to obtain collateral history from the friends, the police, paramedics, the patient record. Try and check the patient record. Are they wearing any bracelet? Any medic alert? And then you want to know how did I start? How is the onset and the progression? Was there any trauma involved? Did they had any seizure activities? Did they had any fever prior to the loss of consciousness? So any abrupt onset. So abrupt onset of loss of consciousness actually suggests central nervous system hemorrhage or ischemia. Okay, so you will want to do your CT scan. It can also suggest any cardiac causes. So you first start with your ECG, or it can also suggest any poisoning. Okay, so if the level of consciousness was sudden, so check for your central nervous system hemorrhage or ischemia or cardiac causes or any form of poisoning. So if it was progressive over hours to days, it could suggest a progressive central nervous system lesion, or it could be a toxic or metabolic cause. Okay. So you want to determine the patient baseline level of consciousness. Okay, before the the outer level of consciousness, how were they before, and then you want to know any past medical history, any history of depression, any similar episode in the past, and what was the cause. You want to know any overdose, any changes to the usual medication they are used to. Then you move to physical exams. You want to do your ABC, making sure airway, breathing, and circulation is stabilized. And then you want to do your vitals. Make sure you include temperature. You want to do heart rate, blood pressure. You want to put on your cardiac monitors. You want to check respiration, respiratory, cardiac exams, abdominal exams, and make sure you complete neurological exams. In particularly, examine the eyes. You want to check the eyes for pupils equal or reactive to light. You want to check that, and then use the glycocomin scale to evaluate the level of consciousness. Okay. Then investigation in this patient, you want to do your blood work because remember we first want to rule out any metabolic causes, any toxin or metabolic causes. So obviously you're going to do your serum glucose levels, your electrolyte, your creatinine, LFTs, your serum osmolality, your CBC, your arterial blood gas or venous blood gas, your lactate, your PTT, your iron R, troponins levels. All right, and then you want to check for your toxins. So you're going to do a toxin toxicology, such as checking your serum acetaminophen levels because they might have it could be due to poisoning or overdose. So you check for your serum acetaminophen levels, your salicylate levels, your ethanol level. Okay. Then you also want to do your imaging. Okay, is there, you want to rule out, is there any cerebral hemorrhage, is there any brainstem involvement? So you'll do your CT scan, your chest x-ray, if the patient is respiratory compromised or has symptoms. Other tests you can do is your ECG, your UNE, your urine toxicology as well, checking for any toxicity that can be found in the urine as well. Alright, so diagnosis. So distinguish between structural and toxic metabolic coma. So structural coma, you look for the pupils, the extraocular movement, you look for and motor finding, and if it's present, they are usually asymmetric. Okay, so look for focal or lateralizing abnormalities such as weakness on one side, decreased reflexes, decreased tone, and then for your toxic metabolic coma, you can have dysfunction of the at the lower level of the brainstem, and that will cause caloric unresponsiveness. They can have respiratory depression with with intact upper brainstem, where you have equal and reactive pupils. It could be due to extraocular movement and motor findings are symmetrical or absent. Okay, so okay, so next we'll be talking about toxic metabolic causes of fixed pupils. Okay, so what are the causes of dilated pupils? Metabolic causes. So it could be a nausea. It could be anticholinergic agents like atropine, your tricyclic antidepressant. Okay, it could be methanol, cocaine, opioid withdrawal, and amphetamine, your hallucinogens, serotonin syndrome. Okay, in patients that are given SSRIs. So this will cause a dilation in your pupils. And what will cause constriction of your pupils? It will be your cholinergic agent, such as your organophosphate, your opioids, such as fentanyl, your heroin. Okay, will cause your constriction of your pupils. So how would you now manage a patient present with low level of consciousness? Okay, so remember we spoke about what to look for. We spoke about you taking your history, physical exams, investigation. Now, how would you manage this patient? So, what are you going to start by giving them? You administer them the appropriate universal antidote. So, with the mnemonics DONT. So, D for dextrose. You're going to give them 50 moles or 50% dextrose. If hypoglycemic, on point of care test. So, you quickly do a capillary blood glucose to find if they're hypoglycemic. Then, oxygen. Checking the saturation, it will give them oxygen. Then naloxone. So naloxone 0.4 milligrams up to 10 milligrams IV. If you suspect any opioid overdose, you're gonna give them thiamine 100 milligrams IV. Okay. If there's a history of alcohol or if the patient looks malnourished. Okay. So that's the first steps. Okay. So you admission. So you're gonna admit them if you have ongoing decreased level of consciousness and admit to services based on the tentative diagnose. So you after doing all your tests, based on the results, you will know which department you're going to admit them there, and you can discharge them if they have reversible outer level of consciousness and ensure that there is adequate follow up. Okay, so that's how you manage a patient when a patient presents with coma, DCS lesser than 8. Or a patient presenting with an outer level of consciousness, whether delirium or dementia. Next, we're going to talk about chest pain. Okay, so what are the emergent differential diagnosis of chest pain. So it could be an MI and stable angina, it could be aortic dissection, it could be cardiac tamponade, it could be arrhythmias, it could be pulmonary embolism, tension, pneumothorax, it could be esophageal rupture, it could be a medullary waist tear, it could be a pneumomediastinum. So there's a couple of causes. Okay. So what are the classic angina characteristics? The classic angina characteristics are, number one, they're going to have a retrosternal location. So chest pain will be a retrosternal, provoked by exertion, number one, and relief by rest or nitroglycerin. So those are your characteristics of a classic angina. So classic angina, chest pain, retrosternal chest pain that is provoked by exertion and is relieved by rest or nitroglycerin. Now, what are the risks for coronary artery disease? The risk for coronary artery disease, number one, is your 3 out of 3 is a typical angina. Then they had high risk. Intermediate risk for females over the age of 50 and in all men. And intermediate risk of men over 40 years old and women over 60 years old. So obviously you are going to check the history, you want to know the history, any previous episode of the chest pain, what is the change in pattern. You want to check the cardiac risk factors, you want to know, are they having any hypertension, diabetes, dyslipidemia, smoking? Is there any family history of any heart diseases? And then inquire about any previous cardiac procedure done, any last stress test done, any last angiogram done, and if they are currently following up with a cardiologist. So you want to know all of that. You want to do your vital sign, you check your cardiac exams, your respiratory, peripheral, vascular, and abdominal exams. Okay, so history, physical exam, important. Then you move to investigation. For all this patient presenting with chest pain, you want to do an ECG. That's the most important step. Assess for STEMI, okay, or those that may evolve to STEMI. So check for that. Always compare previous. So if you have previous ECG, always compare previous ECG with the current ECG. And ECG may be normal in up to 50% in patient presenting with pulmonary embolism and acute MI. So it's not something you do now and you stop. You will do now and you can repeat the ECG maybe in 15 minutes. Then you want to do your CBC, electrolyte. You want to find out, is it having chest pain due to any hyperkalemia now that is affecting the heart? So you want to check all of that. Glucose, you want to check the patient INR, your cardiac markers, your troponin. You want to check your D-dimers if indicated. Chest X-ray. You also want to compare your chest X-ray to the previous ones if you have previous X-rays, and in CT, if indicated. Okay, so if you're suspecting aortic dissection or pulmonary embolism, then you do your CT scan. And obviously, management, as the patient enter, you always want to do your ABC. Okay, ABC, airway is stable, breathing, circulation is stable, oxygen need if they need it. You put on your cardiac monitors, your IV access. Then you treat the underlying cause and involve consultants as necessary. Okay, so you will treat according to then to what the patient is presenting with. Okay, so let's dive into the differential diagnosis of chest pain. So it could be an acute, number one could be an acute coronary syndrome. So how would this patient present? So it could be a new or worsening pattern of remember we spoke about, it's usually a retrosternal chest pain. So they may describe it as squeezing, as a pressure pain, usually radiating to the arm or the neck, presenting also with shortness or break that has worsens with exercise and relief at rest. They usually present with nausea and vomiting or syncope episode. Okay, so those are the classic history the patient can present with. Now, so classic findings, what can you actually find? You can find new or worsened murmur, hypotension, the patient might be sweating. You can find pulmonary edema as well on examination. So what are the diagnostic investigation? You will do your ECG first, and you'll find ischemia. So 15 lead if hypotensive. You'll see AV node involvement. You might have AV node involvement or inferior MI. So you do a serial troponin 1. Okay, it's usually sensitive within 6 to 8 hours after the onset of chest pain. Your troponin, chest X-ray as well. So how would you manage this patient? Suspecting a coronary artery disease. What are you going to do there? You do an ABC. It's the airway, breathing, circulation in all your patients. Next, you want to give them aspirin, right? Then anticoagulation. and you consult cardiology, okay, and consider a percutaneous intervention or thrombolytic. Okay, so you do give them is it ABC, do your ABC, give them aspirin, anticoagulation, then urgent consultations with cardiology. So remember that acute coronary syndrome is more likely to be atypical in females. So female patient might not present with the actual symptoms that we know. Okay, so especially if they're over the age of 80 and if they're diabetic. Okay, so they might present with dyspnea or sweating, fatigue, non retrosternal pain, chest pain. So the symptom might be atypical. It is important to look for reciprocal changes to STEMI in order to differentiate from pericarditis. So, because remember, the ECG of a patient with pericarditis and a STEMI, they usually have ST elevation. But remember that in pericarditis, it's diffuse, and obviously pericarditis, you're going to have maybe a history of viral infection, or the patient has chronic kidney disease. Now the uric acid is high. Now this is causing them to have pericarditis. And then always remember that tracheal deviation is away from tension. So any patient presenting with tension pneumothorax, the trachea will be away. Any other cause like lung collapse whatsoever, the trachea will be towards the affected side. Okay, so it's only in tension pneumothorax where you have the trachea moving to the opposite side. Next, we're going to quickly look at pulmonary embolism. The patient can present with pleuritic chest pain in 75% of cases. They will present with shortness of breath, and obviously they're going to have risk factor for venous thromboembolism. Obviously, previous DVT, previous surgery, so they will have risk factors for venous thromboembolism. So they can have tachycardia, hypoxemia, and evidence of a DVT, and then you can actually use the Wells criteria to score the patients, and then you can do a D-dimer, CT, pulmonary angiogram, or you can do your ventilation perfusion scan in pregnant women or patients that are where the kidney functions is actually impaired. Then you can do your leg Doppler just to check for any DVT, and then do your chest X-ray as well, just to check that it's not maybe pneumonia that you're dealing with or something else. Okay, management, you want to do your ABC like all the time. Anticoagulation, consider airway management and thrombolysis. So you want to do if patient present with massive pulmonary embolism, you need to do thrombolysis, okay? Because they might have hypotension or cardiovascular collapse. So acute pericarditis. Usually, you're going to have a history of a patient that had a viral infection previous days. Now they have anterior precordial pain. They have pleuritic pain, chest pain that is relieved by sitting up and leaning forward. So they have friction rub. On examination, you will hear a friction rub around the heart area. Then you do your ECG. You will see sinus tachycardia, a diffuse ST elevation, PR depression, and lead 2-3 AVF and V4 to V6, and reciprocal PR elevation and ST depression in AVR plus or minus V1. And you can also do your echocardiogram. Alright, so you do your ECG, you do your echocardiogram. How would you manage this patient? Obviously, you do your ABC first, you rule out any MI, you give them high doses of NSAID, okay, or plus or minus colchicine. Then you consult if it's a chronic acute pericarditis, or if it's a recurrent pericarditis, then you consult cardiologist. So large pericardial effusion or non-viral causes like SLE can cause acute pericarditis. Renal failure due to increased uremic acid. This patient may actually require surgery. Next, pneumothorax. So usually this patient, they remember we have pneumothorax caused by trauma, and it could also be caused spontaneously in patients that had chronic lung diseases. They'll present with pleuritic chest pain, often in tall. So remember, spontaneous pneumothorax usually present with pleuritic chest pain, often in tall, thin, young athletes. They can actually have spontaneous pneumothorax. And then, or you could have the history that the patient was involved in a trauma setting. Okay, now they have hemithorax with decreased or absent breath sounds. They have hyperresonance. They deviated trachea and hemodynamic compromise. So if there's tension pneumothorax, obviously it's a clinical diagnosis. Remember, you are later on can do your chest X-ray. Okay. So ABC, and then what do you do? Needle. You insert your needle decompression to the second intercostal mid-clavicular line or fifth intercostal mid-axillary line. Okay, if unstable. Then urgent surgical consultation, thoracostomy. Then you can put your test tube on the fourth intercostal space. The chest tube, sorry. So aortic dissection, how the patient present? They present with sudden severe tearing, retrosternal or mid-scapular pain, plus or minor focal pain, neurologic loss in extremities. Okay, so they will usually present with hypertension, systolic blood pressure difference. So when you're doing the blood pressure in the limbs and that of the lower limbs and the upper limbs, there's usually a difference of more than 20 millimoles of mercury. Or pulse deficit between the arms. So the pulse on the side of the left arm is far different to the pulse of the right arm. And then when you check, you could hear a aortic regurgitant murmur. So if you suspect an aortic dissection, you will do a CT angiogram. You can do a chest X-ray where you find a wide mediastinum. You'll see left pleural effusion, indistinct aortic notch. Indistinct aortic notch. So it will be disrupted the aortic notch on an X-ray. And then more than 4 millimeter separation of the intimal calcification from the aortic shadow. Okay. So what I'm going to do, what can you actually see on X-ray? Let's repeat that. So on X-ray, you can see a wide mediastinum. You can actually see a left pleural effusion. Okay. You can, because remember, the direction of the water is more on the left. Okay. You can have a indistinct aortic notch. So the normal aortic notch will be disrupted. You're going to see more than 4 millimeters separation of the intimal calcifications from the aortic shoulder. So obviously you want to do ABC respiratory, reduce you need to reduce your BP. Okay. So if they have increased BP, you need to reduce your BP and the heart rate. Okay, and classify type A. Usually the ascending aorta that is involved. So if it's a type A, meaning ascending aorta that is involved, you need an urgent surgery. If it's a classified type B, it's usually not involving the descending aorta. So it usually is a medical, you treat it medically. Okay, on CT angiogram, and you do your urgent consultation. Usually, so you consult. So next, cardiac tamponade. So patient present with dyspnea, cold extremities, chest pain, often a recent cardiac. So patient present with chest pain, often a recent cardiac intervention or symptoms of malignancy, or they can have connective tissue disease as well. So you need to also look at that. So what is the Beck's triad? Beck's triad is the symptoms that are found in patients with cardiac tamponade, which involves your hypotension, elevated GVP, a muffled or distant heart sound, tachycardia, pulses, paraoxidosis. And then clinical management, how are you going to manage them? It's a clinical diagnosis, remember? So you are going to do your fast ultrasound. You can also do your chest X-ray. Then obviously you do your ABC, involve cardiac surgery, cardiology consultation. You need to do empiric cardiocentesis if unstable, and then treat the underlying cause because it could be due to malignancy, connective tissue disease. So esophageal rupture, usually sudden onset of severe pain after endoscopy, forceful vomiting. It could be due to after endoscopy. It could be due to forceful vomiting. It could be labor, or it could be convulsions. Patient has convulsion, or in the context of corrosive injury, especially alkaline. Let's say patient had an alkaline poisoning, or if the patient had cancer, then they can actually present with esophageal rupture. So on examination, you will find a subcutaneous emphysema, okay, of the skin, of the superficial skin, and then finding consistent with sepsis. So you want to do a chest X-ray, pleural effusion. So you might find pleural effusion in 75% of cases. You have your pneumomediastinum. You can also find pneumomediastinum and CT scan as well. CT or water soluble contrast esophagogram. Obviously, you're going to do your ABC, early antibiotics, resuscitation, and your thoracic consult, NPO, keep the patient newport os, and then consider chest tube. Remember that patient can present with chest pain if they have GERD or esophagitis. Usually they'll have a history of frequent heartburn, acid reflux, dysphagia, relief with antacid. So an examination, they usually have an oral thrush or ulcer. So obviously you're just going to do ABC, and then you give them PPI medication. Tell them to avoid alcohol, smoking, and trigger food like spicy food or chili food. The herpes zoster usually present with abnormal skin sensation. So itch is usually itching, tingling pain, preceding rash by 1 to 5 days. So usually present the skin start having been itchy, you start having this pain on the skin, usually tingling as well, sensation. Then after 1 to 5 days, now you have the rash. So basically, sometimes they present with no rash. It's in your early stages, but then once there's rash, usually your maculopapular rash, is within the dermatomal distribution. Okay, so it's always going to be on one side. It never crosses the midline. Right? So it's within the dermatomal distribution. So you have development. The rash develops into vesicles and pustule that crust. Okay, so you start first with your maculopapular rash, then it moves to vesicles, then into papules, then it crust. Okay. Diagnosis is also clinical. Or you can do a direct immunofluorescence assay. So you're obviously going to do ABC. So patient stable, yes. Then you give them your antiviral medication if it's less than 48 hours of onset. Okay. Your analgesia plus minus steroid dressing. If they actually need dressing, referral if necessary. Usually they get discharged the same day. So anxiety, patient with anxiety can also present with chest pain. Okay, so but in this case, they will have some symptoms of anxiety, the history of depression. They will have a history of psychiatric disorder. It may coexist with physical disease as well. So they present with tachycardia, they have tremors, they are sweating. So it's actually a diagnosis of exclusion. So after you've diagnosed everything else, rule out everything else, that's when you can actually diagnose that they're having anxiety. So ABC, you're going to arrange social support, rule out any suicide ideation, and consider any psychiatry consultation. So what are the common life-threatening ECG changes? So number one, Tosidis de Puentes. So it's on the ECG finding, what are you going to see? You're going to see ventricular complexes in upward pointing and downward pointing continuum with a heart rate of 160 to 250. So it kind of looks similar to ventricular tachycardia. So ventricular tachycardia, you're going to see 3 or more consecutive premature ventricular beats, all right, with a heart rate of more than 100 beats per minute. And then ventricular flutter is going to be smooth sine wave pattern of similar amplitude. Ventricular fibrillation is this erratic ECG tracing, no identifiable waves. Okay. So those are usually your dysrhythmias. Then conduction. Conductions are usually your second degree heart block, your Mobitz type 2, and third degree heart block. So second degree heart block usually have a constant PR interval and then an intermittently dropped P wave. Okay, but you have a constant PR interval. And then third degree heart block, you have a prolonged QRS complex, which is more than 0.12 seconds. And then you have when you have total AV dissociation, but a stable P2P and R to R interval. Then in ischemia, you can have a STEMI. So usually it's ST elevation in leads associated with the injured area of the heart. And then metabolic, you can have hyperkalemia. So a patient presenting with hyperkalemia on the ECG, initially, you can have tall T waves, followed by PR prolongation, QRS widening, and loss of P waves later on. Finally, they can have a sinusoidal pattern and a pulse electrical activity. So they can actually end up having a VTAC or asystole. So watch out for hyperkalemia. So initially they present with tall T waves, then they can actually worsen, and then they present with VFib or asystole or PEA. So hypokalemia, they will have a P wave that is flattened. So just the opposite of, so the P wave will be flattened. They also going to have a flat T wave. Okay, so instead of having a tall T wave, they're going to have a flat T wave. U wave usually appears. QRS complex is also widened and flattening. Okay. Okay, so you have a patient that can have syndromes such as the long Q syndromes. On the ECG, you have QT interval longer than half of the cardiac cycle. So they're actually predisposed to ventricular dysarrhythmia, like VFib, VTEC. All right, so headaches. So causes of headaches, it could be common and less serious ones, or it could be less common ones but serious. So the common ones and the less serious ones are your common migraines, your tension pneumothorax. So common migraines, you could either present with an aura, or it could be a classic migraine with no aura. So usually commonly present with unilateral thrombing. So always you will see the word thrombing, aggravated by activity. Could be moderate to severe intensity, nausea or vomiting. Present with photo or phonophobia. So classic ones, fully reversible oral symptoms that precede the headaches. They could have flashing lights, pins or needles, paresthesia or vision loss just before the headache. So that would be an aura. Treatment, simple analgesic, acetaminophen, aspirin, antiemetics, triptans. Family physician you can refer them to the family physician to consider prophylactic treatment. So what is a Calmon therapeutic approach in a severe migraine? Patient presenting to the ED and then they have a severe migraine. What are you going to do? 1 liter of bullous normal saline. What are you going to do? You're going to treat the nausea or the vomiting with metoclopramide, 10 milligrams IV. You're going to give them NSAID, such as your ketorolac, 30 milligrams IV, your dexamethasone, 10 milligrams IV. Okay, and you can also give them other things like sumatriptans, analgesia, haloperidol, and so on. Okay, tension pneumothorax. Tension pneumothorax, actually, patient present with bilateral. The pain is usually like a band around the head, the forehead. So bilateral, non-thrombing, not aggravated by physical activity. You could have mild to moderate intensity and can actually last for 30 minutes to 7 days. So usually it's triggered with what? Stress, triggered with what? Sleep deprivation. So if they're not sleeping well, they have a history of not sleeping well, history of stress, think about tension pneumothorax. Treatment, obviously, you need to help them deal with their stresses. You can actually refer them to social worker, for example, and then give them simple analgesics like NSAID, acetaminophen, or aspirin. So what is the less common one but potentially fatal? Number 1 is your subarachnoid hemorrhage. Now, this patient presents with sudden onset. So it's a quick thing. Quick onset. Sudden onset of worst headache of their life. They say this is the worst headache of my life. With maximum intensity within minutes. And so they describe it as like a 10 o'clock headache. All right. Usually has you have increased pain with exertion. Usually involves nausea and vomiting and meningeal sign as well. So diagnose is what? With CT scan. So CT scan, this you can send the patient for CT scan. If you do not see anything on the CT scan, you can do an LP after 6 hours. Just looking for xanthochromia. So basically a yellow discoloration of your CSF. And management is going to be an urgent neurosurgery consult. Okay. Another patient can also present with headaches, and it could be due to increased intracranial pressure. Now, with increased intracranial pressure, patient will usually have headaches that are worse in the morning, headaches that are worse when they are sitting up, when they are supine. Sorry, supine meaning lying flat, or bending down, or when they have they're coughing or Valsalva maneuver. Okay, so if you think if they say this patient has headache worse in the morning, okay, think about increased intracranial pressure. Excuse me. All right, so basically, physical exam. You are looking. You're gonna do a physical exam. You might found neurological deficit, cranial nerve palsy, papilloedema. Remember, papilloedema is actually the latest sign of increased intracranial pressure. And then diagnosis, you can do a CT scan, and then if you first want to do a CT scan, if you rule out any space occupying lesion, then you can do your LP, especially if you're suspecting an idiopathic intracranial hypertension. So what is that? So idiopathic intracranial hypertension usually found in women with that are over maybe the age of 50 with high BMI. Is also known as your pseudotumor cerebri. And basically what happens is that the patient has an increase intracranial pressure of unknown causes. So when you first do your CT scan, you find that this patient, they don't have any space occupying lesion. All right, so when you do an LP, you are relieving them of that. You relieve that intracranial pressure, and then the patient seems to get better. So what are the symptoms? They'll usually present with pulsatile tinnitus, so severe headaches, all right? And then they actually have risk of blindness if it's missed. So it's a very important diagnosis. Due to optic nerve swelling because of the increased intracranial pressure, you have optic involvement, and that can actually cause blindness. Okay? So remember, idiopathic intracranial hypertension. So another cause of headaches could be meningitis. So at least 2 of the following features suggest that the headache could be meningitis. So that would be fever. They will have fever with headaches. Headaches, check for neck stiffness. Headaches, check for a level of, they will have altered mental status. Okay, if they have any of this, then you suspect any of these 2, either fever or neck stiffness or altered mental status, then think about meningitis. Possible clinical or laboratory findings. They may have nausea. When you do a neurological exam, they might have focal neurological signs. They can have seizure. They can have papilledema as well. They can have a petechial rash, actually. So check all of that. And then they can have high CSF white blood cell count, growth of organism in a blood culture. So investigation, what you do, when you rule out increase in the cranial pressure. So the first thing you want to try and do if you suspect meningitis is do a CT scan. But if you can't do a CT scan, this should not actually stop you from actually starting antibiotics. So you want to do a CT head, mental status, check for neurological sign, for papilledema. Then once it's ruled out, then you want to actually do your LP. So treatment, how would you treat the patient? Empirical. So you're going to start them empirical antibiotics. You're going to give them high doses of ceftriaxone, high doses of vancomycin, and ampicillin, especially if they're over the age of 50 years old or they're immune compromised. Then you can give them also acyclovir if you're suspecting any viral meningitis with plus or minus steroid. Okay. So do not wait for the LP results. Do not wait for the LP before you have to start the antibiotics. Okay. Do not wait for the LP. So giant cells arteritis can also be another cause of headaches. So what is giant cells arteritis? Also known as temporal arteritis. So it is an emergency. Okay, so it causes significant morbidity and blindness. Giant cell arteritis. So basically, what do we have? So it's inflammation. So it's inflammatory autoimmune disease, and commonly it affects your temporal arteries. Okay, and then patient will present with severe headache. And then when they come, they'll present like complain of scalp pain, the jaw pain as well. Okay. So remember, it's a vasculitis, inflammation of your blood vessels, especially your temporal arteries. Affects more female than male, and most commonly over the patient over the age of 70 years old. So usually you're looking at elderly. An elderly patient presenting with severe headache, scalp pain, jaw pain. Think about giant cell arteritis. So they can also have other symptoms associated to that because remember, it's an inflammatory autoimmune disease. So they can have arthralgia, they can have myalgia, they can have fever, malaise, weight loss as well. So on examination, if you palpate the temporal artery, usually there is tenderness on palpation of the temporal artery. And then patient can also present with optic disc edema on fundoscopy. And then when you do your lab investigations, they usually have elevated ESR or CRP or both. So how would you diagnose it? The gold standard is to do a temporal artery biopsy. And remember, it's an autoimmune disease, so it's associated with polymyalgia rheumatica. So once a patient has this, you need to look for polymyalgia rheumatica. So treatment, you're going to start them with high dose of steroid, okay? Immediately if suspected, okay? Or else this patient can actually have blindness. So no need to hold treatment until your pathological result. So immediately, you're going to start them with high dose of steroid. Next, other type of headaches that patient can present with. Other causes, it could be due to cerebral venous sinus thrombosis. Okay. So what is it? So it's a gradual or sudden onset of headache, vomiting, papilledema, visual disturbance, focal neurological deficit, seizure, and acute mental status changes. And then when you do your investigation, your CT head, your CT venogram, you want to actually also rule out intracranial hemorrhage. So treatment of this is an anticoagulation. So mostly you're going to give them low molecular weight heparin or heparin. Okay, so this can also cause us headaches, cerebral venous sinus thrombosis. So in meningitis, do not delay IV antibiotic for LP. Deliver first dose of dexamethasone with or before first dose of antibiotics. Okay, so try and give dexamethasone with either with the first dose of antibiotics or before the first dose of antibiotics. Next, gonna talk about joint pains. So remember, rule out life-threatening causes of joint pain, such as septic joint, osteomyelitis. Obviously, patient presenting with joint pain, how are you going to go about it? The first thing, you want to know your history. Is there any recent trauma? Is there any drug use? Are they using any drug use? Anticoagulants, glucocorticoids? Is there any associated symptoms? Is there any fever, constitutional symptoms, any skin lesion, any conjunctivitis, urethritis? Okay? Want to know the pattern of the joint involved. Is it polyarticular, meaning many joints involved, or monoarticular? Is it symmetrical? Is it just on one side or one knee, or is it asymmetrical? Then you want to know, is there any inflammatory symptoms? Okay, so what are the inflammatory symptoms? Or your morning stiffness. So for example, rheumatoid arthritis is an inflammatory disease. So most of the time they're going to present with inflammatory symptoms, such as your morning stiffness more than 30 minutes. They present with pain or stiffness. Okay, that is with activity, and midday fatigue, and then soft tissue swelling. So for patients like rheumatoid arthritis, they're going to have pain and stiffness. Okay, that actually gets better with activities, but then when they sit down for long, that's when they have this severe pain and stiffness. But the moment they're mobilizing, it gets better. Right. So non-inflammatory symptoms, usually this, let's say patient has osteoarthritis, they will have non-inflammatory symptoms like morning stiffness less than 30 minutes. So for them, it's the opposite. So the more activity they have, the more pain they have. Okay, of which inflammatory symptoms, once they do activity, it gets better. But non-inflammatory symptoms, when they do activity, it actually gets more painful. So you also want to assess for pain with range of motion, localized joint pain, or always check the joint below and the joint above, so where they're complaining of pain. Okay, check for erythema, warmness, swelling, inability to bear weight, any fever. So fever may actually indicate any septic joint. Then investigation, you want to do a blood workup, you want to do a CBC, your ESR, CRP, INR, PTT, blood culture, and urate. Drain X-ray, okay. You can do plus or minus contralateral drains just to compare, and then bedside ultrasound just to checking for joint effusion. If you see a joint effusion, you want to aspirate it, okay, send it to the lab. So basically, test the joint aspirate. So if you manage to see a joint effusion, aspirate it, and you test it for what? Number one, culture, white blood cell count, polynuclear cells, glucose, Gram-Stan, and crystal. Okay. How do you manage this? Septic joint, you're going to give them empiric IV antibiotics. Okay, plus or minus orthopedic consultation for joint decompression and drainage. For patient with crystalline synovitis, okay, how are you going to manage that? You're going to give them high doses of NSAID, colchicine within the first 24 hours, corticosteroid, and do not use haloperidol in an acute flares. So, excuse me. So crystalline synovitis, you're also expecting what? Gout, right? So you're gonna what is the management of acute gout? It's your high NSAID and colchicine, right? And not haloperidol. Okay. So it's once the acute phase has subsided, that's when you start with haloperidol. So if it's an acute polyarthritis, involving multiple joints, you're gonna give him NSAID, analgesia. So local or systemic corticosteroid can be used. Patient osteoarthritis, what are you gonna give them? NSAID, acetaminophen. Soft tissue pain. If it's only soft tissue pain, maybe they were involved in a trauma. Now presenting with soft tissue pain, you start with non-pharmacological management, such as ice. So basically, you local heat or cold, electrical stimulation, massage, and add oral analgesia and SAID, muscle relaxant, corticosteroid injections, and topical agents. Right. Next, back pain. So what are the red flags for back pain? Patient has back pain and they are more than 50-year-old. What do you want to do? You want to further assess it, right? Right. If they have back pain and then they have bowel or bladder dysfunction, red flag. If they have anesthesia, so usually within the inner thigh, they have numbness within the inner thigh. What is that? Red flag. They have constitutional symptoms, fever, loss of weight, what's this? Coughing, night sweats, red flag. If they're chronic disease, if it's chronic, if it's a constant pain, check that out. Okay. If they're paresthesia, they're feeling numbness, check it out. If they're more than 50-year-old, if they're IV drug user, now they're presenting a chest back pain, check that it's not infection, right? If they have neuromotor deficit, red flag. Okay. So use the clinical organized relevant exams back tool to screen for common mechanical back pain syndrome and then rule out extra spinal emergency. So remember, a patient can present with back pain while they actually have aortic dissection, while they actually have abdominal aortic aneurysm, while they actually have a pulmonary embolism, while they actually have an MI but present with back pain. They could also have retroperitoneal bleed but have a back pain. Or pancreatitis. They can also have back pain, okay? So rule out extra spinal emergency. So those are the extra spinal emergency: your aortic dissection, your AAA, your PE, your MI, your retroperitoneal bleed, your pancreatitis. Then also rule out spinal emergencies. What are your spinal emergency? So it could be that the back pain is due to osteomyelitis. It could be that the back pain is due to a Cauda equina syndrome. In that sense, you're going to have blood involvement, paresthesia. It could be that the back pain is due to an epidural abscess or hematoma, especially if a patient that had an anesthesia at the back. So it could be due to epidural hematoma or an abscess. It could be due to discitis, the inflammation of the disc. It could be due to a spinal fracture, or it could be due to malignancy. So those are the spinal emergency of back pain. Okay, so try and rule that out. History and physical exams. So evaluate risk for fracture, especially they're having osteoporosis, the advanced age, any trauma. Okay, check for infection, especially if they're IV drug user. Have they had any recent spinal intervention? Then you're thinking it would be epidural abscess or hematoma. IV drug user, you could think about osteomyelitis. Are they immunocompromised? That as well. So they're very susceptible to infection as well and malignancy. So you want to check any history of cancer. Maybe it has now, the patient may have prostate cancer now and they're spread to the back. Any vascular causes, any cardiac risk factors, neurologic symptoms, and then having any subtle anesthesia. You want to check that in the history. So a typical musculoskeletal back pain is moderate, okay? Worse with movement or cough with no visceral symptom. All right. So a patient presenting, say, with back pain. So a typical back pain, when you know that there's nothing that could be involved, it's usually moderate, right? And then usually worse with movement or if they cough. And usually there's no visceral symptoms involved. Okay? That's a typical normal back pain. So assess vital sign, perform pericardial, abdominal, neurological exams of the lower extremities. Then investigation, you can do an ultrasound, you can do a post-void residual bladder scan. You can do a reverse image for neurological deficit, checking for metastasis, and patient with high risk of fracture, check for infection, for cancer, vascular causes, consider CT scan if trauma or there are fracture risk. You can do an urgent MRI if neurological findings are found, like saddle, paresthesia, or saddle anesthesia. Okay, so management, treat the underlying cause and your lumbosacral strain and disc herniation. So if a patient has disc herniation, how are you going to treat them? So if they had a disc herniation, it's going to be an analgesia and continue daily activity. You do not tell them, oh, sit down and rest. So if it's just a lumbosacral strain, let's say a strain from maybe they were clearing ice snow from the passage, and you're using a shovel, and now they're having pain. So how are you going to manage that? You're going to tell them analgesia, and then they need to continue daily activities. Okay? There's no rest. This herniation, same thing. Analgesia, continue daily activity as much as tolerated. Okay? And then discuss to the patient any red flags, and then so that they can come back, and then organize follow-up. So what if it's a spinal infection? If maybe, like, let's say in a patient with an IV drug user, so you're going to do an early IV antibiotics and infection disease. You can also do a spine surgery consultation. What if it's a Cauda equina syndrome? Remember, Cauda equina syndrome is an emergency. So what are you going to do? You're going to give them a dexamethasone and have an early spine surgery consultation. Okay, dexamethasone. Then consult spine surgery immediately. Alright, so next we're going to talk about seizures. So what a seizure is paroxysmal alteration of behavior and or EEG changing resulting from abnormal excessive activity of the neurons. Okay. So patient can present to the ED with a history of status epilepticus. So it is a continuous or intermittent seizure activity for greater than 5 minutes without retaining to consciousness. So it's either they have a continuous seizure for more than 5 minutes, or they have 1, 2, 3 seizures, but then they're not returning to baseline. Okay, so if they have seizure now for lasting for 1 minute, but then they're not regaining consciousness, they're having another seizure. So that is status epilepticus. So remember, it's an emergency management. So under categories, you can have generalized seizures, partial seizures. So generalized seizure usually consciousness. The consciousness is always lost. Okay, level of consciousness is usually lost in a generalized seizure. Usually present with your tonic-clonic, or it could be absence or myoclonic or atonic. Partial seizure usually focal, usually affecting one part of the body, and usually can be simple partial or complex partial. Okay, then causes could be primary seizure disorder. The causes could be due to structural, such as trauma, intracranial hemorrhage. Could be due to infection, increased intracranial pressure. It could be metabolic disturbance, such as hyperglycemia, or hyponatremia, or hypocalcemia, or hypomagnesemia, or toxin or drugs. So that could be the cause. So it could be that the patient just has a primary seizure disorder, or it could be that there are structural causes, metabolic causes. Okay. Differential diagnosis. So it could be syncope, stroke, TIA, psychogenic non-epileptic seizure, migraines, movement disorder, narcotics, narcolepsy, cataplexy. So under history, patient presenting with seizure, you want to do a history and physical examination. You want to know any history of seizures. Are they known to have seizure before? Identify any potential precipitant. Were they having any infections? Any fever prior? You want to know, was it alcohol? Are they alcoholic? And now presenting with alcohol withdrawal symptoms. Have they been having sleep deprivation? That can also cause seizures. So preceding aura. So you want to know, before the seizure started, was there any aura? So you want to know, was it rapid onset? Was it the brief duration of the seizure? Was there any alteration in the level of consciousness? Was there any tonic-clonic movement? Was there any post-ictal symptoms? All right. So those suggest a seizure. But then for patients who have syncope, usually don't have post-ictal symptoms. So post-ictal symptoms like foaming of the mouth or biting of the tongue, then you will suspect seizures. So common signs include tongue biting. This is a high specificity. That is a seizure. Usually they have loss in bladder or bowel control. They have vomiting or aspiration. Okay, those are the common signs. Okay, usually post seizure. So you want to perform your vital signs and then complete neurological examination, and then look for injuries of the head, have there any, and then the spine, and then the shoulders. And then what is seizure associated with? Associated with a posterior dislocation, like let's say a posterior dislocation of the humerus. Okay, of the shoulder. Sorry. So what is going to be a minimal workup for a patient that present with a first-time seizure? Patient present first-time seizure, you want to do your CBC and differentials. You want to check for electrolyte. Could it be due to metabolic causes? That's the first thing you want to rule out. Okay. So obviously checking your calcium, magnesium, phosphate, your sodium, your glucose, very, very important, glucose level. Okay, so say if administering phenytoin, patient must be, if you're going to give the patient phenytoin, make sure that the patient is on cardiac monitors because phenytoin has a risk of causing dysarrhythmias and or hypotension. Okay, so if IV access is not feasible, you can't actually put in an IV line. What can you give them? In an AccuPhase, you're going to give them midazolam 0.2 milligrams per kg IM, and up to 10 milligrams can be used for the initial control of seizure in adult. Okay, so initial management, you can't actually get an IV line to give them lorazepam. You can actually give them midazolam from 0.2 milligrams per kg with a maximum of 10 milligrams. So next, we're going to talk about concurrent investigation and management of status epilepticus. Remember, we already spoke about the definition. So what are you going to do immediately as the patient comes? You're going to protect the airway with positioning. So you want to put them on the left lateral side, right? Intubate if the airway is compromised. Obviously, you want to do your ABC. Is there airway compromise? Yes, then you continue to intubate. Is there increased level of increased intracranial pressure? Then you also want to intubate. Then you want to put on your monitors, your vital signs, check your capillary glucose, put your oximetry, do your ECG, put an IV line quickly. Then you can start them with benzodiazepine. Mostly your lorazepam 2 milligram IV at 2 milligrams per minute up to 10 milligrams. Or if you cannot get an IV access, then you can give them midazolam. Okay, and repeat it at 10 minutes if ineffective. Okay, so you can also give it intranasal if there's no IV or IO access. Then you're going to give them fluid through the IV lines if you manage to put on the IV line. You're going to give them IV dextrose if glucose of 33 millimole per liter. You want to give them 50% dextrose, 50 moles or 50% dextrose, and preceded by thiamine, 100 milligrams IM, if concerned about alcohol withdrawal. And then obtain your CBC electrolyte, calcium levels, your magnesium, do your VBG, check your serum blood glucose, your toxin, check and if they are on anti-epileptic drugs, you want to check them to the drug levels and do your beta ECG. Then vasopressin support. So if you have given fluids and then you are not able to maintain the blood pressure, you can give them your vasopressors. Okay, but that is after aggressive fluid resuscitation. Okay, so remember, let's repeat that. You have a patient presenting with status epilepticus. First, protect the airway, right? So protect the airway with positioning. You might need to intubate the patient. Put on your monitors. Get an IV access. Start lorazepam 2 milligrams IV. If you can't, then you start with midazolam of 0.2 milligrams per kg IM. Give them fluid resuscitation. Okay, and then give them dextrose if the glucose is low, and then followed by if you actually need to give them thiamine, you first give them thiamine before you give glucose. So thiamine first, 100 milligrams IM if you're actually concerned about any alcohol withdrawal or if they are malnourished. Then you obtain your blood, your toxin and everything. Continue fluid resuscitation. If you're still not getting your systolic blood pressure above 90 or the MEP above 70, then you can start with your vasopressors. Okay. That's the first step you do. Second step, once you see the patient is now stabilized you a little bit, then you can put a second IV line on. And then if the status epilepticus, if they continue having seizures, you're going to give them phenytoin 20 milligrams per kg IV. And then if the seizure resolves, anti-epileptic drugs still required to prevent recurrence. So you're going to give them anti-epileptic drugs even if the seizure has resolved because you do not want them to get another seizure. So what are you going to give them at that? So if they continuously have seizure, you give them phenytoin 20 milligrams per kg IV. Okay? At about 25 to 50 milligrams per minute in adult. Okay? So if the seizure resolves, then you still need to give them anti-epileptic drugs to prevent recurrence. So you're going to give them what? Levetiracetam, loading dose of 60 milligrams per kg IV in adults, maximum of 1.4 grams, and then infuse it over 5 to 15 minutes. Then you will send the patient for an EEG or monitoring. Okay, so that is what you do as your second step. So let's say for any reason now, this seizure does not get better. So the seizure does not get better. So it's still continuous. So there we're looking at refractory seizure. So if the status persists after maximum doses of all the above, you've given them everything up to maximum doses, then you need to consult ICU and start one or more of the following. You can start them with phenobarbital 20 milligrams per kg IV at 50 milligrams per minute. You can start them with midazolam 0.2 milligrams per kg IV loading dose at 0.1 to 0.4 milligrams per kg per hour, or propofol 2 milligrams per kg IV at 2.2 to 5 milligrams per kg per hour. And then require definitive airway management. They usually require definitive airway management, including rapid sequence induction and assisted ventilation, and then electroencephalogram. So you're going to do an EEG for continuous monitoring. Then post seizure, you want to investigate the cause. Obviously, you're going to try and rule out your metabolic cause, any structural cause, CT scan, any LP. So depending on how the patient's symptoms are. So decision to admit or discharge should be based on the underlying disease. Okay. So if a patient had a brief generalized seizure and has returned to baseline function and is neurologically intact, then consider discharge with outpatient follow-up. So first time seizure patient being discharged should be referred to a neurologist for follow-up. Admitted patients should generally have neurology consult. Patients should not drive until medically cleared. So you need to so depending on the local regulations. So complete notification form to the appropriate authority regarding the ability to drive based on the local legal requirements. And then warn the patient regarding other safety concerns, like you're going to tell them no swimming, no bathing of children alone. All right, so next we're going to talk about shortness of breath. Okay, so differential diagnosis of dyspnea could be due to respiratory causes, cardiac causes, metabolic causes, neuromuscular causes. So respiratory causes, airway obstruction, could be foreign body, could be pneumothorax, hemothorax, gas exchange, pulmonary edema. So many causes. In all cases, you want to take your history and do a physical examination. And then rule out other associated symptoms with the shortness of breath. You want to know, are they having any chest pain? Is there any fever or cough? Sputum? Or is there urticaria? Is there anaphylaxis? Is there a wheeze with acute bronchospasm? And is it due to environmental causes or occupational exposure? So try and find out the other cause. And then dyspnea may be the sole complaint, and physical examination may reveal few abnormalities. So usually in patients with pneumothorax or pulmonary embolism, they might not have other symptoms. They might just have dyspnea. Okay. So you want to do your vital signs. You're checking for wheezes or any stridor. So wheeze and stridor are ventilatory symptoms. Crackles are parenchymal symptoms. All right. Check for murmurs. Investigation you want to do depending on what you're suspecting. Chest X-ray, your CVC, exclude anemia. Consider your ABG, VBG, Wells score criteria to exclude your PE, chest X-ray, CT scan of the chest. So just depending on the causes. Okay. So here it says that history and physical examination lead to accurate diagnosis in patient with dyspnea in appropriately 2/3 of cases. Okay, so make sure you do your proper physical examination and take your history properly. The decision to admit or discharge should be based on the underlying disease process, and patient with non-invasive positive pressure ventilation should be considered in patient with severe COPD or congestive heart failure. So it may reduce the need for intubation in this patient population. Okay, so what is your non-invasive? So those are usually your CPAP. So you can actually use that in COPD or patients with congestive heart failure. Considering intubation in COPD and congestive heart failure, if your non-invasive positive pressure ventilation will not be tolerated. So if they still have decreased level of consciousness, obviously they cannot tolerate it. If they have vomiting, then obviously the risk of aspiration. So you want to actually insert a definitive airway. So next we're going to talk about syncope. What is syncope? So it's a sudden transient loss of consciousness and postural tone with spontaneous recovery. So usually spontaneous recovery, and usually caused by generalized cerebral or reticular activating system hypoperfusion. So usually it's due to a cerebral or your brainstem hypoperfusion. Okay. So the causes, it could be syncope has two causes. So it could be due to cardiogenic cause or non-cardiogenic cause. And the cardiogenic causes are the most common causes. Okay. So it could be that the patient has a dysarrhythmia. There could be that they have an outflow obstruction. They could have an either a valvular disease and now presenting with syncope. Or the non-cardiogenic cause could be peripheral vascular, such as hypovolemia, such as vasovagal, um, orthostatics, cerebrovascular disorder, central nervous system, metabolic disturbance like ethanol, alcohol intoxication. So history, we want to get the details from witness to and clarify the patient experience. So you want to know, is it just dizziness? Is it ataxia, or is it really a true syncope? Okay. So the two key historical features is prodrome and situation. So you want to know how was the setting? Because if, for example, if the patient was they were in a queue and all of a sudden they fainted, okay? And how was the patient posture? So that is important. So in a history, you want to make sure you know that what was the setting that the patient was? Was he like in the field playing? And then what was the patient posture? Okay, because obviously, so that's important. So distinguish between syncope and seizure. So some patient may have myoclonic jerks with syncope, and that is actually not a seizure. Okay, so signs and symptom during pre-syncope. What were the symptoms pre-syncope, or during syncope, or post-syncope? You want to know that because remember, with seizure, you're going to have your post-ictal period afterwards, of which syncope you do not have post-ictal. So you want to make sure before the syncope started, how is the patient's symptoms and sign? During syncope, how were they? After syncope, how were they? Okay. Then you want to know past medical history, drugs. Are they using any drugs? Think they say think anatomically in differential. So think about pump, your heart, blood vessels involvement, the brain. Okay. So when a patient presents with syncope, how are you going to think about the causes? First, the heart. Are we having any heart conditions? Could it be due to cardiogenic causes? Then blood. Is it that this patient is maybe hypovolemic? They have decreased. The blood levels are decreased. They are maybe anemic. They're hypovolemic. They may be DKA. They have lost so much blood or so much fluid. Then you think about vessels. Vessels. Is there maybe a PE? Is there any clots? Maybe because your parasympathetic nervous system was highly activated. If your high activation in your parasympathetic, meaning your vagal nerve, all right, patient can present with that. Okay, so you're gonna have vasodilation. Okay, so and then you think about brain. Is it due to cerebral hypoperfusion, brainstem hypoperfusion? Am I dealing with a space of occupying lesion? So basically like that. All right. So remember, syncope is cardiogenic. It's cardiogenic until proven otherwise. The first causes you're looking in a patient that had a syncope is it's cardiac causes. Okay. So with cardiogenic causes of syncope, there is a sudden loss of consciousness with no warning or prodrome. So they don't have any warning sign, and they just fall off to the ground. Loss of level of consciousness is sudden. And then syncope is accompanied by chest pain. The moment the patient says, I had chest pain, think about cardiogenic causes. So cardiogenic causes are the first things you're looking at in a patient who has syncope. All right. They usually present a sudden loss of consciousness. There's no warning sign prior to the syncope. Then the syncope is also associated with chest pain. Physical exam, want to do your postural BP, heart rate, your cardiac, respiratory, neurological exams, examine for signs of secondary injury caused by the syncopal episode, like check for head injury if maybe due to the fall they had a head injury involved. Investigation, remember you first want to rule out any cardiogenic cause, so what are you going to do? ECG. ECG. You could see tachycardia, bradycardia. You could see conduction block. Could be a Wolf Parkinson White. Could be a long QT interval. Could be a Brugada syndrome. Could be a right ventricular strain. Could be hypertrophic cardiomyopathy. Then next, excuse me. Obviously, you're gonna put on your monitors. You're gonna check for your capillary blood glucose all the time. Blood workup. You want to do your CBC electrolyte, troponin, cardiac markers. Check for metabolic causes like calcium, magnesium, D-dimers, beta ECG, and consider toxicology screen as well. So ABGs, how would you manage them? Always check your airway, breathing, and circulation in every emergency case. IV, you would do your IV. Put on your IV. Excuse me. I'm gonna put on your IV. IV line, put oxygen, put all your monitors. So for cardiogenic syncope, you need to admit to medicine or cardiology. Low risk syncope, you can actually discharge with follow up as indicated. If okay, then remember. So on discharge, instruct the patient to follow up with family physician. Educate about avoiding orthostatic or situational syncope. Okay, situational syncope. Evaluate the patient for fitness to drive or work, and patient with recurrent syncope should avoid high risk activity like driving. Okay, next.
So next we're going to talk about sexual assault. So patient presenting with sexual assault are usually women. So 1 in 5 women and 1 in 50 men will be sexually assaulted in their lifetime, and only 7% are reported. So what is the general approach? You want to do your ABC. So treat acute serious injuries. Physician priority is to treat medical issues and provide clearance. So ensure the patient is not left alone and provide ongoing emotional support. Obtain consent for examination and treatment and collection of evidence, and disclose to police. So notify police as soon as consent is obtained. So remember, if the patient is more than 16 years old, they need to give you consent to actually report to the police. Ideally, the examination should be done by experienced provider, generally a sexual assault nurse examiner. So administer sexual assault kit. So if a patient has been assaulted in less than 72 hours, then you can use the sexual assault kit to collect evidence. So make sure you label the samples immediately and pass directly to the police, and offer community crisis resources like shelter hotlines. So you do not report unless the victim is lesser than 16 years old. If they're lesser than 16 years old, you are legally required to report the sexual assault. So history, ensure privacy for the patient. You may ask other people to leave the room, and the question that you ask the patient is who did it, when did it happen, where did the penetration occur, what happened, any weapons or physical assault that was done. Then post-assault activities, you want to ask them, have they already urinated, defecated, have they changed any clothes, and done any shower or douches. So you want to do your gynecological history as well, asking for gravidity, parity, last menstruation period. You want to ask on any contraceptive, what is the last voluntary intercourse that they had, because sperm motile 6 to 12 hours in the vagina, 5 days in the cervix. So basically, once the person has sexual intercourse, the sperms can stay in the vagina for 6 to 12 hours and can stay up to 5 days in the cervix. So you want to know their last voluntary intercourse. You want to know their medical history, any acute injury or illness, are they on any chronic disease, psychiatry history, medications, allergies. So all of that will be in your history. Then you move to physical exams. So never re-traumatize a patient with the examination. So intimate exams and specimen collection should ideally be referred to a sexual assault nurse if there is one available. Okay. So you want to do a general examination, mental status. You want to know sexual maturity of the patient. What are the sexual maturity? Patient should remove clothes and place it in a paper bag. You want to document any abrasion. Is there any bruises, laceration? Is there any torn frenulum or broken teeth? which may indicate oral penetration. Then you want to do a pelvic exams and specimen collection. Ideally, you want to do this before urination or defecation. Examine for seminal stains. Check the hymen and then check for signs of trauma. Collect moisture swabs of dry seminal stains. Pubic hair dry, you can comb it, you can cut pubic hair. And in speculum exams, remember to lubricate the speculum with only water. Checking for vaginal laceration in foreign body. Then same time you can do a pap smear, and you can take culture for gonorrhea and chlamydia. Then check the posterior fornix for fornix secretion if present, or aspirate of saline irrigation. So you irrigate with normal saline and then you aspirate it. So immediate wet smear for motile sperm, and then air dry slides for motile sperms. It can be an acid phosphatase ABO group. You can scrape the fingernails and take saliva sample from the victims. So investigation, what are you gonna do? You're gonna test for syphilis using your venereal disease research lab, which is VDRL, and you repeat the syphilis test in 3 months. If it's negative, you want to do your serum beta HCG and test your blood group, do your RH type, do baseline serology, hepatitis, HIV. And how would you manage this patient? So involve local or regional sexual assault team, sexual assault forensic examiner or sexual assault nurse examiner. So medical management, you will suture laceration, give tetanus prophylaxis, gynecology consult for foreign body if there's any foreign body or complex lacerations. Assume positive. Always assume that the patient is positive for gonorrhea and chlamydia, so you want to give them prophylactic antibiotics by giving them ceftriaxone 1 gram. 1 gram if they're more than 150 kg, and 500 milligrams if they're less than 150 kg IM. Then doxycycline 100 milligrams per os BD for 7 days. Alternative, you can give them azithromycin 1 gram per os as a single dose. Alright, so you may start them on post-exposure prophylaxis for hepatitis B, for syphilis and HIV, and then pre and post counseling for HIV testing. Pregnancy prophylaxis should be offered. So you want to give them levonorgestrel 1.5 gram per ostat is a plan B to prevent pregnancy. And psychological, so they usually have high incidence of psychological sequelae, so have victim change and shower after you've completed the examination. So remember, follow up with physician in a rape crisis center within 24 hours for a repeat pregnancy and STI testing. Okay. Next, we're going to talk about intimate partner violence. So women are usually the victims, but male victimization also occurs. Identify the problem. Usually needs a high index of suspicion. Suggestive injury that could show intimate partner violence is usually bruising, strains, abrasions, occasionally fractures, burns, and other injuries often inconsistent with the history provided. So somatic symptoms, look for chronic, and they usually present with chronic vague complaints. They usually have psychosocial symptoms. So clinical impression, your gut feeling. So e.g. overbearing partner that won't leave the patient's side. So if you have an overbearing partner, they won't leave the patient's side, you need to suspect intimate partner violence. So if disclosed, be supportive and assess danger. Patient must consent to follow-up investigation or reporting. So if they're more than 16 years old, they have to consent. If they're less than 16, you have to report it for them. Management, treat injuries, document the findings, ask about sexual assault and children at home, encourage notification of the police, and safety plan with a good follow-up with family physician or social worker. So usually high index of suspicions. So next we're going to talk about medical emergencies. The first one being anaphylaxis and allergic reaction. Alright, so what are the most triggers of anaphylaxis? Is food, for like nuts, shellfish. It could be bee stings, drugs like penicillin, NSAID as ACE inhibitors. It could be radiographic contrast media. It could be blood products, could be latex. Okay. So what are the etiology? Remember, anaphylaxis is an exaggerated immune-mediated hypersensitivity reaction that leads to systemic histamine. So you have it's a type 1 hypersensitivity reaction, and it leads to the release of systemic histamines and vasoactive mediators. So leading to an increased vascular permeability and vasodilation. Right. So because you have these increased histamines and these vasoactive mediators, this will lead to vascular permeability, meaning more plasma cells enter, and then it will lead to vasodilation. So obviously, vasodilation will lead to what? To hypotension. So regardless of the etiology, the presentation and management of anaphylactic reaction are the same. So what's the first thing you're going to give in a patient that present with anaphylactic reaction? Epinephrine, which is 1 is to 1000, 0.3 to 0.5 milligrams IM in the anterolateral thigh. Okay. So it could be allergic, where the patient is having a re-exposure to an allergen. It could be non-allergic, such as exercise injuries. Okay, so diagnostic criteria. Diagnosis of anaphylaxis is highly likely with any of the following. So number 1, if there is an acute onset of illness, minute to hour, with involvement of the skin, mucosal tissue, and at least one or of the following, like respiratory compromise. So basically, anaphylactic reaction means that 2 systems need to be involved. So either the skin and the respiratory system, or the skin maybe with GI symptoms, or skin with cardiovascular symptoms. So 2 systems need to be involved. So how would you manage an anaphylactic reaction? Number 1, so moderate reaction. If a patient has moderate symptoms, such as generalized urticaria, angioedema, wheezing, tachycardia, then you're going to start by giving them epinephrine, 0.3 to 0.5 milligrams IM in the anterolateral thigh. You can also give them antihistamines such as cetirizine, 10 milligrams per also IV, and salbutamol, 1 cc via MDI. If a severe reaction where the patient has severe wheezing, they have laryngeal or pulmonary edema, they're in shock, then you want to start your ABC, and you might need to put in a definitive airway, like then an ET tube and a tracheal tube due to airway edema. Then you're going to immediately give epinephrine. You can also give epinephrine via the ET tube, okay, and titrate to the desired effect. Then you move to giving antihistamine, something a bit stronger, like diphenhydramide, 50 milligrams IV, or cetirizine, 10 milligrams IV. Then you add glucocorticoids. So you're going to give them an IV dose of methylprednisolone, 125 to 250 milligrams, or prednisolone 40 to 60 milligrams per ounce if they can actually swallow. Then remember to give them large volumes of crystalloid. Then try and remove any triggers. Search for any insect stink, and then decompress GI tract if possible. Alright, so ABC, epinephrine, antihistamines, glucocorticoids, can add salbutamol, give crystalloid fluids, and try and check to remove any triggers. So patients that are actually taking beta blockers might not respond to epinephrine, okay, in an anaphylactic reaction. So you might need to first give them glucagon to reverse the beta blockers before now giving them epinephrine. So epinephrine is a life-saving, and there are no absolute contraindication to that epinephrine administration. So all patients should be kept under observation until symptoms fully resolve, especially if severe. Okay. So when you are discharging this patient, you want to make sure they have an epinephrine auto-injection. You discharge an H1 and H1 antagonist such as cetirizine, 10 milligrams per ounce daily. So you can also use second generation are actually better because they're less sedative compared to first generation, and glucocorticoid are not recommended. So what are the pediatric dose of epinephrine? For adults, remember it's 0.3 to 0.5. Alright? Milligrams, right? And then for children, it's 0.01 milligram per kg IM up to 0.5 milligrams. Alright? Crystalloid bolus. The initial crystalloid bolus, how are you going to calculate? It's going to calculate by 20 to 30 moles per kg. Then you reassess. Children usually maybe like 10 moles per kg. Okay. Next, we're going to talk about asthma. So be aware of a silent chest in asthma exacerbation. So this is a medical emergency and require aggressive treatment. Intubation of patients with severe asthma is extremely high risk. and maximum medical therapy should be used to avoid it as soon as possible, as much as possible. Okay, so what is asthma? It's a chronic inflammatory airway disease with episode of bronchospasm and inflammation resulting in reversible airflow obstruction. So asthma causes reversible airflow obstruction. COPD causes irreversible airway obstruction. So history and physical exams, obviously you want to try and find what are the causes of the asthma exacerbation. So a patient presenting asthma exacerbation, they usually will have a history of a prior asthma, or known asthmatic, and now maybe they had a viral infection, or they were exercising, or any environmental triggers, and now they're presenting with asthma exacerbation. So history of asthma control, severity of exacerbation. You want to know any previous exacerbation they had, signs of respiratory distress. Are they using accessory muscle to breathe or abdominal muscles to breathe? Vital signs. You want to know the oxygen saturation. Alright, so investigation. You want to do a peak flow meter. You want to do an ABG if in severe respiratory distress. Chest x-ray if diagnosis is uncertain to rule out pneumonia or pneumothorax. Okay. So asthma assessment and management. So remember, the management is depending on how the patient presents. So patient can present with respiratory arrest, which is an imminent emergency, or patient can present with severe asthma or moderate asthma or mild asthma. So for respiratory arrest, which is an imminent or emergency situation, patient usually has a history of exhausted, confused, sweating, cyanotic. They have a silent chest, ineffective respiratory effort. They have decreased heart rate. They have respiratory rate more than 30. They have carbon dioxide more than 45. Saturation is below 90 despite supplementary oxygen. So what are you going to do? A, B, C, right? First, make sure airway is secure. You might need to intubate this patient. So always anticipate the need for intubation. Then carry out, then you want to give them 100% oxygen. Put on your cardiac monitors, your IV access. Then you might need to consider intubation. And if you want to intubate, consider using ketamine. Okay? So remember, it's A, B, C. Airway done, breathing done, circulation done. Now what are you doing? You're giving short-acting beta blockers. Sorry, not beta blockers. Short-acting beta agonists. Salbutamol. You can give it as a nebulizer, 5 milligrams continuously. You also give short-acting anticholinergic, ipratropium. Nebulize a dose of 0.5 milligrams times 3 doses. Then you give them IV corticosteroid, methylprednisone 125 milligrams. Salbutamol can also be given IV 1 to 2 milligrams per kg IV. Epinephrine can also be helpful, especially if associated with hypotension. So first of all, you do your ABC. Airway, you give them oxygen. Circulation, you might need to intubate. You might need to circulation, put IV lines and everything. Once you're done with ABC, then you move to short-acting beta blockers, then short-acting beta agonists, then short-acting anticholinergics. Then you give steroid, then you can give epinephrine. Then you can also give magnesium sulfate. If the presenter with severe asthma, usually they are agitated, diaphoresis, they have labor respiration, they are speaking in words. There's no relief with beta agonist. Saturation is below 90. Okay? So remember, respiratory arrest, the chest is silent. They're not speaking anything. Severe asthma, they're only speaking words. Moderate asthma, they're speaking phrases. Mild asthma, they're actually communicating, but have difficulty finishing sentences. So for severe asthma, how are you going to manage it? Magnesium sulfate 2 grams IV, right? You give it slowly. You give them oxygen because you want to try and increase your saturation. You give them short-acting beta agonist. You give them short-acting anticholinergics such as apratropium, and then IV steroids. Okay. Moderate asthma, you present usually with shortness of breath and rest, cough, congestion, chest tightness, speaking in phrases, inadequate relief with beta agonist. So what are you going to do? Give them oxygen to try and maintain the saturation above 92%, then short-acting beta agonist, then short-acting anticholinergics, then IV steroids, then yes. Okay. So what are the elements that shows that the patient asthma is well controlled? So number 1, the daytime symptoms are lesser than 4 times per week. Nighttime symptoms are lesser than once per week. No limitation to activity. No absence from work or school. And then they use their rescue inhaler, your salbutamol. They use it lesser than 4 times per week. Okay. So the risk factors are factor for recurrence. So frequent. What are the risk factors for recurrence of an asthma exacerbation? Is frequent ED exam visit. Sorry, frequent hospitalization, recent steroid use, recent exacerbation, poor medication compliance, prolonged use of high doses of beta agonist. So beta agonist MDI with a aero chamber, 2 to 4 puff, 2 to 4 hourly until symptoms control. Then they start using it as per needed. Initiate inhale corticosteroid with an aero chamber if not already prescribed. If moderate to severe attack, administer prednisone 30 to 60 milligrams per day for 5 to 10 days with no taper, and counsel on medication adherence and educate on the use of the aero chamber, and then follow up with primary care physician or asthma specialist. Okay. So once you're discharging the patient, you have to make sure what you give them inhale corticosteroids. If they have severe cases, you want to give them, you can give them steroids, oral steroids for 5 to 10 days. Then you're going to give them what? Beta agonist as well. So next we're going to talk about cardiac dysarrhythmias. So we're looking at Brandy dysarrhythmias and AV conduction block. So what are the AV conduction blocks? So it's meaning atrioventricular conduction blocks. Your first degree, second degree, third degree block. So first degree usually present with prolonged PR intervals. Okay, more than 200 milliseconds. Usually no treatment is required. It's just can just need to be monitored. Okay. Second degree, you have Mobitz 1, which is a gradual prolongation of PR interval. Then there's a drop of the QRS complex, but it's also usually benign. Then you have Mobitz 2, where you have PR interval is constant. So PR interval is constant with a drop of the QRS complex. Can progress to a third degree AV block. Okay. And then in third degree you have a P wave that is unrelated to the QRS complex, and P to P and R to R intervals remain constant. So how would you treat a third degree? You give them atropine and transcutaneous or transvenous spacing. Okay, so with atropine, give it with caution, because atropine can actually precipitate a third degree heart block in a patient who has Mobitz type 2. So basically, what are we saying? We're giving atropine because usually they are bradycardia, and we want to do a transcutaneous or transvenous spacing. If transcutaneous or transvenous spacing fails, then consider your IV dopamine or epinephrine. Okay, dopamine or epinephrine. Alright. So in long term, what is the long term treatment for Mobitz 2 and third degree block? Is your internal pacemaker. Okay, so they need a pacemaker. Acute management, atropine, subcutaneous or transvenous spacing. If transcutaneous or transvenous spacing does not work, IV dopamine or epinephrine. So what about sinus bradycardia? Sinus bradycardia usually means the heart rate is lesser than 60 beats per minute, and can actually be found, and it can actually be normal in patients like athletics. So what could be the causes of a sinus bradycardia? It can be vagal stimulation. So if the vagal nerve is hyperstimulated, if there's vomiting, if there's an MI or ischemia, if there's increase in intracranial pressure, if there's sinus node dysfunction, hypothyroidism, drugs like beta blockers, patient is using beta blockers or calcium channel blockers, then they can present with sinus bradycardia. So look for an upright P wave in lead 2 and or a biphasic in lead V1 to confirm a sinus P wave origin. And look for symptomatic. So is the patient symptomatic? Are they having hypotension, chest pain? If they are symptomatic, acute treatment will be atropine to increase the heart rate, or plus or minus transcutaneous or transvenous spacing. You also have something called sick sinus. You will give them transcutaneous or transvenous spacing. So AV block can cause bradyarrhythmias as well. If it's drug-induced, to discontinue, reduce the offending drugs, example beta blockers or calcium channel blockers. Consider an antidote pacing often is ineffective. Use IV epinephrine to increase your chronometry. So next we're going to talk about supraventricular tachydysrhythmia. So what is supraventricular tachycardia? So usually it's a sinus tachycardia more than 100 beats per minute. Causes are usually increase in sympathetic tone, drugs, fever, tone, anemia, thyrotoxicosis, MIPE, emotional pain. So search for the cause and then treat the cause. Okay. So regular rhythm, usually not sinus tachycardia. So usually you can do a vagal maneuvers like thoracic massage, Valsalva maneuver. You can do a continuous 12 lead ECG, which is usually helpful during maneuvers or cardioversion if first episode will help with illicit underlying etiology. So patient presenting supraventricular tachycardia, what are you going to do? You're going to give them adenosine. 6 milligrams IV push. If no conversion, if there's still no conversion, then you give 12. So the first dose is 6 milligrams, second dose 12 milligrams, and can repeat 12 milligram doses once. And warn the patient regarding the side effects, because they may have adenosine can cause chest pains and nausea. So down the ECG here, you will see that's a ventricular tachycardia. So you can also use electrical cardioversion if your vagal maneuvers and your adenosine is unsuccessful. So a patient presents with supraventricular tachycardia. What's the first thing you want to do? You want to do your vagal maneuvers. You want to do your thoracic massage, your Valsalva maneuver, right? Continuously have a 12 lead ECG. And still this does not help. Try and look for the cause and treat the cause. Still does not help. You start with adenosine 6 milligrams. Still is not converted. Then you move to 12 milligrams. And you can repeat 12 milligram dose once. And then if adenosine is not working, then you move to electrical cardioversion. Okay. So what are the rhythm converts? Rhythm converts probable re-entrant tachycardia. They can so rhythm does not convert. Usually your atrial flutter, ectopic atrial tachycardia, junction tachycardia. Okay. In this case, you do your rate control. So rate control or rhythm control. So rate control, you can do that with beta blockers or calcium channel blockers, and rhythm control, you do it with cardioversion. So next we're going to talk about atrial fibrillation. So most common sustained dysrhythmias, there is no organized B wave. Okay, there is no organized B wave. So the atrial rate usually more than 30 per minute. Usually irregularly irregular heart rate.
Next, we're going to talk about acute exacerbation of COPD. So it's basically irreversible airway obstruction, typically caused by smoking, but you can obviously have other causes. So the first thing you want to do is do your history and physical exams. The cardinal symptoms of an acute exacerbation of COPD is number 1, increased dyspnea, increased coughing, frequency or severity, okay, and then increased sputum volume or purulence, okay. So you have increased dyspnea, increased coughing, increased sputum production. So what could trigger COPD exacerbation is viral infection, pneumonia, pulmonary embolism, congestive heart failure, MI, or drugs. Okay. So usually it's characterized by previous episode and or hospitalizations. Usually there is a smoking history in most patients. So you do your vital sign. You want to check your level of consciousness. Obviously, you're starting with ABC, right? Investigation. You want to do your CBC. You want to do your VBG, ABG, electrolyte, chest X-ray. Very important, just to rule out any secondary infection like pneumonia. ECG. And then pulmonary function tests are not useful in managing acute exacerbation. Okay. So physical exam findings in COPD. Number 1, you could find wheeze, all right? Number 2, a maximum laryngeal height of less than 4 centimeters. A false expiratory time more than 6 seconds. It decreased breath. You'll find decreased breath sounds, and also you will find decreased cardiac dullness. So you need to rule out. What do you need to rule out? So you need to rule out with COPD. You want to rule out, is it an exacerbation? Is it pneumothorax? Is it congestive heart failure exacerbation, acute MI, is it a pneumonia or other infections, or is it pulmonary embolism? So that those are the DDs. Next, so how would you manage this patient? First, oxygenation. So after you've done your ABC, make sure oxygenation is intact. So keep oxygen saturation about 88 to 92%, and be aware of chronic hypercapnia or CO2 retainers. But so basically remember, because you have airway obstructions, your airway obstruction, what happens is that you have increased COPD, and then that causes hyper wheezing, hyperventilation. So first of all is your oxygen. Second is bronchodilators. You're going to start in a short-acting beta agonist, salbutamol. All right, you can use a spacer. Plus or minus, you can add short-acting. Salbutamol is a short-acting beta agonist. You can add a short-acting anticholinergics, ipratropium, 0.5 milligrams. Then next is going to be a steroid. You want to give them IV steroids or the OS. So oral steroid would be prednisone, IV steroid would be your methylprednisone, 1 to 2 milligrams. Then you want to add antibiotics. So what are you going to start? Bactrim or cephalosporin, respiratory quinolones. So given if all the cardinal symptoms are present, or 2 cardinal symptoms with increased sputum purulence. So basically, if they have increased sputum volume and purulence, if they have increased coughing, if they have dyspnea, then you want to add antibiotics. Then ventilation. So you do want to give them apply actually a non-invasive positive pressure ventilation. So you want to give them CPAP or BiPAP. Okay, so if they're in severe distress, or they have signs of fatigue, or if the arterial pH is lesser than 7.35, or they are hypercapnic. So if life-threatening, intubate. Okay, so if they are life-threatening, you have given the non-invasive positive pressure ventilation and they're still not getting better, so you might need to intubate and refer to ICU for admission. Actually, these patients actually have a high chances of ventilation dependency. Okay. Next, we're going to talk about heart failure. All right, so patient presenting to the emergency. What are actually the precipitants of congestive heart failure exacerbation? So mnemonics is failure. So F is that they forgot medication. A, arrhythmias like dysarrhythmias or anemia. I is ischemia, infarction or infections. L is for lifestyle if they're having high salt intake. U is for upregulations of cardiac output, such as in patients who are pregnant or have hyperthyroidism. R is for renal failure. E is for embolism. So what could be the causes? So first, the causes of chronic heart failure. Number one, you have decreased myocardial contractility, and then this could be due to ischemia or infarction. So if there was any ischemia, MI, or infarction, then you're going to have decreased myocardial contractility. Then the other state could be pressure overload state. So pressure overload could be due to hypertension, valve abnormalities, congenital heart disease, or it could be due to restricted cardiac output, where example of myocardial infiltrative disease, cardiac tamponade. Okay, so we have the causes. So causes of chronic heart failure: number one, decreased myocardial contractility; number two, pressure overload state; number three, restricted cardiac output. Now, precipitant of an acute decompensated heart failure. What are the precipitant? Number one is your cardiac. If maybe the patient had any ischemia, infarction, arrhythmias like AFib, that can precipitate your acute decompensated heart failure. Medication, beta blocker, calcium blockers, NSAID, steroids, and if patient is also non-compliant to their medication. And dietary as well, if they have high level of sodium and intake and high level of water intake. As well as high output. If maybe they are pregnant, they have infection, they have anemia, they have hyperthyroidism, this can actually be precipitate acute decompensated heart failure. Other precipitant can actually be renal failure, hypertensive crisis, iatrogenic fluid overload, blood transfusion, or overload with fluids. Okay, so presentation. So left-sided heart failure we present with dyspnea, shortness of breath on exertion, autopnea, paroxysmal nocturnal dyspnea, nocturia, fatigue, altered mental status, pre-syncope or syncope, angina, systemic hypotension. They can also have hypoxia, decreased air entry to the lungs, crackles, S3, S4, pulmonary edema, pleural effusion. usually on the right side. And then right-sided heart failure would be usually dependent bilateral with bilateral pitting edema, JVP elevation, a positive abdominal jugular test. They may have ascites, hepatomegaly. All right. So patients often present with a combination of right-sided and left-sided symptoms. Okay. So acute. So what would be investigation? Next, let's talk about investigation. So you do your blood workup. You want to do your CBC electrolytes, your liver function test, cardiac enzymes, brain natriuretic peptide, which is BNP, chest X-ray, most useful test because you want to check are they having any pleural effusion. When you do ECG, you're looking for precipitant like your MI, ischemia, left ventricular hypertrophy, atrial enlargement. You want to do a bedside ultrasound, looking at the Curly B lines, pleural effusion, and rule out any cardiac tamponade because that can actually cause what? Restricted cardiac output. Okay. So you want to do an echocardiogram. So left ventricular function, checking the left ventricular function, structure of the heart disease. Excuse me. And rule out other serious diagnosis like PE, pneumothorax, pneumonia, and emphysema. So it can be difficult to differentiate acute decompensated heart failure and COPD exacerbation in patients who have both Curly B lines, pleural effusion, and elevated BNP. Okay. So because remember, in acute decompensated heart failure, you're also going to have elevated BNP as well as exacerbated COPD. So try and differentiate the two. Treatment, very important, starting with ABC. So the patient may require intubation. So make sure the patient sit upright. You do your cardiac monitors and continuous pulse oximetry. So a saline lock IV, so your IV line is set for the catheter. You want to monitor your input and output of the catheter. You want to give 100% oxygen by mask. If poor response, you might actually require to give them a BiPAP. So BiPAP is usually preferred compared to CPAP, or you might actually need to intubate them, but it's very rare. So medical management that you're going to give them diuretics, right? So if volume overload, you're going to give them diuretics. Are they volume overload? Are they having pitting edema? Are you suspecting any pulmonary edema? Okay, so you want to start them on diuretics. You're going to give them furosemide 0.5 to 1 milligrams per kg IV and titrate to based on the response. You want to give them vasodilator. So especially if the systolic blood pressure is more than 100, you want to give them a vasodilator. So nitroglycerin 0.4 milligrams sublingual every 5 minutes as per needed. So remember, if systolic blood pressure more than 100, you want to give them vasodilator. But if systolic blood pressure is lesser than 90, what are you going to do? You want to give them inotropes or vasopressors. So first line agent is your norepinephrine. Okay, you can add dobutamine or epinephrine. And they also say that milrinone helpful in refractory cases, but readily available. Okay. So you treat the precipitated factors. All right. So e.g. rate control. So if you need to rate control, what are the medication that can help with rate control? It's your beta blockers, your calcium blockers. What are the medication that can help with rhythm control? Rhythm control is your electrical or chemical cardioversion. Okay. So that is if maybe they have a new AF. There's a new dysarrhythmia that is found. And then obviously you want to consult cardiology. Okay. So acute treatment of congestive heart failure. Remember the mnemonics: LM, NOP. So L, Lasix, M, morphine, N, nitroglycerin. That is if the systolic blood pressure is more than 100. Oxygen, obviously. Then they need to sit upright, and then you might need to give them non-invasive positive ventilation, such as your BiPAP. Okay, so BiPAP is preferred more than CPAP when it comes to heart failure. Okay. So on your what are you going to see on X-ray in a patient with congestive heart failure? So you can see pulmonary vascular redistribution. You can see perihilar infiltrates. You can see interstitial edema, A, Curly B signs, alveolar edema, bilateral infiltrates, may see cardiomegaly, pleural effusion as well, peribronchial coughing, visual thickening. Okay. So next, let's talk about venous thromboembolism. So what are the risk factors of a patient getting or having a DVT? So we're looking at the Virchow triad. Risk factors number 1 is alteration in blood flow, which means venous stasis. Sorry. So number 1 is alteration in blood flow. Okay, venous stasis. So basically, blood is not moving from the limbs upwards. Okay, it could be that the patient is in a trip or something, and they're not mobilizing. Next risk factor, on the Virchow triad is your injury to the endothelium. So what causes injury to the endothelium is smoking, hypertension, surgery, catheter trauma. Then the last criteria is hypercoagulate, excuse me, coagulable state. So basically, anything that increases your chances of causing forming clots, which could be pregnancy, the use of oral contraceptive pills, malignancy as well. So deep vein thrombosis. What will be the presentation? So patient will present to you at the emergency department with a cough pain, unilateral leg swelling, erythema of the affected limb, edema of the affected limb, palpable cord along the deep vein system on exam. So basically, that's what the patient will present with. The clinical signs and symptoms are unreliable for the diagnosis and exclusion of DVT. So further investigation is often needed. Okay, but then obviously, if the patient presents with cough pain, unilateral leg swelling, erythema of the affected limb, the affected limb is 3 centimeters greater in diameter compared to the non-affected limbs, then you should actually suspect DVT. So investigation, you can actually use what is called the Wells criteria for DVT to guide investigation. The next D-dimer is only useful in ruling out DVT, and a D-dimer test result should only be considered in case where a low moderate risk patient has a negative test. Okay, because there's high risk of false positive. So what are the cases where you can get false positive for D-dimers? So in an elderly patient, you can have false positive. If a patient has infection, you can get false positive. If they had a recent surgery, trauma, hemorrhage, if they are late in pregnancy, like third trimester, or they liver disease, or they have cancer, you can actually have a high false positive result. So an important one is to do an ultrasound. So because it has high sensitivity and specificity for a proximal clot. Okay. So if it's positive, if the ultrasound is positive, you treat the DVT unless anticoagulation is contraindicated. If it's negative and low risk, meaning you rule out the DVT. But if it's negative and you have moderate to high risk, you repeat the ultrasound in 5 to 7 days just to rule out DVT. So how would you manage a patient who presents now with DVT? You would do, so first option is your direct oral anticoagulants, known as DOAC, direct oral anticoagulants. So it can be used in acute management of a symptomatic DVT. All right. So an example is your rivaroxaban. 15 milligrams per oz BD for the first 21 day. After 21 day, you give them 20 milligrams per oz daily for the remaining treatment. So if it's 6 months and should be taken with food, okay, at each same time each day. So that's the thing about it. It has to be taken every day. Another option of your direct oral anticoagulants are your epizapan, 10 milligrams per oz BD. For the first 7 days, then 5 milligrams per oz BD for the remaining of the treatment. Alright, so the second option is your low molecular weight heparin. Okay, so unless the patient also has renal failure, but the first option will actually usually be your direct oral anticoagulants. But if patient has renal failure, so low molecular weight heparin, example is your dalteparin, which is 200 international unit per kg subcut. Okay, or it could be, you could give them enoxaparin. So enoxaparin is also known as Clexane, so it's 1 milligrams per kg subcut. So the use of your direct oral anticoagulants versus your low molecular weight heparin for cancer-induced venous thromboembolism. So it actually varies. Some practice prefer the direct oral anticoagulant compared to the low molecular weight. So you can also use if you have a cover filter or surgical thrombectomy can be considered if anticoagulation is contraindicated. So duration of the anticoagulation. So for how long do you decide to treat this patient? So 3 months if transient coagulopathy, and 6 months if unprovoked DVT, and lifelong if ongoing coagulopathy. Okay. So basically, what does unprovoked DVT mean? So if unprovoked DVT, meaning there's no an underlying risk factor that caused the DVT, then you need to treat them for 6 months. But if let's say there's an underlying cause, like maybe they were an oral contraceptive, then you treat them for 3 months. All right. So next we talk about pulmonary embolism. How they present? They present with dyspnea, number 1, pleuritic chest pain. They can present with hemotopsy, which is they're coughing out blood. And then tachypnea, cyanosis, hypoxia, fever, and obviously they will have clinical signs and symptoms are unreliable for the diagnosis or an exclusion of PE. So if further investigation is often needed, you actually need sometimes just clinical symptoms and signs. It's not enough. So investigation, you use a Wells criteria for pulmonary embolism. And then pulmonary embolism, you can also use pulmonary embolism rule out criteria score. You can do your ECG, your chest X-ray. I usually useful to just rule out other causes like pneumonia, pericarditis. On ECG, this easily changes of a PE. You will see a sinus tachycardia, right ventricular strain. You can see T wave inversion in the anterior and inferior lobes. A chest X-ray. Signs of pulmonary embolism, which I actually rate to see, is your Hampton hump. So it's a triangular density extending from the pleura. So it's a sign of pulmonary infarct. Okay, you can also have the Westermarck sign, which is dilation of vessels proximal to the obstruction. Proximal to the obstruction. Sorry about that. So the other thing you can do a D-dimer. It's only useful in ruling out PE, but remember it has low sensitivity and specificity. So CT scan, you can actually use CT scan, pulmonary, and angiography for high sensitivity and specificity for PE, and may also indicate an alternative diagnosis. So you can use VQ scan for patients who are pregnant, or when CT pulmonary angiograph are not available, or IV contrast is contraindicated. So what are the risk factors for patient with venous thromboembolism? Is the mnemonics is thrombosis. So T for trauma or travel, H for hypercoagulable or hormones replacement therapy, R for recreational drugs like IV drug user, O for old age more than 6 years old, M for malignancy, B for birth control, O for obesity or obstetrics, S for surgery or smoking, I for immobilization, S for sickness such as patient with MI, nephrotic heart disease, vasculitis. So how would you manage this patient with PE? So treatment of PE with anticoagulation and duration of treatment is the same as your DVT. So you would treat it the same as a DVT, but if they have a massive PE, okay? So what does a massive PE means? So massive PE is defined as an acute pulmonary embolism with sustained hypotension, so meaning a systolic blood pressure less than 19 for at least 15 minutes, or requiring an inotropic support, and not due to a cause other than pulmonary embolism. Okay, so in this case, this patient will need thrombolytics. So that would be a massive PE. All right. So catheter-directed thrombolysis or surgical thrombectomy may be considered in a massive PE, or if anticoagulation is contraindicated. Okay, so it could either be surgical thrombectomy or it could be a catheter-directed thrombolysis. Okay, that is used. This is what is actually used for a patient who presents with a massive pulmonary embolism. Okay, so basically this diagram is an approach to a suspected DVT. It says basically if you're suspecting or the patient is symptomatic for an acute DVT, you first thing you want to do is a compression ultrasound. All right, so if it's normal and then you still have high index of suspicion, you repeat it in 5 days. Okay, if the DVT is present, you treat. Okay, so but then if the results are inconclusive, okay, or the study is inadequate, then you can do a venography or an MRI, okay, to further diagnose the DVT. So what is the Wells criteria for DVT? So for every point you get a +1. So active cancer +1, paralysis or paresis or recent immobilization of the leg +1, recent bedridden, if they recently been bedridden for 3 days or more, or a major surgery within 4 weeks is a +1. If they have local tenderness +1, entire leg swelling +1, a cuff swelling more than 3 centimeters compared to the asymptomatic leg +1, unilateral pitting edema +1, core lateral superficial veins +1, and alternative diagnosis more likely. If you think an alternative diagnosis is more likely, then it's a -2. So if you have a score of more than 3, high probability that is a DVT. So what is the Wells criteria for pulmonary embolism? Number 1 is if they have a previous history of DVT or pulmonary embolism, it's a +1.5 point. If a heart rate is more than 100, it's +1.5. If they have recent immobility or surgery, it's a +1.5. If they have clinical signs of DVT, it's a +3. If they have alternate, if you think alternate diagnosed less likely than PE, is a +3. If they have hemoptysis, is a +1. If they have cancer, it's a +1. So if they have the score is between 3 to 6, you have intermediate probability. If it's more than 6, you have high probability that is a PE. So remember, we spoke about some rare signs that can actually be found on a chest X-ray in a patient with pulmonary embolism. The first one is your Hampton-Hum sign. Alright, so it's a wedge-shaped infiltrate that abuts the pleural effusion. Atelectasis or infiltrates 15% normal. So both signs are, the other signs is your Western mark sign. Alright. Next, we're going to talk about your diabetic emergency. First, it's going to be diabetic ketoacidosis. So what is the triad of a patient with diabetic ketoacidosis? Number 1, hyperglycemia. Number 2, ketosis. Number 3, acidosis. Okay. So they have hyperglycemia, ketosis, acidosis due to severe insulin deficiency and a counter-regulatory hormones excess. Okay. So what are the precipitated factors of a diabetic ketoacidosis? Your infection, cardiac or mesenteric ischemia, IM, intoxication, insulin omission. So those are the precipitated factors. Okay. So basically, what are the clinical features? So it's often young patient usually with type 1 diabetes patient. May already be first presentation in undiagnosed type 2 diabetes. So usually first presentation type 1 diabetes. All right. So early signs and symptoms. What will be the early signs and symptoms of DKA? Number 1, polyuria, polydipsia, malaise, nocturia, weight loss, abdominal pain. So those are the early symptoms. Late symptoms, they can present with GI, which is anorexia, nausea, vomiting, increased abdominal pain, or neurological, where they start feeling fatigue, drowsiness, even going to common respiratory symptoms. Late signs of respiratory symptoms are your Kussmaul respiration, dyspnea, often due to acidosis. They'll have this fruity ketotic breath. Okay, those are usually your later signs. But normally they'll just present with polyuria, polydipsia, nocturia, weight loss, abdominal pain. The investigation, okay, you want to do a blood workout, CBC electrolyte, your calcium, magnesium, phosphate, creatinine levels, urea, glucose, ketones, osmolality, your liver function, your amylase, your troponin. And remember, you're also trying to find what could be the precipitant. Okay, so if it could be infection, so you have already done your CBC. It could be a cardiac causes that has precipitated or MI or intoxication, then you want to check all of that. You also want to check the urine for glucose and ketones. You want to do your ABG, VBG. You want to do your ECG. Okay, just to rule out any precipitant, like MI, any dysarrhythmias. So how would you manage this patient? Most important, you have three factors when you're looking at the management of DKA. Number one, you need to is hydration. Number one, hydration. Number two, potassium. Number three, insulin. Okay, so make sure you hydrate the patient well. Okay, because what it is, there are high chances that they are actually presenting with hypovolemic shock. Okay, so you make sure you have a bolus of normal saline, then high rate of normal saline infusion. Okay, so be aware of overhydration as well and cerebral edema especially in pediatrics patients. So you do want to hydrate them. You first want to give them a bolus. How would you calculate your bolus? 20 to 30 moles per kg. And after that, you can do your maintenance fluids depending on the kg that they are, using your 4-to-1 rule. Okay. So be aware of your pseudo hyponatremia due to hyperglycemia. Okay, so what you want to do is that you want to add 3 sodium per 10 glucose over 5.5 moles per liter. So because of the hyperglycemia, patient can actually present with a pseudo hyponatremia. So be aware of that. So potassium is the next one. So before you give insulin, make sure your potassium is well. Okay. So essentially you want to avoid hypokalemia. Okay. So basically, because once you give insulin, it will cause potassium to be absorbed into the cell. All right. So if it's absorbed in the cells, meaning intravenously, your potassium is going to drop, and that can also cause other things. So you need to replace KCl, replace potassium with KCl, potassium chloride, 20 milligrams. Sorry. So only if the patient is voiding. So is the patient voiding? Okay, are they able to urinate well? Do they have an adequate renal function? Okay, and if the potassium is lesser than 5.5 moles, then you can start them on KCl 20. All right, and obviously use cardiac markers and monitors if potassium levels are normal or low. The next step is your insulin. So critical, and this is the only way to inhibit gluconeogenesis or ketosis. So usually do not give insulin if your potassium is lesser than 3.3 moles, as insulin would want to exacerbate hypokalemia. All right. So what are you going to do? You're going to give your insulin. It's going to be a continuous infusion, all right, of 0.1 unit per kg per hour. So once the blood glucose is lesser than 14 moles, you give them dextrose should be added to the patient IV fluid. All right. So bicarbonate is usually not given unless the patient is really at high risk of shock or death. Okay. So next we're going to talk about hyperosmolar hyperglycemic state. So this is your HHS. So hyperosmolar hyperglycemic state is characterized by extreme hyperglycemia. So you usually have hyperglycemia, the glucose level of more than 33.3 moles per liter. So due to relative insulin deficiency, you have your counter-regulatory hormones that become so excess, like your cortisone, glucagon, and then this produces goes through gluconeogenesis and at the same time causes dehydration due to the hormostic diuretics. So patient present then with dehydration as well and hyperglycemia. So clinical features, often you see it in elderly patient, type 2 diabetes patient. Okay. And actually this patient present with fewer GI symptoms and actually more neurological deficit than DKA. DKA, you have more GI symptoms and less neurological symptoms, but HHS usually has a lot more neurological deficit, which includes they'll have mental disturbance. They can actually be in coma. They can actually be in delirium. They can actually present with seizures. Okay. They will also have symptoms like polyuria, nausea, vomiting. So blood workout the same as your DKA. You want to do CBC, electrolyte, calcium, magnesium, phosphate, all of that, ketones, osmolality. Check your urine for glucose and ketones just to rule out DKA. VBG, ECG, chest X-ray, blood and urine culture and sensitivity. Then how would you manage them? Because the most common thing is hydration. Want to hydrate them with IV normal saline, starting with a bolus and then you give them maintenance fluid. Oxygenation, because remember they have high chances of having neurological deficit. Make sure you have your cardiac monitors, frequent electrolyte check, glucose monitoring as well, and insulin management. So you would give them insulin management as per DKA. So obviously we're making sure that your potassium is up to standard, is more than 5.5 moles. If yes, then we can give them insulin at 0.1 unit per kg per hour. Okay, so criteria for DKA diagnosis. So remember we say hyperglycemia, they have increased acidosis, they have increased ketones. Those are the main things. So number one, hyperglycemia, metabolic acidosis, ketonemia, or ketouria. All right, so three things. The glucose is high. They are metabolic acidotic. Then they have ketones in the blood and in the urine. Okay, those are your DKA. So what about hypoglycemia? So characteristics, especially characterized by the Whipple's triad. So they have low plasma glucose, that's symptoms suggestive of hypoglycemia, and prompt resolutions of symptoms when glucose is administered. So the moment you give them glucose, they get better, right? So clinical features of hypoglycemia, they can have neuroglycopenic symptoms. They can present with headaches, confusion, seizures, loss of consciousness, and coma. They can also have autonomic symptoms like sweating, nausea, diaphoresis, tremor, hunger, tachycardia, palpitations. Okay. And then what will be on the history and physical exams? Want to know when was the last meal? Are they non-diabetic? Do they have a prior similar episode of hypoglycemia? Any drug therapy? Are they compliant to medication? Are they having any other disease, liver or renal disease? Are they depressed? Are they using alcohol? Any drug abuse? So how do you manage them? You want to check the bedside glucose, bedside capillary blood glucose, and then give them oral glucose if possible. So if they can actually swallow, you're going to start by giving them some sugar tablets or juice, something sugary, right? Then put up IV access, especially if they cannot take anything orally. And you start with 50 moles or 50% dextrose IV push. So one push. This is in adult. All right. So in adult, you start with 50 moles or 50% dextrose IV push. All right. So use a lower concentration dextrose solution in children. So the rule of 50s. So if you only have in children, if you only have 50% dextrose, okay, you are going to give them 1 mole per kg. If you have 25% dextrose, you're going to give 2 moles per kg. If you have 10% dextrose, you're going to give them 5 moles per kg. If you have 5% dextrose, you're going to give them 10 moles per kg. Okay. So if IV access and oral replacement are not possible, what are you going to give them? You can give them glucagon, 1 to 2 milligrams IM, and then you repeat it 10 to 20 minutes. Okay. Make sure they have oxygen. You give them oxygen. You do your cardiac monitors. Frequent blood glucose monitoring. Thiamine, 300 milligrams IM. So if you're actually suspecting an alcohol disorder or malnutrition. Meal. Make sure that they're able to make sure they start eating as soon as the mental status permits. Okay. And if it's due to long-acting insulin or your sulfur ureas, you need to watch for prolonged hypoglycemic due to long half-life. Okay, you might need to decrease the dose and search for the causes. Okay. So the common causes include an exogenous insulin. It's just that the patient had a lot of insulin given, or they are on sulfonylureas, or they are alcohol abusers. Okay, so those are the most common causes. So check whether is it because of insulin, is it because of alcohol, or is it because of anti-glycemic medication. Okay. So just a quick one revision on DKA. So what are the precipitated factors of DKA? 5I. So 5 I's. First I, infection. Second, ischemia, infarction, intoxication, insulin mist. Right. Infection, ischemia, infarction, intoxication, insulin mist. Okay. So causes of hypoglycemic, the most common cause is due to excessive insulin use, okay, in the setting of poor oral intake. Okay. The other common causes of hypoglycemic are your alcohol intoxication, sepsis, liver disease, and oral anti-hyperglycemic. Okay. Other rare causes are your insulinomas, hypopituitarism, adrenal insufficiency medication side effects. Okay, so note cerebral edema may occur if hyperosmolality is treated too aggressively. So if patient now is in DKA and you're treating it very aggressively with fluid, you can have cerebral edema. Okay, so next we're going to talk about electrolyte disturbance. Okay, so first, number one is hypernatremia. What are the most common cause? Hypernatremia is usually caused by inadequate water intake, usually found in elderly patient, disabled patient, or it could be due to inappropriate excretion of water. So water is inappropriately excreted from the body via the use of diuretics or a disease known as diabetic insipidus. So symptoms patient will be lethargic, weakness, irritability, and edema. They can actually have seizure, coma, and occurs with severe elevation. This usually occurs with severe elevation of sodium, where the levels are above 158 millimole per liter. Then the patient start having central nervous system symptoms like seizure, edema, coma. They start being irritable. They start feeling weak. They start feeling lethargic. So usually you'll be your central nervous system symptoms. Treatment: salt restrict. So salt restrict and give normal saline. Okay, until hemodynamically stable. So use half normal saline once the vital signs are stable. Okay, so first of all, you want to restrict them from any salt intake. Number one. Number two, you start them with normal saline. Very, very interesting. 0.9% normal saline until they become hemodynamic stable. Once they are stable, now you start with half. Give them 0.4% saline. Okay, once the vitals are stable. Now, what are the special consideration in patient with hypernatremia is that you don't want to have more than 12 millimoles per liter drop in the 24 hours. So sodium should not drop more than 12 millimole per liter in the 24-hour period. So meaning you should not have a drop of more than 0.5 millimole per liter per hour. Okay. Why? Due to the risk of cerebral edema, the risk of even dying, and the risk of even seizures. Right. So it's a big thing. Next is hyponatremia. And what are the most common cause is your hypovolemia. So you have lost a lot of fluids, either through your the GI, like vomiting, diarrhea, or your renal system, or through the skin, through sweating, or blood fluid loss. Okay, or it could be euvolemic, meaning your volume is normal but your sodium is low. It could be due to the syndrome of inappropriate antidiuretics hormone secretion. Okay, so if you have that, what happens? So your volume levels is normal, all right, but then your sodium. So you are having inappropriate antidiuretic hormones, and what does antidiuretic hormones does is that it causes inhibition of your water excretion, so water does not get excreted. So also stress, adrenal insufficiency, hypothyroidism, diet intake can actually cause that. Then hypervolemic causes are congestive heart failure, you're retaining a lot of fluid, repeating edema, cirrhosis, you have ascites, for example, you have a lot of retained fluid compared to the rate of sodium that causes hyponatremia, or nephrotic syndrome. So symptoms, so neurologic symptoms secondary to cerebral edema. So remember, in hypernatremic, we say that if we are dropping the sodium too quickly, we're going to have cerebral edema. So now, patients with hyponatremia, the most common symptoms they're going to have are symptoms related to cerebral edema. So headache, seizure, decreased level of consciousness, depressed reflexes, chronic, milder than acute. All right, so if it's an acute hyponatremia, they're going to have a lot of symptoms all related to cerebral edema. How do you treat that? You want to give, if the patient is hypovolemic, let's say they had GI symptoms, they've been vomiting and whatever, you want to start them with normal saline. If they're euvolemic, let's say they have syndrome of inappropriate antidiuretics hormone secretion, so you will restrict them water and then eliminate the underlying cause. If they have hypervolemic, like in heart failure, cirrhosis, nephrotic syndrome, what are you going to do? You're going to restrict fluid and sodium, and you're going to give them loop diuretics if it's severe. And then 3% hypertonic saline if they have seizures or if they have coma. Okay, so if they're hypervolemic, Let's repeat that again. You're going to give them loop diuretics if it's severe. So basically, you're restricting both fluid and sodium. But if you start having seizure coma, you're going to give them 3% hypertonic saline. So what are the special considerations? So limit the rise. You don't want to give them too much sodium. So you don't want to give them more than 8 millimole per liter of sodium in a 24-hour period. Why? Because patient will be at risk of osmotic demyelinating syndrome, so ODS. Next, hyperkalemia. What are the most common causes? Are your rhabdomyolysis, breakdown of your muscle cells, insulin deficiency can cause that, because insulin usually helps potassium to go inside the cell. So if you have insulin deficiency, that could cause you to have a lot of insulin inside the blood. Okay. So metabolic acidosis, like acute renal failures, missed dialysis, medication that are potassium sparing diuretics, ACE inhibitors, NSAID, spironolactone. So nausea, we can present with nausea, palpitation. So it affects your heart, right? So it affects your heart, right? Dysarrhythmias, causes muscles to be stiff, okay? Irreflexia, palpitations, nausea. How would you treat this? The first thing you want to do is protect your heart, right? So what can protect your heart is your calcium gluconate. Okay, so now that you've protected the heart, now you can shift potassium back into the cell by giving the patient insulin. Okay, insulin is what does the work. Now, because you have given insulin, you have to give them dextrose, depending on how much glucose they have. All right. Now, next, you can also give them sodium bicarb. You can also give them salbutamol. Salbutamol will also help moving potassium into the cell. Okay. Or if none of these methods are working and it's severe, you can actually use dialysis. You can actually remove potassium by giving the patient fluid together with furosemide. So if you give patient furosemide, remember it's a diuretics. You need to add fluid. So you can give furosemide plus fluid, or if it's very severe, you do dialysis. Special consideration: high risk of dysarrhythmias with patient with hyperkalemia. So obviously on ECG you will see a peak or narrow T wave. You're gonna have a decreased B wave. Sorry, a peak or narrow T wave, decreased B wave, prolonged PR interval, or widened QRS. An AV block can cause an AFib, can cause a bradycardia. So peak T wave, depressed P wave, peak T wave, depressed P wave, prolonged QRS complex, widened QRS complex, prolonged PR interval, widened QRS complex. You can have AV block, VFib, bradycardia. So what about hypokalemia? So most common causes are your metabolic alkalosis, especially patient who has, like, if a patient had a diarrhea, now they have metabolic acidosis. They're going to have hypokalemia. Insulin, high insulin, remember the opposite of low insulin. Diuretics, if you give them diuretics, except for potassium sparing. If for some reason, anorexia, salbutamol. So basically the symptoms are usually GI symptom, nausea, vomiting, constipation. They also have muscle cramps, dysarrhythmias as well. How would you manage hypo? You want to give them KCL, right? So KCL 20 to 40 over 3 to 4 hours. Remember, you slow it down. Okay, so special consideration in ECG, you usually see a U wave. It's most important, okay? And so they'll have a U wave on ECG, a flattened inverted T wave, prolonged QT, depressed ST. Okay, and you may need to restore magnesium. Okay. Next, hypercalcemia. The most common cause is your parathyroidism. You have so two most common cause of hypercalcemia is number one, you have increased your parathyroid hormone, or you have some sort of malignancy. Okay, that's a 90% of cases. Okay, then other things like medication, your thiazide diuretics. So thiazide diuretics actually prevent excretion of calcium. So then lithium as well. So lithium thiazide diuretics. Symptoms of hypercalcemia, multi-system, including cardiovascular system, GI system. It can cause renal systems involved, cause stones, rheumatological system. Okay, so patient with hyperparathyroidism, it could affect the bones. They can actually present psychiatric symptoms. Right, so it affects every system: cardiovascular, um, GI, renal. So first of all, how would you treat hypercalcemia? You would give them isotonic saline plus furosemide if hypervolemic. Okay, so what is furosemide does? Okay, so basically, remember it's a diuretics. Okay, so diuretics is going to cause the excretion of calcium. Okay, into out of the kidney through the kidneys, and then so first you will start with fluids. Okay, so very important here to remember. A patient have presented with hypercalcemia. What's the first management? It's fluid. You need to give them isotonic saline. You need to give them saline. That's the first thing you do, and then you can add diuretics if they are actually hypervolemic. Okay, you can add diuretics. So first line, saline, fluid, hypercalcemia, fluid. Give them isotonic saline. Then later on, you can think about other things like dialysis or biphosphonate. Okay, biphosphonate your chelations. Yeah. So what a special consideration: patient with more severe or symptomatic hypercalcemia are usually dehydrated and require saline hydration as the initial therapy. That's it. Hypocalcemia. Most common cause are your hydrogenic, hypoalbuminemia, liver dysfunction, primary hypoparathyroidism, hormones, recent thyroid surgery. Symptoms are your laryngospasm. So that's why that one is very, very important. So decreased calcium can actually cause laryngospasm. Okay, which is not good. Hyperreflexia, then paresthesia, tetany, the Vostek, and the Trocio sign. Sorry about that. And then, actually, how can you treat it? You're gonna give them an acute ionized calcium. So it requires immediate treatment. So you're gonna give them IV calcium gluconate. So that's the management. IV calcium gluconate, 1 to 2 grams in 10 to 20 minutes, followed by slow infusion. Okay, so sometimes check also your magnesium. Right, prolonged QT interval may arise, leading to dysarrhythmia. Okay, so hypocalcemia can actually cause prolonged QT interval, and this can actually lead to dysarrhythmia. And then they can also have upper airway obstruction. Why? Because of laryngospasm. Okay, so they present with tetany. Oh, great. So yeah, that is for your electrolyte dysfunction. So next we're going to talk about hypertensive emergency. So hypertensive emergency, you have two types. So remember, you have hypertensive emergency and hypertensive urgency. Okay, so hypertensive emergency is what is your hypertensive crisis, and is defined by an elevated blood pressure with an evidence of an end organ damage. So you have high blood pressure, and you also involvement of other organs like your central nervous system, retinal, cardiovascular system, renal, GI. Etiology: it could be essential hypertension. Of course, it could be emotional exertion. It could be pain. It could be the use of your sympathomimetic drugs like cocaine. Patient use cocaine, amphetamine, now they're presenting with hypertension. Or patient that are using your monoamide oxidate inhibitors for some sort of depression. And then they use it together with a tyramine containing food like cheese, red wine, or fermented products. So basically, if a patient is on monoamide oxidase inhibitor, they should not actually use food that contain tyramine. Okay, like cheese, anything fermented, cheese or red wine. Okay. Then it could be that the patient is pregnant. It could be that they have pheochromocytoma. Okay. So those are the couple of causes that can actually cause a patient to have hypertensive emergency. It could be that they are non-essential hypertensive. They have maybe now they have hypertension, not hypertensive. Now they have emotional exertion. They have pain now, or patients that are using drugs like cocaine and amphetamine, or patients that are using your monoamide oxidase inhibitors or pheochromatoma. So what are the clinical features? Remember, we talk about high BP. then you have an end organ damage also. So signs and symptoms, depending on the end organ damage, the complications. So if you have either if it's involving the central nervous system, you're going to have a high BP with either a stroke, symptoms of stroke, headaches, altered level of consciousness, seizures, hemorrhage. If it's affecting your retinal, it will be vision changes. They'll see hemorrhage or exudate or papillary edema or fundoscopy. If this is your renal that is involved, you're going to have nocturia, elevated creatinine levels, protein in the urine. You're going to have blood in the urine, or you're going to have no urine at all. If it's your cardiovascular, you can either patient presenting with ischemia, angina, infarction, congestive heart failure. If it's your gastrointestinal system, they'll have nausea, vomiting, abdominal pain, elevated liver enzymes. Okay, so severe elevated BP plus an end organ damage. All right. So just on the side, it says HELLP syndrome. So remember, HELLP syndrome is only seen in preeclampsia or eclampsia patient. And what are the three criteria is number 1, hemolytic anemia. Number 2, elevated liver enzymes. Number 3 is low platelets. Okay. So if you use the mnemonics HELP, okay, you will see H is for hemolytic anemia. E and L is for elevated liver enzymes. L and P is for low platelets. Okay. So investigation, obviously you want to check, you have to do your blood workup, CBC electrolytes, blood urea nitrogen, creatinine. You want to see that the liver, kidney involved, the cardiovascular system, urinalysis. You want to check for obviously any proteins in the urine, any blood in the urine. Okay. So peripheral blood smear to detect your microangiopathic hemolytic anemia. Alright, especially if the patient is pregnant. So chest x-ray, if they have symptoms of chest pain or shortness of breath. Want to do ECG. So a patient presenting with that high BP, do all of this. Workup. ECG, troponins, creatine kinase if chest pains is involved. CT hat if they start having neurological signs or severe headaches. Toxicology screen, obviously, if you're suspecting a sympathomimetic overdose, so such as cocaine or amphetamine. Alright, so you would do your toxicology screen. Okay. So if a patient actually admits of taking your cocaine or amphetamine, you're not going to do it, but if they're refusing, you're going to do your toxicology screen. And then how would you manage this? So in general, strategy is to gradually and progressively reduce your BP in 24 to 48 hours. Okay, so you don't want to have a sudden drop in your BP. All right, so lower BP by 25% over the initial 60 minutes by initiating antihypertensive therapy. So what is the first drug that you usually, most of the time you will use is labetalol. So depending on the type of patient you have, if the patient has preeclampsia, you obviously can consult obs and gynae. You want to get an arterial line transferred to ICU for further reduction of BP under monitoring settings. So in case of ischemic stroke, so do not rapidly reduce. So if a patient has an ischemic stroke and they have a high BP, remember, do not rapidly reduce the BP. You want to try and maintain the BP. Why? Because if you decrease the BP, the little amount of blood that you were supposed to get past that level of the ischemia, it's very low. Okay, so you need to maintain the BP by having a BP of at least more than 150/100 for 5 days. Right. Now the opposite is for aortic dissection. Okay, because you don't want a lot of pressure, and then this it bursts out or something. So the opposite is for aortic dissection, where you actually want to have a rapid reduction in systolic blood pressure of where you want to have it to 110 to 120 stat. Do not resuscitate with IV fluids in a patient with aortic dissection. Do not, because you're going to make it, you're increasing your systemic volume, and then that will also aggravate the dissection. Okay. So in case of excessive catecholamines, so if you have excessive catecholamines, like in a patient who has pheochromocytoma, you want to avoid beta blockers except for labetalol. Okay, so labetalol will still be your first line to decrease the BP. All right. So in case of ACS, address this ischemia initially, then the BP. So if a patient has acute coronary syndrome, you're going to first manage the acute coronary syndrome. then later on you manage the BP. So what about catecholamine-induced hypertensive emergency? So it says here avoid the use of non-selective beta blockers, but then you can actually use except for labetalol. As they inhibit your beta-mediated vasodilator and leave your alpha-adrenergic vasoconstriction unopposed. Okay, so let's try and understand it a little bit. Remember, your non-selective beta blockers actually block both your beta 1 and beta 2. Beta 1, beta 2 found in the lungs and in the blood vessels. So it does include your propranolol, your timolol, nodelol, okay? So most of them actually, because they inhibited, they actually will cause vasodilation, but they actually do not inhibit alpha adrenergic vasoconstriction, of which labetalol actually does. So you can avoid every excessive catecholamines, avoid beta blockers, okay, except for labetalol. So we are speaking about hypertensive crisis. Next, we're going to talk about, hypertensive urgency, which means severe asymptomatic hypertension. So it means elevated BP. So you have systolic blood pressure of more than 180, diastolic blood pressure of more than 120, but there's no evidence of end organ injury. Okay, but remember, you first also need to screen. You always need to do your ECG, everything, just depending on how the patient is presenting. Are they having any headaches? Are they having any chest pains? Are they having, okay? If they're having nothing of that, then it's a hypertensive urgency. So most will have a mild headache or non-specific vision changes or nausea. Just need to make sure. So most will, search carefully for end organ injury also, and measure BP properly. So measure in a quiet room and on both arms. Okay. So there is no proven benefit from rapid reduction of blood pressure. So rapid reduction can actually lead to MI, to acute kidney injury, and cardiovascular injuries. So you don't want to rapidly reduce the blood pressure, except if the patient has aortic dissection. Okay, as we spoken earlier. So what are the commonly used agent for the treatment of hypertensive crisis? Remember, we spoke about, I'm going to start with my adrenergic inhibitors, my beta blockers, my labetalol. All right. But actually, yeah, they have other options. They have vasodilators that you can actually use your sodium nitrobruside or your calcium channel blocker such as nicardipine or your nitroglycerin or hydralazine. Hydraz, hydralazine is usually used in eclampsia. Okay. So basically, nitroglycerin can actually be used in hypertensive crisis. So it's actually a quick one. It has a quick onset, quick duration, but the side effects are hypotension, bradycardia, headaches, lightheadedness, and dizziness. So you do not want to give it together with another drug that will cause hypotension. Like let's say, your phosphodiesterase like sildenafil. You don't want to give it together with nitroglycerin because it will cause a high decrease in hypotension. So it can cause hypotension, bradycardia, dizziness, and lightheadedness. So for nicardipine is a calcium channel blocker. Onset is about 15 to 30 minutes, and for over 40 minutes. Side effects is your tachycardia, headaches, flushing, local phlebitis, encephalopathy, renal failure, and eclampsia. So most hypertensive emergency. So it's usually indicated for most hypertensive emergency. So if you're not using labetalol, you can actually use nicardipine. So IV form is actually not available in Canada, and oral form does not have a reliable response to acute settings. So not really used in Canada. So what about sodium nitrobruside? So it's a vascular smooth muscle dilator. All right. So it's also an immediate action, and duration is about 35 minutes. But side effects is nausea, vomiting, muscle twitching, sweating, cyanide intoxication, coronary steal syndrome. So cyanide intoxication and coronary steal syndrome are the big ones. Then usually used in combination with beta blockers like esmolol in aortic dissection. So caution with high increased intracranial pressure, or azotemia. So adrenergic inhibitors that you can use is your labetalol. The thing with labetalol, it can cause vomiting, scalp tingling, burning in the throat, dizziness. It can actually cause a heart block, because remember it's a beta blocker. It can cause an orthostatic hypotension. So heart block, orthostatic hypotension, dizziness, burning on the throat. So usually it's the first choice for most hypertensive emergency, especially even eclampsia. So try and avoid it in patients with acute congestive heart failure. If they have heart block, if it's more like second degree or third degree heart block, I avoid giving beta blockers, right, or calcium channel blockers in patients who have heart block. Esmolol, as we have seen as well, it can cause hypotension and nausea and bronchospasm. Why can it? So basically, remember, it's both works on the beta blockers. Both works on the lungs and the blood vessel. So you can actually, in the lungs and the blood vessel, yes. So it can actually cause bronchospasm. So usually for aortic dissection, initially we say that you can actually use esmolol with sodium nitroprusside for patient with aortic dissection. Okay, so you can also use it for acute MI, supraventricular tachycardia, dysarrhythmia. But try and avoid it with patients. Same thing as labetalol, avoid it in patient with heart block. Okay, so last one, phentolamine. So phentolamine is a non-selective alpha-adrenergic antagonist. Phentolamine. So alpha is a non-selective alpha-adrenergic antagonist. So it also works very fast. Tachycardia, heart, headaches, and flushing are trigger side effects, and usually used for patients with catecholamine excess. So what are patients who have a pheochromocytoma, where they have an unopposed alpha, e.g. cocaine, you actually want to use phentolamine. It actually has not so much side effects, except maybe for tachycardia. So phentolamine, patient who have catecholamines, because remember catecholamines excess, you don't want to use them. You don't want to use beta blockers except for labetalol that you can use. So you can actually use phentolamine. Next, we're going to talk about acute coronary syndrome. So definition is a new onset of chest pain, or an acute worsening of a previous chest pain, or chest pain at rest. Okay, so it's either with negative biomarkers, negative cardiac biomarkers, and no ECG changes. So if it's an unstable, so you have different types. So you have unstable angina, right? Then you have a STEMI, you have a non-STEMI. Okay. So what is unstable angina? So unstable angina means that the patient has chest pain, or they have an acute worsening previous chest pain, but they don't have any, the cardiac biomarkers are negative, and there is no ECG changes. Then it's an unstable angina. Okay, so the other ones your STEMI. The next one is your non-STEMI. So here you have a positive cardiac biomarkers where you have an elevated troponin levels. And obviously you have non-STEMI on ECG. So non-STEMI on ECG meaning you are not having, so the ST elevation, there's no ST elevation, but then your biomarkers is high, I think. So what about STEMI? STEMI, you'll find it on ECG. Basically is an elevated ST, right? ST elevation, and you also have your positive cardiac biomarkers. Then occlusion, myocardial infarction. Okay, those are other ones. Investigation, you want to do an ECG stats. You want to know as soon as the history suggests an acute coronary heart disease syndrome. So patient presenting, I have a chest pain, is radiating to my arm. Immediately, the first thing I want to do is an ECG. Put an ECG on, and you do your serotonin levels. So 2 to 6 hours after symptoms onset, you do your chest X-ray. He did his chest X-ray to rule out other causes that the patient could present with, because remember, chest pain, you have a lot of causes that can cause chest pain. So you do a series of ECG. So you don't just do one ECG, you do a series of ECG. Actually improves sensitivity. Consider in patients who have pain highlights suggestive of ACS. If you have a previous ECG, that's better. If you have previous chest X-ray, that's also better. Just to compare, just to see that is this a new onset. Obviously, you want to ask the patient as well: have you had a previous chest pain before? Any cardiovascular disease, family history of heart disease, all of that history. I think we discussed it when were talking about chest pains. Okay. So how did you want to manage this patient? You want to stabilize this patient. Your ABC, obvious, or airway, breathing, circulation. Give this patient oxygen. Put in IV access. Do you put on your cardiac monitors, oximetry? You start then with giving them an aspirin. You want to give them aspirin, 162 to 325 milligrams, either swallowed or chewed. Next, nitroglycerin, 0.3 milligrams sublingual every 5 minutes, 3 times. IV only if the pain persists or if they have congestive heart failure or they're hypertensive. Because remember, nitroglycerin also helps in hypertension, right? We spoke about that early. Just that you need to watch out for the risk of hypotension as well. So nitroglycerin. What are the contraindication of high nitroglycerin? Okay, so number 1, we spoke about it already, hypotension. Number 2, phosphodiesterase inhibitors. Why? Remember, phosphodiesterase inhibitors like sildenafil causes hypotension. Okay, so you cannot give that together with nitroglycerin. The patient blood pressure is going to drop. If they have a high ventricular infarction as well, contraindication. Okay, so right ventricular infarction means, so it's 1/3 of all the inferior MIs. And these MIs are preload dependent. Okay, so because they are preload, these MIs are preload dependent. They depend on the preload. You don't want to give them nitroglycerin. Okay, so what are the symptoms of right ventricular infarction? Your hypotension, of which, remember, contraindication already to nitroglycerin is hypotension. Increased jugular pressure. It's a preload disease. So you're going to have an increased jugular pressure. So remember, it's a right-sided. The lungs will be clear, okay? The lungs will not be affected. But because it's preload, now on the right side of the heart, it has ischemia or there's infarction. The contractility is poor. What happens? Hypotension, increased JVP, because now fluid gets accumulated, right? So symptoms relief only. So remember, you can give the patient nitroglycerin after you've excluded your contraindications. And then you can also give them the next one after is your anticoagulation. So your choice of anticoagulation, you want to give them either unfractioned heparin or lower molecular or fondaparinux. You can add additional antiplatelet therapy like clopidogrel or ticagrelor or prasugrel. So it depends on STEMI versus non-STEMI and reperfusion strategy. Next, early cardiology consultation for reperfusion therapy. So for unstable angina or non-STEMI, so early coronary angiography is recommended if high thrombolysis in MI, if they have a high TIMI score. For STEMI, what are you going to start with? You need primary percutaneous coronary intervention. Okay, STEMI patient is to have PCI, primary percutaneous coronary intervention, within 90 minutes, preferable. Okay, so within 90 minutes of symptom onset. Okay, thrombolytics. So if you can't do your primary percutaneous coronary intervention, you can give them thrombolytics. Thrombolytics, if your PCI is unavailable within 120 minutes of medical contact. So symptoms less than 12 hours and no contraindications. So you can still give thrombolytics if the symptoms are less than 12 hours or no complication. But remember, you need to get your cardiology on board. Okay, so let's run through it. You're in the ED. Okay, you're suspecting a patient with coronary artery disease. First thing, you want to stabilize. You want to do your ABC. You want to put in oxygen. You want to put an IV line. Do your put on your cardiac monitors, your oximetry. Give them aspirin. Okay, then you can consider giving them nitroglycerin. All right, if there's no contraindication, consider giving them anticoagulations. You can give them additional antiplatelet therapy, clopidogrel, okay, or ticagrelor or prasugrel. You can give that. And then at the same time, somebody's already put on this ECG, trying to figure out is it STEMI, is it non-STEMI. As soon as you know it's a STEMI, you want to consult cardiology for reperfusion because you need to they need to have a primary percutaneous coronary intervention within 90 minutes of arrival. Okay, or be started on thrombolytics if they have no contraindication, and then if they have less than 12-hour presentation as well. Sepsis next. So definition, overall sepsis can be thought as a life-threatening organ dysfunction caused by dysregulated host response to infection. So basically, you have systemic inflammatory response syndrome. What does that include? 2 or more, temperature more than 38 degrees Celsius or less than 36 degrees Celsius. 2, heart rate more than 19. 3, respiration. So what a systemic inflammatory response syndrome includes: number 1, either 2 or more of the following. Either they have a temperature more than 38 or temperature less than 36, that's 1 point. A heart rate more than 90, 2 points. Respiratory rate more than 20, 3 points. White blood cell count more than 12. So that's how many factors? 1, 2, 3, 4. So heart rate, respiratory rate, temperature, white cell count. So sepsis, what is sepsis? So sepsis is your systemic inflammatory response syndrome and suspected or the presence of a source of infection. That's the definition of sepsis. What is septic shock? Septic shock is sepsis and either initial lactate of more than 4 or hypotension. So a septic shock is a patient presenting with sepsis, okay? So they have a source of infection and they either have an increased lactate of more than 4 or they have hypotension. Okay, so you have something called a Q-SOFA score. Q-SOFA score of more than 2 has high risk for hospital mortality. Okay. So how do you manage sepsis? Early recognition and of sepsis and investigation to locate the source of the infection is very important. So identify severe sepsis with lactate. You want to do your blood vessels. So the higher the lactate more than 4 should be concerning. So identify severe sepsis with lactate or evidence of tissue hypoperfusion. So evaluate tissue perfusion at a bedside with capillary refill, mental status, and urine output. So how do you evaluate tissue? Let's just repeat that. How do you evaluate tissue perfusion at a bedside? By doing your cap refill. What is the patient mental status? What is the patient urine output? Okay. So sepsis standard operating procedures. The initially specified as early goal-directed therapy have evolved to the usual care, which includes a standard approach with component of sepsis bundles. Okay. So obviously you want to check for early identification of sepsis, do your lactate, do your blood cultures, give antibiotics, give fluid. Okay. So treatment priorities, you want to do your ABC, airway, breathing, circulation, put on your monitors, put on your IV lines. Next, aggressive fluid resuscitation. If you are giving fluid, still not going, you might consider to use your anatropes. Consider ventilatory support, you give them oxygen. Do your culture. Do your culture, blood culture, urine culture, right? Then, early empiric antibiotics. Consider your broad spectrum antibiotics. Okay? Want to give ceftriaxone, vancomycin, plus or minus ampicillin. Okay, so and then source control. Check if it's a patient that has been hospitalized. You want to check, is it maybe the Foley catheter? You need to remove the infected Foley catheter. Surgery for ischemic gut. Is there? So basically, you do all checking the source basically. So remember, if I say first, you need to identify the source. Any identification of source, check your lactate, do your cultures, start antibiotics, IV fluid. So monitor adequate resuscitation with what? How do you monitor adequate resuscitation? Number 1 is with what? Vital sign. Is a vital sign fine? You check for inferior vena cava, okay, on ultrasound. So if the patient is if the patient is mechanically ventilated, or if they're not, then you can just check your JVP. Okay, obviously the JVP should not be high if they actually central venous pressure should be less than 15. So number 1, vital sign, inferior vena cava. Next, urine output. Okay, then next the serial measurement of serum lactate. Okay, so you will do multiple measurement of serum lactate. If that decreases, you know that you're actually doing an acute resuscitation. Okay. So in patient presenting with septic shock, the goal-directed therapy and aggressive management should not be delayed while waiting for lab results. Okay, so you take your culture, you start with antibiotics, you start with fluids, you put in your catheter, monitor output, your urine output, you're checking for vital signs, you're checking for serum lactate. Okay. Patient failing initial therapy should be resuscitated more aggressively, e.g. by the use of vasopressors. You don't want to give them so many fluids, then now they have fluid overload. Fluid, you give them boluses, still not helping, start an anatropes. Okay, they might even need blood transfusion in some cases. So they say consider glucocorticoids if treatment refractory hypotension for a relative adrenal insufficiency. You might okay. Look for other causes of shock. Okay, so that's for sepsis. So next we're going to talk about stroke and transient ischemic attack. So what is stroke? Stroke is a sudden loss of brain function due to ischemia. So most common cause of type of stroke is ischemic, correct? Ischemic, which is 87%. Then 13% is hemorrhagic. All right. So you have sudden loss of brain function due to either ischemic or hemorrhagic with a persistent of symptoms for more than 24 hours. Okay. Or neuroimaging evidence. So remember, with stroke, symptoms are persistent for more than 24 hours. With transient ischemic attack, symptoms are lesser than 24 hours. So it's a transient episode of neurological dysfunction from local ischemia without acute infarction or neurological imaging evidence. So remember, for stroke, symptoms are more than 24 hours, or you have a neuroimaging evidence like a CT scan showing ischemic stroke or hemorrhagic stroke. By TIA, the symptoms are usually less than 24 hours, and then you have no evidence of hemorrhage or ischemia on your CT scan. Clinical features, what are the signs and symptoms of stroke? Okay, so signs and symptoms. We are going to go section by section. The first section is general symptoms. So they're going to have decreased level of consciousness, which is usually rare. Change in mental status. They can be confused. Then they can present with language or throat symptoms, where they have aphasia. They actually have aphasia, dysarthria, they actually have swallowing difficulty. They have, it could be vision that is involved, is either the eyes, diplopia, they have double vision, their eye deviations, they are asymmetric pupils, eye field defect. Or they can have coordination symptoms like ataxia, intention, tremors, lack of coordinations. Or they can have motor symptoms like increased tone or loss of power, or sensation, where they have loss of sensation, reflexes, hyperreflexia, or clonus. So those are the symptoms of stroke. So you're gonna do a head to toes examination. Obviously looking at starting on the facial. Okay, all right. Remember, for stroke usually affects the contralateral side. So if it is the left side of the brain that is affected, the symptoms are going to present on the right side of the brain. And then the facial symptoms are usually does not involve the forehead. If it's a fifth nerve palsy, it's going to affect the forehead. But stroke does not affect the forehead. It affects the lips, the tongue. Next is stroke and transient ischemic attack. So stroke is a sudden loss of brain function due to ischemia in 87% or hemorrhagic 13% with persistence of symptoms more than 24 hours or neuroimaging evidence. So transient ischemic attack, usually symptoms do not persist more than 24 hours, and usually there is no neuroimaging evidence of stroke. Okay. So what are the 7 causes of emboli from the heart? So AFMI, endocarditis, valvular disease, dilated cardiomyopathy, left heart, myxoma, prosthetic valves can actually cause emboli within the heart, and then this can actually go and belong somewhere else. So what are the clinical features of stroke? Starting, general, patient can present with change of mental status, confusion, and neglect. They're going to have hyperreflexia or clonus. They're going to have loss of sensation to the affected side. They're going to have an increased tones, loss of power, and then they can present with ataxia as well, intention, tremor, lack of coordination, double vision, eye deviations, asymmetric pupils, visual field defect. If they can also present with dysarthria, aphasia, swallowing difficulty. So basically, patient with hemorrhagic stroke resulting in subarachnoid hemorrhage. So you can have actually a patient who has subarachnoid hemorrhage. Now results in hemorrhagic stroke. So usually they'll have a history of a thunderclap headaches, describing it as the worst headache of their life, and then they can actually recall exactly when the headache started. Now, what are the stroke mimickers? What are the disease that actually mimic stroke? Those are your seizures, and then there's something called thought paralysis. So basically, it's a period of partial or complete paralysis following a seizure. There's also migraines, hypoglycemic, peripheral nerve injury, Bell palsy, tumor, syncope, somatic symptom disorder. Remember with Bell palsy, the eyebrows, the muscle of the eyebrows are actually involved. In which in stroke, it's not involved. All right, so what is the difference between upper motor neuron disease and lower motor neuron disease? Upper motor neuron disease involve a group of muscles. So it's a group of muscles that's affected, for example, like a stroke. And then usually you have increased reflexes, you have increased tone, right? You have usually have decreased power. You have fasciculations is absent, atrophy is usually absent or minimal, and then your plantar response is usually upgoing. In the lower motor neurons, usually we have involvement of only one muscle, so it's an individual muscle disease. And then reflexes are usually decreased or absent, the tone is decreased, fasciculation is present, atrophy is usually present, and then the plantar response is usually downgoing. So stroke syndromes. So the region of strokes, and then the type of symptoms that we have. So if it's the anterior cerebral artery that is affected, patients are going to have contralateral hemianesthesia. So one side of the opposite side. So if the stroke is on the left anterior cerebral artery, the patient is going to have symptoms on the right side of the body, and so basically they're going to have hemianesthesia. So they are going to have impaired sensation, touch and pain, and temperature on that side. They're going to have hemiparesis, and usually in anterior cerebral artery is the leg. The leg is more paralyzed compared to the arm and the face. Then they're going to have also gait, apraxia, altered level of altered mental status, and impaired judgment. If it's the middle cerebral artery that is affected, they're also going to have contralateral hemianesthesia. They're also going to have hemiparesis, but in this case, the face and the arm is more paralyzed compared to the legs. They're also going to have contralateral homonymous hemianopsia. Sorry, this word is kind of difficult. And also ipsilateral gaze. Okay. So basically, as you can see the structure down here, they're going to have blindness on one side of the eye. Okay, so it's not both eye that is affected. So both eyes are affected, but basically it's on one side. So each corner. So posterior cerebral artery, it's a patient, if it's a posterior cerebral artery, patient present with contralateral homonymous hemianopsia, cortical blindness, and impaired memory. Because remember, this is the occipital lobe that is affected. So cortical blindness, the blindness will be a total blindness as well, and impaired memory. If it's a vertebrovestibular artery, you're thinking about cranial nerve, your cerebella, because that's where your cerebellar arteries branches from. Thinking about the brainstem itself, right? So you're gonna have symptoms like vertigo. They can present, so they're not going to present with weakness of the arms or the legs, but they are actually going to present with things like vertigo, nystagmus, diplopia, double vision, visual field deficit, dysphagia, dysarthria, facial hypoesthesia, syncope, ataxia, loss of pain and temperature sensation on the ipsilateral face, and contralateral body. Okay. So they're not going to have all the symptoms of cerebral artery. Okay. So next, what will be the investigation? You want to do a CBC electrolytes, blood glucose coagulation studies, cardiac biomarkers, toxicology screen is important, CT angiogram, you want to do that, and perfusion of the head and neck, ECG, just to find out whether the cause of the embolus is from the heart. For patient who had transient ischemic attack, you can you can do a follow-up with actually your thoracic Doppler, your outpatient CT angiography actually. Okay, so if a patient present within 4.5 hours of onset of disabling neurological deficit, more than 60 minutes with no signs of resolution, they may be a candidate for thrombolysis. Okay, so do a brief assessment and order CT head ASAP. So how would you manage a patient that you're suspecting to have a stroke? First, it's your ABC. Okay, you might need to intubate, especially if GCS is lower than 8 or they're actually rapidly decreasing in GCS or inadequate airway protection reflexes. You might actually need to intubate this patient. So for ischemic stroke, actually what you need to do for this patient is that if they present lesser than 4.5 hour from the onset of the symptoms of a stroke, you can actually start them on alteplase, for example. So they will present the symptoms of stroke Once you have stabilized the patient, you send the patient for a CT scan, and then if it's ischemic stroke, you immediately want to assess are they eligible, and then are they is it lesser than 4.5 hour? If yes, then you can actually want to use your thrombolysis, like Actoplace, as long as there is no evidence of hemorrhagic stroke on the CT scan. Okay. Then you can also use thrombectomy. It says thrombectomy may be an option in some centers as an alternative to thrombolysis. The first thing you want to try and do is thrombolysis within 4.5 hour, 4.5 hour. Uh, but you can use thrombectomy that can be used in some centers, which is an alternative to thrombolysis in the first 4.5 to 6 hour. And in some instances, up to 24 hours after symptoms onset or last seen normal. Okay. But the first option will be thrombolysis. Some center can now use thrombectomy. So next, you want to give the patient your dual antiplatelet therapy for 21 days. So this should be initiated for high risk, a patient with high risk of transient ischemic attack in the ED. So clopidogrel, for example, you're going to give that for 21 days. So elevating the head of the bed if suspicious of increased intracranial pressure. Also elevate the head just to prevent aspiration or worsening of cardiopulmonary status. NPO, give the patient NPO. You want to put an IV line. You want to put your cardiac monitors. So judge the fluid rate carefully because you want to avoid overhydration because you can actually cause cerebral edema, as well as you don't want to under dehydrate them as well. You want to keep them well perfused. So BP control only treats severe hypertension if the systolic blood pressure is more than 200, if the diastolic blood pressure is more than 120, and if the MEP is more than 140. And remember, with ischemic stroke, you want to decrease the blood pressure gradually over even a period of 5 days. So hypertension associated with hemorrhagic stroke transformation. So if so remember to treat your hypertension. What are you going to treat hypertension with? Labetalol. What else can you use? IV nitroprusside, but it's not found in Canada. Glycemic control. Make sure you check your glucose and you make sure the glucose control is between 7.8 to 10. Cerebral edema control. What can you do? Hyperventilation. Mannitol to decrease intracranial pressure if necessary. Consult neurosurgery, neurology, and medicine as indicated. So after all you have managed this patient, following an acute ischemic event, what is it that you would do? So you can give them antiplatelet agent to prevent recurrence of stroke or to prevent TIAs. So you're going to give them aspirin as first line, clopidogrel. Okay, so you're going to give them aspirin, clopidogrel, a second line. Okay. So consider anticoagulation if AFib present or if immobile, the patient is not moving. You might need to consider DVT prophylaxis. Okay, especially if the patient is going to be bedridden, you want to prevent further clot formation. So you're going to give DVT prophylaxis, and then you want to follow up considerations. You need to might consider a cardiac Doppler. So an absolute exclusion criteria for tissue plasminogen activator. So what is exclusive criteria? So this is important. So remember, a patient is presenting to you suspecting of a stroke. You have stabilized them or intubated them, and then now you want to decide, okay, it's still lesser than 4.5 hours since he was last normal. So you want to consider thrombolytics. So these are actually your tissue plasminogen activator. Example is alteplase. So actually, what is the absolute contraindication for this? Number 1 is going to be suspected subarachnoid hemorrhage. Number 2, previous intracranial hemorrhage. 3, cerebral infarct or severe head injury within the past 3 months. A systolic blood pressure of more than 185, diastolic blood pressure more than 110, a bleeding diastasis, a prolonged PT more than 15 seconds, or an INR more than 1.7. Platelet count less than 100,000. Heparin received within the last 48 hours. And current use of a thrombin inhibitors or a direct factor 10A inhibitor. Blood glucose less than 2.8 moles per liter. An intracranial hemorrhage on a CT or a large volume infarct. So these are absolute contraindication. The other relative contraindication are only minor or rapidly improving symptoms if they are pregnant, if there's GI or urinary hemorrhage within the past 21 day, seizure and onset causing post-ictal impairment. Okay, so you need to take into consideration the absolute contraindication. So next we're going to talk about otolaryngal emergencies and presentations. So first, ear symptoms. Patient can present ear symptom otalgia, oral fullness, otorrhea, hearing loss, tinnitus, vertigo, pruritus, fever. So what are the risk factors for hearing loss? Is number one, Q-tip use for trying to clean the ear and stuff. Hearing aids, earphones, occupational noise, exposure. Those are the risk factors for hearing loss. So dizziness and vertigo. So you need to distinguish between the types of dizziness. So first one is vertigo, which means the room is spinning. Then second one is lightheadedness, mean disconnected from the environment. Third one is presyncope, which is almost blacking out. And then disequilibrium means unstable or off balance. So those are the four type. When a patient comes to you and then they tell you, I feel dizzy. So you want to know which type of dizziness are you having? Is it a vertigo? Is it lightheadedness? Is it presyncope? Is it disequilibrium where you're feeling unstable or off balance? All right. So you need to try and rule out a stroke and consider advance any drugs event. You want to know what drugs are they on, what medication are they taking. So otalgia, the causes of ear pain can be due to infection, okay, such as acute otitis media, otitis externa, or it could be others like trauma or neoplasm, foreign body. Okay, so you want to, if there's any discharge from the ear that is present, you want to do culture sensitivity for that. You want to do a CT scan if if suspicious of myocarditis, or if there's you suspect any malignant otitis externa. And then, depending on the cause, either give antibiotics, antifungal, antiviral for respective treatment. So, hearing loss, you want to differentiate, is it conductive hearing loss or sensory neural hearing loss? You can do your Weber test or your Rene test, or using a tuning fork. So you want to rule out sudden sensory neural hearing loss. So sudden sensory neural hearing loss is an emergency. So it's an emergency and it requires high doses of steroid and urgent referral. Okay. So an elderly patient presenting with unilateral tinnitus or a sudden sensory neural hearing loss must be presumed to have an acoustic neuroma known as the vestibular schwannoma until proven otherwise. Okay, so remember, sudden sensory neural hearing loss, you want to give them steroids and refer urgently. Patient and elderly presenting unilateral tinnitus or sensory neural hearing loss, you must think about your acoustic neuroma. Okay. Consider angiogram and referral to or follow up to a family physician. So remember, we're looking at emergency medicine. So what do you do in emergency settings? Epitaxis, 90% of nosebleed actually is from the anteronasal septum. So it's known as the clear cell batch plexus located in the little area. So it can actually be life threatening. So 90% is from the little area. So most cases of epitaxis are caused by trauma, for example, digital by the patient fingers, blunt or foreign body. And other causes are barometric changes, nasal dryness, chemicals like cocaine, Otrivin, or systemic disease like patient has hypertension, coagulopathy. That can also cause us. But the most common cause of epitaxis is trauma. Then other causes, hypertension, coagulopathy, chemicals, nasal dryness. So obviously you want to do a blood workout. You want to see is it maybe a coagulopathy cause. So you will see CBC, PT, PTT, RNR, platelet function, assay. If you are suspicious of any bleeding disorder as needed, imaging as well, X-ray, CT scan as needed if you're thinking about trauma. So what's the treatment? The goal of the treatment is to localize the bleeding and achieve hemostasis. Okay. So first aid, what's the first thing you want to do? First aid is going to be ABC, right? Airway, breathing, and circulation. Then you clear the clot, right? By blowing. You ask the patient to blow their nose. They need to blow their nose to clear the clot. Or if they can't, then you suction it. Okay. They need to lean forward. Okay. Then you pinch the cartilage portion of the nose for 20 minutes twice. Okay, so best to actually use a compressive device and not the patient fingers. So ABC, clear the clot or suction out the clot. The patient leans forwards, and then now they need you pinch the cartilage portion of the nose for 20 minutes twice. Then want to assess blood loss by checking your vitals. If severe bleeding or unstable bleeding, you want to put in an IV, start with fluid. You might actually need to give this patient blood transfusion. So if the first 8 measures, remember if the first step is not works, it fails, then proceed to packing. So how would you prepare your packing? So apply an anterior pack. So first of all, you want to clear the nose of any clots, and then apply a topical anesthesia or a vasoconstrictors. So you will apply lidocaine with epinephrine, even cocaine, or soaked plaget. Then you insert either a traditional Vaseline gauze pack or a commercial nasal tampon or balloon. Okay, so important if the site of the bleeding is identified, cautery with silver nitrate can be performed as an alternative to packing. So make sure you only cauterize one side of the septum, because if both are cauterized, this can lead to septal perforation. So if bleeding stops, arrange follow up in 48 to 72 hours for reassessment and pack removal. If packing both noses, so you might need to give them prophylactic Staphylococcus antibiotics to prevent sinusitis or toxic shock syndrome. Okay, so you might actually need to give them prophylactic Staphylococcus antibiotics. So if you suspect posterior bleed or anterior packing does not provide hemostasis, then you need to consult ENT for posterior packing and further evaluation. Okay. So admission, severe case, you need to admit if the bleeding is not stopped, and if it's a posterior packing, then because you need to consult your ENT. So what is a complication of a nasal packing? Is that you can cause hypoxemia, you can cause toxic shock syndrome because of your staphylococcus. You can cause aspiration, you can cause pharyngeal fibrosis or stenosis. You can cause septal necrosis or Alice necrosis. So those are the complications of a nasal packing. So thrombocytopenic patient. So use a resorbable pack to avoid the risk of rebleeding. So you can actually use reabsorbable pack to avoid rebleeding caused by pulling, because if you're pulling out the removable pack, patient with thrombocytopenia, they can actually start rebleeding again. So if you, in this case, you have to use reabsorbable packs. Next, gynecological and urologic emergencies. The pregnant patient, so unless proven otherwise, all females patients of a childbearing age, think about pregnancy. Okay. Should always assume to be pregnant or to have an ectopic pregnancy, either of the two. Okay, so basically, first trimester they can present with ectopic pregnancy, abortion. Second or third trimester can be due to uh, uh, placenta previa, placenta rupture. So remember, some patients in the first and second trimesters can actually have something they call a friable cervix. Okay, where they will just be spotting. Usually, those are the most common cause, and they will just be spotting, but because of all the vasculature around the cervix, they're actually spotting, but everything is actually normal. So, so there can also be postpartum, presenting with vaginal bleeding postpartum. So the causes of postpartum hemorrhage remember your 40, your tone, uterine atony, tissue, retained placenta, trauma, laceration, or uterine eversion, and thrombin coagulopathy. Okay, so non-pregnant patients, think about why the other causes of vaginal bleeding if they're not pregnant. Structural things like use a mnemonic palm, P for polyps, A for adenomyosis, L for leiomyoma, M for malignancy or hyperplasia. All right. So for non-structural causes, you do the mnemonic squain. So if the patient is not pregnant, you're now thinking, is this structural causes or is it non-structural causes? Okay. So structural causes, you use the mnemonic palm. Non-structural causes is mnemonic coin. So C for coagulopathy, O for ovulatory, E for endometrial, I iatrogenic, and N not yet diagnosed. Okay. So obviously the history you want to ask them the frequency, duration, number of pads used, tampons, type of pads used, cyclicity, what is the cycle like, is there any pain involved if present? So menstrual history, sexual history, STIs history, syncope, syncope, malignant history, family history, hematological history, cardiac history, abdominal history, history of previous ectopic pregnancy, smoking history, intrauterine device, any use of COPD, oral contraceptive. So detail of the history, including gush of fluids or fetal movement, especially if they're more than 20 weeks. Okay, so basically physical examination, you're gonna always make sure your ABC. You do your abdominal exams, speculum exams. So basically, bimanual examination is not should not be done in the second and third trimester bleeding, as it may worsen the bleeding. So perform only if the placenta previa has been ruled out with an ultrasound. That's when you can actually do your bimanual exam. So vaginal bleeding can be life-threatening. Always start with your ABC and ensure your patient is stable. Ectopic pregnancy can be ruled out by confirming an intrauterine pregnancy on a bedside ultrasound unless the patient is using an in vitro fertilization due to the associated risk factors. So always first investigation, every patient childbearing age, you're gonna present him with vaginal bleeding. You're first gonna do a beta ECG. Then you can do every other blood, your CBC, blood group, RH level type and cross if significant blood loss, then transvaginal ultrasound or abdominal ultrasound. Okay, then you basically treat the cause, you treat the underlying cause. Okay, so if it's a postpartum woman, you are going to do your ABC, start with 2 large bore, IV, rapid infusion. You can actually type and cross 4 units of blood, consult obstetrician immediately. So for uterine atony, what are you going to use? So uterine atony, you're going to use oxytocin 10 unit IM, or 40 unit in 1 liter, widely open until the uterus is firm. Okay, so if it's just the atony, remember to also do uterine massage. Okay. Genital tract trauma, visual inspection and repair, retain product of conception. You do your bimanual and speculum. Okay, so just based on the cause, you would treat accordingly. Okay, so renal colic. So 10% of the population, twice as common in male, recurrent 50% at 5 years, and the peak is between 30 to 50. A patient presenting with kidney stones. So what are the most kidney stones that we have? 80% of kidney stones are caused by calcium oxalate. Okay, 10% is caused by trivite, 10% is also caused by uric acid. Okay. So what are the clinical features? So patient can have urinary obstruction where you have leading to upstream distension of the ureter or collecting system, leading to severe colicky pain. All right. So the stone is obstructing the urine flow, and then this causes accumulation as well of accumulation of the fluid upstream in your ureter or collecting system, and this causes the severe colicky pain. So may complain of flank pain. Okay, so usually they present with flank pain radiating to the groin of the penis. Okay, so they can present with flank pain, groin pain, testis involved, the tip of the penis involved as well. They can also have nausea, hematuria. 90% of patients present with microscopic hematuria. They can present with diaphoresis, tachycardia, tachypnea. Occasionally, symptoms could be of frequency of urgency. They can also have fever if infection is involved. Chills, rigor, if they in a secondary pyelonephritis. Okay. So peritoneal findings or anterior abdominal tenderness are usually absent. If present, consider renal pelvis rupture or other causes. So if there's obstruction and infection, patient have obstructive symptoms, and then now they also have fever. It's a urological examination. Emergency. So it's an emergency. So you need to urgently consult urology, give IV fluids, and start broad spectrum antibiotics. So differential diagnosis to renal stones could be an acute ureteric obstruction. It could be your gallbladder obstruction, pancreatitis, diverticulitis. Could be an ectopic pregnancy, torsion and rupture of the ovarian cyst. Could be pyelonephritis. It could be radiculitis. Okay. L1 due to herpes zoster or nerve root compression. So what is the indication for admission to the hospital with a patient presenting with renal stones. So if they have intractable pain, if they have fever which suggests infection or other evidence of pyelonephritis, if they have a single kidney with urethral obstruction, you want to admit them. If they have bilateral obstructing stones, so the both kidneys are obstructed with stones. If they have intractable vomiting because they're losing fluid, you need to admit them. Compromised renal function, you need to admit them. Okay. So obviously investigation, we do a CBC, you want to check for fever, signs of infections, electrolytes, creatinine. You want to assess the renal function. You want to do your urinalysis, want to check for your routine and microscopic. So you're checking for any white blood cell count, red blood cell count, for hematuria and crystals. And you also do culture and sensitivity of the urine. So non-conscious CT scan is actually the study of choice. It has better specificity and sensitivity. Consider abdominal ultrasound in female of childbearing age, also in children, or if patient has another contraindication to CT scan, because ultrasound can actually help demonstrate stones or hydronephrosis or debris in the collecting system. Abnormal renal parenchyma. So you can also visualize that on ultrasound. So abdominal X-ray will identify large radio-opaque stones. So if the patient has large radio-opaque stones such as calcium stone, trivide stone, or cystine stones, they can actually be seen on abdominal ultrasound. But you actually may miss smaller stones or uric acid stones or stones overlying the bony structures. Considered as initial investigation in patients who have a history of radio-opaque stones and similar episode of acute flank pain, just to rule out. Alright, so you can start with abdominal X-ray. Then how do you manage this patient with renal stones? You want to give them analgesia. So NSAID, usually you will give them ketorolac, also known as Toradol. So it's actually preferable, since an NSAID is preferable over opioids. You also want to give them antiemetics, IV fluid if indicated. You want to do a urology consult, especially if the stone is more than 5 millimeters, or if the patient has signs of obstruction leading to renal dysfunction or infection, then you consult your urology. You can actually give them alpha blockers. Example is your tamsulosin. Tamsulosin. I don't know what's wrong with me and drugs. So alpha blocker tamsulosin may be helpful to increase stone passage in selected cases. Okay. Tamsulosin. So most patients can actually be discharged. So if they don't have any of the following, they can actually be discharged. If they don't have any intractable pain, if they don't have any fever or signs of pyelonephritis, if they don't have just a single kidney, and there's no bilateral obstructing stones in both kidneys, or intractable vomiting or compromised renal function, then they can actually be discharged. And obviously they'll go home and drink a lot of fluid and whenever they go to the toilet to urinate, they try and look for the stones. But make sure the patient is stable when you're discharging them. Make sure they have adequate analgesia and able to tolerate oral medication. You may advise hydration and limitation of proteins. So how are you going to advise them? You're going to advise them keep hydrated, avoid proteins, sodium, oxalate, and alcohol intake. Because remember, that can precipitate more stones. Next, we're going to talk about ophthalmologic emergency. So history and physical exam. So a patient may complain of pain, tearing, itchy eye, redness, photophobia, foreign body sensation, trauma. So mechanism of foreign body insertion. So usually if high velocity injury is suspected, let's say a patient was welding, is a welder, or was doing metal grinding, was doing striking metal, then you need to suspect a foreign body, and you must obtain an orbital X-ray, orbital ultrasound, or a CT scan to actually exclude the presence of an intraocular metallic foreign body. Okay. So ask about sexual partners. Are they having the same symptoms? You want to ask them about exposure to eyes. Has the eyes been exposed to body fluid like semen, urine, blood, vaginal fluids, saliva? You want to do visual acuity in both eyes. Check the pupils, extraocular structures, extraocular movement, fundoscopy, tonometry to check for the pressure, intraocular pressure. You want to do your slit lamp exam, visual field. So what are the contraindications to pupil dilation? So when are the cases where you will never dilate the eye for examination? So if you have a shallow anterior chamber or iris supported lens implant, if potential neurological abnormalities requiring pupillary evaluation, or there is caution with cardiovascular disease such as midriatics can cause tachycardia. So those are contraindication to the pupil dilation. So how would you management of an ophthalmologic foreign body? So for a chemical injury, so you will irrigate the eye with normal saline, right? For any foreign body. So then removal of the foreign body under a slit lamp exam with cotton swab or sterile needle or electric burr tool. Then you want to give them antibiotics if indicated, especially if it's organic foreign body. Let's say patient was welding, was grinding, was striking the metal. Okay, don't forget to do your x-rays or CT scans or ultrasound just to exclude the presence of intraocular foreign body as well. And then make sure if the foreign body is visible, then you have to remove the foreign body under a slit lamp exam, and then give them antibiotic drops. So patching may not improve healing or comfort, so do not patch contact lenses wearers. Limit use of topical anesthetics to examination only, and don't forget your tetanus prophylaxis. And they need to have an ophthalmology to see them later on after discharge. So what are the differential diagnosis of a red eye in an emergency department? So if the patient has a red eye and light sensitive, think about iritis, keratitis, abrasion, ulcer. If they have a unilateral red eye, think about the above: iritis, keratitis, abrasion, ulcer, also herpes simplex or acute angle closure glaucoma. So if they have significant pain and is in the eye is red, think about chloritis as well, the same as abrasion, ulcer, keratitis, iritis. If they have a white spot on the cornea, then think about corneal ulcer. If they have a red eye and then it's with a non-reactive pupil, so you are actually putting the light, but then instead of the pupil to constrict, it's not. So think about an acute glaucoma or iritis. If there is a discharge, red eye, the discharge, think about gonococcal conjunctivitis. Right. Alright, so let's think about what are the causes of painless vision loss. Patient comes to you, they complain about painless vision loss. So you would think about central retinal vein occlusion. You think about amaurosis vagus. Occipital stroke can actually cause painless vision loss. So what is amaurosis vagus? Remember, this is an emergency where the patient has temporal sudden loss of vision or in one eye. So basically, it's a brief painless vision loss in one eye due to a transient retinal ischemia. So the vision loss lasts for seconds to minutes, and often the patient will describe this as a curtain coming down. Vision, and then the vision fully returns. If a patient presents such, then you think about amaurosis vagus. So what are the common causes? Your carotid artery emboli due to atherosclerosis, cardiac emboli. So these are the warning signs, indicate increased stroke risk and needs urgent referral. So next, what are the selective ophthalmologic emergencies? So we're gonna first look at acute angle closure glaucoma. So if you have a patient is suspecting an acute angle closure glaucoma, patient usually present with unilateral red eye that is very painful, and they will have a blurry vision, and they will also describe as seeing rainbows around light, so your halos around light. And usually they have a mid-dilated pupil, nausea and vomiting. They have increased intraocular pressure. So when you're using your tonometry, they usually have the intraocular pressure is really more than 40 milligrams of mercury. Okay, so basically, acute angle closure glaucoma is actually when the iris blocks fluid from draining, and because of that, the pressure in the eye increases. The patient starting having pain and redness, decreased vision, blurriness. Okay, so how would you manage this? You will consult ophthalmology for a laser iridotomy, because remember, it's the iris that is blocked, that blocks fluid from draining. So medication that can actually help to decrease the pressure immediately while you're waiting for the ophthalmologist. Number one is your alpha agonist, epinephrine, your alpha 2 agonist, apraclidin, beta blockers, timolol, your cholinomimetics such as your pilocarpine, your diuretics like your acetazolamine, your mannitol, or your latanoprost. So these are actually medication that can actually help you decrease the pressure while you're waiting. So epinephrine, tamilol, your pilocarpine, your acetazolamine, your mannitol. So next, patient can present with corneal abrasion. So a patient presenting with corneal abrasion ulcer, they usually have like a painful red eye, tearing of the eye, and the sensation of a foreign body, because they can also have a white spot on the eye. And then what happens is that when you put the fluorescent dye, it will show areas of de-epithelialization. So where the epithelium is off because of the abrasion, the dye actually will stain the area. Okay, so most management, so most patient with corneal abrasion spontaneously it clears off within 24 to 48 hours. Due to If it's due to foreign body, then remove the foreign body. You want to remove the foreign body under local anesthetics and with steroid needle, and you can also consult ophthalmology for removal under magnification. Then you give topical antibiotics or drops or ointment, and then you're also gonna give tetanus prophylaxis. So what about chemical burns? So if the patient has a known exposure, they will tell you, okay, I was exposed to acid or alkaline. So alkaline exposure is actually worse. They usually have pain, decreased visual acuity, vascularization or defect of the cornea, iris, and the lens. Can also actually damage the lens. So first of all, you want to irrigate the eye at the side of the of accident with normal saline with the eye retracted until you have a neutral pH achieved. Okay, and then sweep the fornix, and then you can actually give this patient your cycloplegic drops. So cycloplegic drops or atropine drops actually helps with inflammation. Then you can also give them topical antibiotics. So orbital cellulitis usually will present with a very red, painful eye, decreased visual acuity. Also have fever and headaches. The eyelid is red. There's edema, swelling of the eyelid. They actually have difficulty opening the eyes. They can also have conjunctival injections, chemosis, proptosis, ophthalmoplegia. They can also have a relative afferent defect, also known as the Marcus-Gunn pupils, where the pupils dilate and instead of constricting when exposed to light. So a patient with orbital cellulitis needs to be admitted. You have ophthalmology consult. You want to do blood culture, orbital CT scan, IV antibiotic, ceftriaxone plus vancomycin, and drainage of the abscess. Next, retinal artery occlusion. So if the retinal artery is occluded, patient will have a sudden, painless, monoocular vision loss. And then they're also going to have relative afferent defect. So for retinal artery occlusion, they will have a cherry red spot. Okay, so if you check down here, you will see on the right hand side, you have a cherry red spot. Okay, but then for your retinal vein occlusion, it's also painless. It's a sudden vision loss as well, and then so patient has painless the eyes. Okay, so it's just painless but sudden vision lost, seconds to minutes, and then now when you check your fundoscopy for retinal vein occlusion, you will see blood and a tender appearance. So okay, so yeah, you have swelling of the. So it could either be central retinal vein blockage, or it could be a branch retinal vein blockage. So if it's central retinal blockage, that's when you're gonna have bleeding spot in the retina due to increase in back pressure because it's blocked. So you're gonna have bleeding all over the retina, and then also swelling of the macula, so causing a decreased vision, right? But then if it's just a branch that is blocked, So bleeding spot in the retina will be on one side, and then swelling as well will be on the side where there is the vein blockage. Sorry, excuse me. So next we're going to talk about dermatologic emergency. The first one looking at is your diffuse rash. All right, diffuse rash. So, and then later on we're going to talk about discrete lesions. All right. So under this diffuse rash, the first one we have is your staphylococcal scalded skin syndrome. So it's caused by an exotoxin from infecting strain of the coagulase positive Staph aureus. Right, it mostly occurs in children and usually starts with fever. You have signs of fever, irritability, malaise, and skin tenderness, and then with sudden onset of diffuse erythema. So the skin is red all over the skin, as you can see the picture right down here. The skin get red and warm and very tender, okay, rapidly. Then later on, it proceeds to have this flaccid bullae that are difficult to see. Then they squamate into large sheets, right? So as you can see, you have that peeling off. So that's the desquamation on the skin. Alright, so the next one is your Steven Johnson syndrome, SJS, and your toxic epidermal necrolysis, so 10. So these two diseases are caused by drugs. Alright, so the patient will have a history of drugs, such as either, for example, are your phenytoins, your sulfurs, your penicillin, your NSAID. It could also be due to bone marrow transplantation. It could be due to blood product transfusion. And this is usually found occurs in adult. So here you're going to have a diffuse erythema followed by necrosis. So start with erythema, then necrosis, severe mucosal membrane blistering, and the entire epidermis desquamation. Okay, so it's a little bit similar to your Staphylococcus scalded skin syndrome, but the thing with Staphylococcus is that it's mostly found in children, and then this one is more found in adults, and they usually have a history of drugs. Okay, high mortality, more than 50%. So the next one is your DRESS syndrome. So it's a drug reaction with eosinophilia and systemic symptoms syndrome. So DRESS. Okay, so it presents 1 to 6 weeks after the first episode of drugs. So after the patient has taken the drug, it presents 1 to 6 weeks later on and persists for weeks after the withdrawal of the drug. So even after you have stopped the drugs, patient still persists having those the symptoms. So you have your mobiliform rash. So in this one is more the rash compared to the previous one we spoke about, where you have more erythema. Here's more a rash involving the face, the trunk, and the arms. You also have systemic features, such as fever, malaise, cervical lymphadenopathy, internal organ of involvement. So such as hepatitis, arthralgia, nephritis, pneumonitis, lymphadenopathy, or hematologic abnormalities or thyroid abnormalities can be present as well. Next, we're talking about toxic shock syndrome. It's caused by your super antigen from the Staph aureus or group A streptococcus activating T cells and cytokines. So your Staph aureus and your group A streptococcus causes an activation of T cells and your cytokines, and then this causes an inflammatory reaction. So the patient often presents with onset of shock and multiple organ failure and fever. They get this diffuse erythematoid macular rash. And then at presentation, at least 3 organ systems are usually involved. It could be your central nervous system, respiratory, the GI system, muscular, the mucous membrane, retinal, liver, hepatologic, and skin. So they can have also necrotizing fasciitis or gangrene at presentation. All right. So usually you have like 3 organ systems that are involved. Then you can also have this vesicular bilious lesions, as you can see here. Those are the skin manifestation. So usually, what is it caused by? Usually, the patient will have maybe the history of tampons used. That's the most common. Surgical wounds, or the history of burns or infections. Okay, and then now, this bacterial infection, your Staph aureus and group A streptococcus, then invade the skin or the air, and then makes the patient present then with the symptoms. The next one is erythema multiforme. As you can see, that's the diagram on the right side. So it's commonly caused by herpes simplex. So it's less common cause are your mycoplasma pneumoniae, drug induced. So usually the patient will have previous symptoms of a viral infection. Okay, so like 1 to 14 days before the rash. So target lesions. So usually you have a central gray bullae, or it's a central gray or a well surrounded by concentric rings of erythema and normal skin. And if mucous membrane involved, then may have difficulty in oral intake. So there's erythema multiforme, mostly caused by herpes simplex virus. Now, next we're going to talk about discrete lesions. Number one is your pyoderma gangrenosum. So this one is has an unclear pathogenesis and may be due to neutrophil dysfunction, genetic predisposition, or immune dysregulation, often associated with inflammatory bowel syndrome, rheumatoid disease, leukemia, monoclonal gammopathies, and often occurs in the arms, the hands, the feet, and all the regional area. So it usually begins as a painless macrovesicles pustules or bulla on a red or blue base, and then starts slouching, leaving a gangrenous ulcer, as you can see on the right side. Next, disseminated gonococcal infection. So patients present usually with fever, skin lesion, such as your pustule vesicles on erythema base, approximately 5 millimeters in diameter. So they're going to have so it's fever, skin lesion, arthritis, where you have joint swelling and tenderness, and septic arthritis in larger joints such as the knee, the ankles, and the elbow. So most commonly in a gonococcus positive woman during menstruation or pregnancy. And skin lesion usually appears in the extremities and resolve quickly in less than 7 days. Next is your meningococcemia. It's a gram-negative bacterium Neisseria meningitis caused by flu-like symptoms of headaches, myalgia, and nausea and vomiting. There are potential macular or maculopapular lesions with gray vesicular centers, usually a few millimeters in size, but may become confluent and hemorrhagic. Usually appears in the extremities, but may appear anyway. So look for signs of meningeal irritations like a positive jolt accentuation test, Koenig sign, Brzezinski sign. Right, so for this emergency, first of all, remember you want to have a history, you want to do a physical examination, determine the onset, the cause, the duration, location of the skin lesion, is there any fever, joint pain, what are the associated symptoms, central nervous system, respiratory system involved, any history of medication, sexual encounters, living environment, occupational exposure, vital signs. Then you do also a physical examination based on the relevant history. So investigation is case dependent, considering you might need to know your CBC, electrolytes, your liver function, blood culture, skin biopsy, serum immunoglobulin levels. And how would you manage this patient? The general management for all of this skin lesions, you first want to do IV. You need to give them IV fluid and electrolyte control. Consider vasopressors if hypotensive, prevent infection. If patient unstable, immediately you need to consult and admit the patient. You might consult dermatology or skin or infectious disease or allergy or immunology, plastic surgery. Specific management is determined by the cause. So in case where a patient presents with your SSS, your TSS, and your TGI, your meningococcemia, you give them IV antibiotics. Patient presenting with TENS, stress syndrome, SGS, EM, usually you need to start a precipitating medication, give them fluid. And then symptomatic treatment, antihistamines, antacids, topical corticosteroid, systemic corticosteroid, prophylactic oral cyclovir, and consider IV immunoglobulin, your plasma pheresis. So for TENS, you're going to debride the necrotic tissue. For EM, you're going to treat the underlying cause, provide supportive care and management support, and may actually need admission. So basically with SJS, okay, so just to remember that SJS stands for Stevens-Johnson syndrome, okay, and then TENS stands for toxic epidermal necrolysis. So for SJS, usually affects less than 10% of the body surface area, of which 10 affects more than 30% of the body surface area. And then if in between 10 to 30%, it could be both or either of the two. Next, we can talk about environmental injuries. So heat exhaustion and heat stroke. So heat exhaustion is a clinical features related to loss of circulating volume caused by exposure to heat stress. So usually water depletion, Heat exhaustion occurs if loss of fluid, not adequate replaced, and is not adequately replaced. Maybe it could be due to very hot weather. And salt depletion, there is heat exhaustion occurs when loss is replaced with hypotonic fluid. So heat exhaustion may closely resemble heat stroke. Heat exhaustion may eventually progress to heat stroke. So if the diagnosis is uncertain, treat as a heat stroke. So we spoke about heat stroke. So usually it's because of, heat exhaustion is usually due to loss of circulatory volume caused by exposure to heat stress. So you have a heat stress in the hot weather, and because now you have loss of circulatory volume, that results in a heat exhaustion. Now heat stroke, now it's the most important one because it's a life-threatening emergency resulting from failure of the normal compensatory heat shading mechanism. Okay. So it's divided into classical and exertional subtype. So you can see as classical heat stroke, exertional heat stroke. So if patient does not respond relatively quickly to cooling treatment, consider other possible causes of hyperpyrexia. Let's say meningitis, thyroid storm, anticholinergic poisoning, delirium tremens, infection, adverse drug event. So this can actually be your DDs. Okay, your differential diagnosis to heat stroke. So if you are giving all the cooling mechanism and if the patient still does not stabilize, so you have to look for other causes. So first of all, we're going to talk about heat exhaustion clinical features. So patient present with non-specific symptoms like malaise, nausea, headaches, fatigue, and temperature is usually lesser than 40 degrees Celsius. So lesser than 40.5 degrees Celsius. Usually the temperature is normal. There's no coma, there's no seizure, but there is dehydration. So the patient is dehydrated, so the heart rate is high, they're hypotensive, and then with the treatment with heat exhaustion, usually it's rest in a cooling environment. You can give them an IV normal saline if they have orthostatic hypotension. Otherwise, replace losses slowly per os with salt and electrolyte solution. Okay. So now we're going to talk about heat stroke. The first one is your classical heat stroke that occurs in settings of high temperature. So let's say if there's a heat wave or there's poor ventilation, that's when this occurs. So often patients are usually older patient and sedentary or immobile. They're either oldish, usually in not mobile a lot. They may be bedridden and they present with dry, hot skin. And the temperature is usually more than 40.50 degrees. And remember, you're going to have a history of a heat wave or poor ventilation. And they're going to have an altered mental status. They can have seizure, delirium, or coma, and may have an elevated AST and ALT. All right. So that's the classical heat stroke. Then the exertional heat stroke usually occurs in high endogenous heat production. Let's say the patient was exercising. That overwhelms the homeostatic mechanism. Usually patients are often younger, they are more active, the skin often is diaphoretic, so they're sweating, and other features as for the classical heat stroke, but may also have your DIC, acute renal failure, your rhabdomyolysis, because they're very active, and a marked lactic acidosis. So your classic stroke usually found in adult, elderly patients that are not mobiles, they may be bedridden, and then now because of there was a history of heat wave or poor ventilation, and they're presenting with this hot skin, dehydration, the delirium, and all of that. And then exertional heat stroke, as the word says, young athletic patient presenting now with symptoms of increased temperature, and then you have other organ system involved. Now, how would you manage both of the heat stroke? So remember, it's an emergency. You want to cool the body temperature with water. So you can actually use a bottle spray of water and then sprinkle the patient with that, and then have a standing fan. So that's the first thing. So cool the patient. Next, ice water immersion, also effective. So that if there's any ice water available, that can work. Monitor body temperature closely using your rectal thermometer to avoid hypothermic overshot. All right, and then secure the airway because of seizure and aspiration risk, and give fluid resuscitation if still hypotensive after the above therapy. Avoid beta agonist. All right, epinephrine. Avoid your peripheral vasoconstriction. Avoid your antipyretics. Okay, so it means cooling. Just try and cool the body. Okay, so next we're going to talk about hypothermia and cold injuries. Hypothermia is defined as a core temperature below 35 degrees Celsius, and in which the body heat loss is greater than the heat production. Okay, so what are the causes? It could be due to increased heat loss, e.g., environmental exposure, decreased heat production, for example, your endocrine disease, impaired regulation due to central nervous system failure. So, what are the precipitated risk factors? One being alcohol use, homelessness, psychiatric disease, and older age. So, older adults have increased risk due to decreased physiological reserve, chronic disease, medication side effects, and social isolation. So, treatment is based on rewarming and supporting the cardiovascular function. So, what are the complications of hypothermia? Coagulopathy, yes, acidosis, dysarrhythmia, your AFib, VFib, profound bradycardia, asystole, and volume or electrolyte depletion. Okay. So you do your lab studies. Obviously, you're gonna do your CBC electrolytes, VBG, serum glucose, creatinine, your magnesium, calcium, amylase, coagulation profile, troponin, lactate, plus or minus beta ECG if it's a female. So imaging, X-ray, because of risk of aspiration pneumonia and pulmonary edema are common. Okay, very interesting. So monitors you do your ECG because you want to try and prevent any dysarrhythmias. Initial rectal thermometer followed by a transesophageal temperature probe for ongoing monitoring. Okay, Foley catheter in tube. You monitor your metabolic status frequently. All right, so classification of hypothermia. So mild temperature. So for mild temperatures, usually between 32 to 34.9 degrees Celsius, and patient present with tachycardia, tachypnea, ataxia, dysarthria, shivering. Moderate is between 28 to 31.9 degrees Celsius. You have loss of shivering, dysarrhythmias, your Osborne or the J wave on ECG, decreased level of consciousness, combative behavior, muscle rigidity, dilated pupils. Severe less than 28 degrees Celsius, patients usually unresponsive, they come in hypotensive, acidemia, either they could have ventricular tachycardia, fibrillation, atrial fibrillation, asystole, and even a flaccidity or apnea. So, warming. So, management is rewarming. Okay, so the options we have, so gentle fluid and electrolyte placement in all stages. Make sure you give the patient gentle fluids and electrolyte replacement. So first rewarming is option is your passive external rewarming. Okay, then you have active external rewarming, then your active core rewarming. So passive external rewarming is suitable for most stable patients with a core temperature of more than 32.2 degrees Celsius. So remove all wet clothes, then cover the patient with insulating blankets. The body generates heat and rewarms through metabolic process or shivering. Then next is your active external rewarming, which involves the use of warming blankets, but be aware of after drop phenomenon. Safer when done in conjunction with active core rewarming. So what is an after drop phenomenon? So it's warming of the extremities causes vasodilation and movement of a cool pooled blood from the extremities to the core, resulting in a drop in core temperature, leading to cardiac arrest. So if you're going to do an active external rewarming, make sure together as well you do it with an active core rewarming, so that the blood from the extremities will not move into the heart, and then because the blood from the extremities are still very cold, it will move into the heart, and then now can actually cause cardiac arrest. So active core rewarming, usually generally for patients who have a core temperature less than 32 degrees Celsius and or with cardiovascular instability. So avoid after drop seen in active external rewarming alone. Okay, so remember we spoke about after drops phenomenon. And then rewarm core by, so how would you rewarm the core? It's by warmed humidified oxygen. You give the patient warm humidified oxygen. Number two, you're going to give them warm IV fluids. You can actually do your peritoneal dialysis with warm fluids. You can do gastric, colonic, pleural, bladder irrigations with warm fluid. You can do external circulation. So external circulation is the most effective and faster way. Okay, so approach to cardiac arrest in a hypothermic patient. So the main treatment of focus is to active core rewarming. So remember, you want to give them warm humidified oxygen, warm fluids. You can do peritoneal dialysis, give them with warm fluids, gastric. You can do a gastric lavage, warm fluid. You can put in a catheter and flush the bladder with warm fluid. All right. Okay. So basically, treatment. So you first make sure you are actually doing an active core rewarming. Then intubate if it's required. Ventilate with warm and humidified oxygen. Do all procedure gently and may precipitate, or it may precipitate your ventricular fibrillation. So check the pulse, the rhythm for at least 1 minute. May have a profound bradycardia. Okay, so if any pulse at all, even very slow, do not do CPR. So sometimes they have a very profound bradycardia. Okay, so if you can feel a pulse, and no matter how slow this particular pulse is, do not do CPR. So if the patient is in VFib, try to defibrillate up to a maximum of 3 shock if the core temperature is less than 30 degrees. Intubate if it's required. Ventilate with warm and humidified oxygen. Medication, vasopressors, you can give them anti-dysarrhythmias. Medication such as your vasopressors or your anti-dysrhythmics may actually not be effective in the low temperature. So the most important treatment is for you to do an active core rewarming. Focus of treatment is rewarming. Okay. So next we're going to talk about frostbite. So as you can see this hand, okay, so your first degree frostbite is usually just erythema. As it progresses, you have necrosis. So third degree will be like a full thickness involving the dermis, and you have necrosis. So classification of frostbite, you have the ice crystal form. So what happens is that the ice crystals form between the cells. So it's classified according to the depth. So similar to burns, so first degree to third degree. So first degree, usually symptoms are usually initial. They have paresthesia, they have pruritus. It's usually just erythema, edema. There's usually no blisters. Second degree, patients start feeling numb. There's numbness to the hand. They have blistering, which are clear erythema and edema. Third degree, they start having pain, burning, thrombing, maybe painless if severe, and they have signs of hemorrhagic blisters, skin necrosis, edema, no movement. Fourth degree, the extension into the subcuticular, the osseous, that involves the muscles and even bones. Management of frostbite. So treat for hypothermia. So first of all, remember, you want to give them humidified oxygen, warm fluids, maintenance of the body temperature, and remove every wet or constrictive clothing. And then emerge in 40 to 45 degrees activated water for 10 to 30 minutes. So depending where the frostbite is, if it's on the hands or all the feet. So this process of emerging is very painful. So you need to administer adequate analgesia. So clean injured areas and leave it open to air. Consider aspiration or debridement of blisters. Debride the skin. You need to give your tetanus prophylaxis. Remember, burns and frostbite, you need to give your tetanus prophylaxis. Consider antibiotics, as frostbite injury are at high risk of infection. Surgical intervention may be required to release constrictive compartment, like to prevent compartment syndrome. Never allowed the area to be re-chilled or freeze. Okay, so consider using TPA or alloprost for severe burns in conjunction with a specialist advice. So what about burns? So clinical features or physical exams findings. So burn size. For you to notice the burn size, you're going to use the rule of nines. So the rule of nine does not include the first degree, the superficial burns. Okay. So the burn depth can be superficial, first degree, superficial partial thickness, second degree, deep partial thickness, second degree, full thickness, third degree, and deep. So this is the rule of 9. Okay, so quite different from adult. So quite different from kids. Okay. So what is your superficial first degree burns usually affects your epidermis only. So it looks like a sunburn. So painful, tender to palpation. Then your superficial partial thickness, second degree, it usually extends to the epidermis and the superficial dermis. Okay, and you usually have blisters formation occurs and it's very painful. Then your deep partial thickness, which is also under second degree, so it involves the hair follicles, the sebaceous gland. The skin is blistered, it exposes the dermis. So the dermis is white to yellow and an absence of sensation. The full thickness, third degree, involves your epidermis an old dermal layer. The skin is pale, insensate, and usually leathery. Then deep, fourth degree involves involvement of fat, muscles, and even bone. Okay, so management ABC. So number one, you need to management of burns. You need to remove any noxious agent, stop the burning process, and consider PPE usage. Establish your airway, all right, if needed. Indicated. Usually, you need to put an airway in if the burns are more than 40% of the body surface, or there's a history of smoke inhalation injury, or there are actually signs of significant upper airway burns. So, resuscitation of second and third degree burns after initial of your two large bore IV. So, you want to insert two large bore IV, start your resuscitation. So, fluid boluses is if unstable, all right. So, you can actually use the Parkland formula. So meaning Ringer's lactate. So you use Ringer's lactate 4 moles or 4 cc per kg, right? So it's going to be 4 cc times kg of the patient times the body surface area that is burnt, and you give half in the first 8 hours, then the next half in the next 16 hours. So maintenance fluid are also required if patient cannot tolerate per os hydration. Okay, so make sure, how would you know the patient is getting enough fluid? Urine output. So urine output is the best measure of resuscitation. So it should actually be between 40 to 50 cc or moles per hour, or 0.5 cc per kg per hour. All right, avoid giving the patient diuretics. So the body surface area percentage defined in pediatrics patient, infants have a proportionately larger head. So instead of having the head 4.5 is usually 9.9. So number one is the fluid, making sure airway secured. Then pain relief, continuous opioid. You can give them fentanyl, morphine, hydromorphone infusion for pain with breakthrough doses as per needed. Then investigate, just making sure that they haven't lost a lot of electrolyte. Check the X-ray for any form of aspiration, ECG, ABG, and your carbo-Z hemoglobin levels. So burn wound care. So what does that include? So you need to prevent infection, clean and debride with mild soap and water, and sterile dressing. Okay, so the patient might actually need to may do a fasciotomy for circumferential burns like chest or extremities. Topical antibiotics. Burn victims are highly susceptible to infection. Portal of entry with reduced immune function. So systemic antibiotic may often be required. Tetanus prophylaxis if burns is deeper than superficial dermis. Okay. So use the palm of the patient hand to estimate the 1% body surface area affected. Okay. So burn causes thermal. One of the causes of burns can be thermal burns, usually flames or chemicals. Then next, chemical burns. Then you have radiation such as UV light, medical or therapeutic radiation, or it could be electrical. Okay. Next, what the patient that you're gonna meet for burns? If the second degree burns more than 10% of the body surface area, or any significant third degree burns, second degree burns on the face, hands, feet, perineum, or across the major joints, or electrical, chemical burns, and inhalation burns, you need to admit them. Burn victims with chronic medical condition or immune compromised patients. So next, we're going to talk about inhalation injuries. So etiology, cardium monoxide or cyanide, poisoning through the dermal contact, or so it can actually be poison through dermal contact or inhalation, and then direct thermal injury, so limited to the upper airway, so above the vocal cord. So smoke causes bronchospasm and edema from particulate matter or and toxic inhalation. Alright, so we're looking at two most common ones, your carbon monoxide and your cyanide. So usually you will take your history and physical exams. Risk factors are usually a close space fire. If they were involved in a close space fire, you want to know the period of unconsciousness, any noxious chemicals that were they involved. Usually present with cherry red skin, beta almond odor, are classic findings of your cyanide toxicity, but are often not present clinically. So what are the Classic sign of your cyanide toxicity: number one, your cherry red skin and bitter almond odor. Okay, so usually patient can present with oral or nasal membrane burns, or the nasal hairs that are burned. They usually have a salty sputum. They can have hoarseness, stridor, dyspnea. They can present with decreased level of consciousness and confusion, and decreased saturation. So a normal PO2. So PO2 normal, but O2 saturation low suggests your carbon monoxide poisoning. So always look for inhalation injury in patients with burns. Intubate early prior to fluid boluses. Okay, if you suspect inhalation injury, as airway can become obstructed due to edema. All right, because remember the smoke causes bronchospasm and edema, so you need to make sure you protect the airway. A, B, C. So immersion investigation, your CBC electrolyte, your lactate level. So if lactate is high, cyanide toxicity should be assumed. If lactate is high, so measure your carboxy hemoglobin levels and your core oximetry. Do an ABG, X-ray, and then an outpatient bronchoscopy. So first of all, how would you manage a patient with carbon monoxide? Is poisoning? It's 100% oxygen, right? Plus or minus hyperbaric oxygen. So hyperbaric oxygen is controversial. Specific scenario where it can be considered. So hyperbaric oxygen and 100% oxygen. For cyanide poisoning, remember we say that the lactate is going to be high. You're suspecting the lactate is going to be high, and then usually presents patient will have an almond odor and cherry red skin. And then So for cyanide poisoning, you are going to give them hydroxycobalamin. So hydroxycobalamin 70 milligrams per kg IV over 15 minutes, a maximum of 5 grams, up to 2 doses. Hemodynamic support. Obtain lab immediately, as your hydroxycobalamin will alter the lab test result. So you first take your blood test before you give the patient your hydroxycobalamin. So direct thermal injury, you're going to give them humidified oxygen, early intubation, pulmonary toilet, bronchodilator, and your mucolytics, your N-acetylcysteine. Next, we're going to talk about bite. So you want to know your history, take your histories, circumstances of bite, symptoms, allergy. You want to know the tetanus immunization status, any comorbid condition, any risk of rabies exposure, transmission, HIV, hepatitis risk. So high mobility associated with clinch fist injury, like a fight bite. There's high mobility associated with that because it's very high risk of infection. So physical exam, you want to assess the type of wound. Is it an abrasion? Is it a laceration? Is it a puncture? Is it a crash injury? And then you want to assess for direct tissue damage. You want to check the skin. Is there any involvement of the bone? Okay, you might need to dissect a little bit to see is there involvement of bone or tendons or neurovascular status, or drains. So investigation, if bony injury or infection is suspected, check for fracture and gas in the tissue with X-ray. Okay, so you can actually do the X-ray just to see is there gas in the tissue or is there any fracture. Then gas in the tissue if you're actually suspecting there's any infection. So get a skull X-ray in children with scalp bite wound. So if a child had a scalp bite wound, or plus or minus CT just to rule out any cranial perforation. Okay, so ultrasound may be helpful for identifying abscess formation as well as locating radiolucent foreign body in infected wound. So you might want to do an ultrasound, you might want to do GIGS X-ray to exclude infections and bony injury. You might want to do a skull X-ray in the children they had scalp bite, or you might as well want to do CT scan just to rule out any cranial perforation. So depending on the scenario. So what will be the initial management is that you will clean the wound and you do a copious irrigations as soon as possible. Clean the wound, copious irrigation, number one. Number two, irrigate or debride the puncture wound if feasible, but not if sealed or very small opening. So I avoid hydro dissection along tissue planes. Okay. So debridement is important In crush injury, to reduce infection and optimize cosmetic and functional repair, culture the wound if there's signs of infection, such as erythema, necrosis, there's any pus, then culture the wound. Obtain anaerobic cultures if the wound is foul smelling, necrotizing, or if abscess is present, and notify the lab that sample is from a bite wound. Then you can decide to suture. So vascular structure of the face and the scalp are less likely to become infected. Therefore, consider suturing. All right. Consider suturing uncomplicated wounds that have been well irrigated or debrided and are vascular. Okay. Consider antibiotic if suturing, and in the case of the hand injury, even if not suturing. So hand injury, even if you're not suturing, you need to give them antibiotics. If you're suturing, make sure it's well irrigated, you have debrided well, and it's mostly vascular areas, and make sure you give them antibiotics. Okay, if suturing. If it's a hand injury, even if you're not suturing, you need to give them antibiotics. Okay, so tetanus immunization, if more than 5 years or incomplete primary series, you're going to give them, right? So prophylactic antibiotics, type of infection resulting from bite. It could be cellulitis, lymphangitis, abscess, tenosynovitis, osteomyelitis, septic arthritis, sepsis, endocarditis, meningitis. So that's the type of infection resulting from bite. A 3 to 5 days course of antibiotics is recommended for all bite wound to the hand and should be considered in other bites if any high risk factor is present. Okay, so dog and cat bites. Usually the pathogens they have is your Pasteurella maltosida or Staph aureus or Staph viridans for kids and dog. And so dog and bites, yes. So 10 to 50% of cat bites and 5% of dog bite become infected. So first line of antibiotics would be amoxicillin plus clavulanic acid, not cefalexin, as it does not cover your Pasteurella species or your Echinella corydens. So you want to give them amoxicillin, which is augmentin. So augmentin, amoxicillin plus clavulanic acid. Right. Human bite pathogens that we're looking at are your Echinella corydens, Echinella corydens, Staph aureus, Staph viridans, or oral anaerobes. Right. So carry out a risk assessment for blood-borne infection. So if hand injury, always consider and associate your metacarpal phalangeal drain. So always think about if the hand is injured, if it's a fist fight, always think of your metacarpal phalangeal drain involvement. And the first line is going to be amoxicillin clavulanic acid as well. All right, rabies. So reservoirs, warm-blooded animals, except rodents, primarily your bats, your raccoons in Canada, your lagomorphs like your rabbits. The incidence in domestic animals is low, high risk in if animal bite outside of Canada. So post exposure vaccine is effective, right? So treatment depend on the local prevalence. Solicit guidelines from the local public health unit. Okay, so maybe most of the time, so if it's outside, if incident with domestic, the incident of getting rabies with domestic animals is low. Higher risk if maybe the animal bite was outside of Canada, then you might need to give them your rabies vaccine. Very important. So next we're going to talk about non-fatal drowning. So most common in children less than 4 years and teenagers. So it causes lung damage, hypoxemia, and may lead to hypoxic encephalopathy. We also must also assess for shock, C-spine injuries, hypothermia, your scalp-related injuries like your barotrauma, your air emboli, lung re-expansion injury. Complications of your non-fatal drowning are your volume shift, electrolyte abnormalities, hemolysis, rhabdomyolysis, renal DIC. So physical exams, you want to do ABC, vital signs, watch closely for hypertension, respiratory exams. Make sure you check for your ARBs, ARDS, your pulmonary edema, decreased breath sound. Check for pneumothorax. Check for your murmurs, dysarrhythmias, JVP. Assess C-spine for C-spine injury. Okay, you want to do a GCS. check pupils and focal deficit. Okay, you might need to do your labs, investigation, imaging, X-ray, ECG. How would you manage an non-fatal drowning? So ABC, treat for trauma, shock, hypothermia, and cardiac and oxygen monitors, IV fluid, IV access. So intensive respiratory care, you want to do ventilator assistance if decreased respiration, if your PCO2 is more than 50 or your PO2 is less than 60 on maximum FiO2, you might need to give them ventilatory assistance. So it may require intubation and airway protection, ventilation, or pulmonary toilet. So high flow oxygen, CPAP, BiPAP may be adequate, but some may need mechanical ventilation with positive and expiratory pressure. So make sure you manage your dysarrhythmia. Usually respond to correction to hypoxemia, hypothermia, and acidosis. Vomiting, very common. So make sure you have a nasogastric tube suctioning to avoid aspiration. Convulsions usually respond to oxygen. If not, you're going to give them lorazepam 4 milligrams IV slowly. Bronchospasm, you might need to give them bronchodilators. Bacterial pneumonia, prophylactic antibiotics not necessarily useless. Contaminated water or head tap. So you might need to give them prophylactic antibiotics. Always provide rescue ventilation and initiate CPR in drowning-induced cardiac arrest, even if patient is hypothermia. Continue CPR until patient is fully rewarmed. Okay. So next, we're going to talk about toxicology. What is an approach to an overdose patient? Patient present overdose. You're not sure exactly what they took. When I actually try and get the age, the weight, the underlying medical problems, medication they're on, substance, route, and quantity that has been ingested, time, and symptoms since exposure to determine the prognosis and the need for decontamination. Want to know how did they ingest it? What was their intention? Any suicidal ideation? Indication to suspect overdose: if they have altered mental status and they have coma, suspect overdose. Young patient with life-threatening dysarrhythmias. Usually, dysarrhythmias are found in older patient, but if you have young patient with life-threatening dysarrhythmias, think about overdose. If you have a trauma patient, think about overdose. Bizarre or buzzing clinical features as well. So obviously, you want to get a history. You want to know how much did they drink or how much did they take. What route did they take? Was it injection? Was it orally? What's the quantity they took? At what time was this taken? So that you can know, okay, do I still have space to decontaminate this patient? I want to know obviously the weight and age. Okay. So physical exams is your ABC, check level of consciousness, vital sign, pupils. Okay. Now you have your ABCD3EFG of toxicology. So basic axiom of K is symptomatic and supportive treatment. So address the underlying problem only once the patient is stable. So A, make sure you have airways. A for airways, consider stabilizing the C spine. B, breathing. C, circulation. D1, drugs. So ACLS necessary to resuscitate the patient. Remember using the universal antidote DONT. Okay. Spoke about DONT earlier. So oxygen, naloxone. What's the other one? D2, draw blood. D3, decontamination. Decrease absorption. So to decrease absorption, so you want to try and decontaminate. E, expose, look for specific toxidromes or examine the patient. F is do your full vital signs, ECG monitors, Foley catheter, X-rays. G is give specific antidote and treatment. So A, B, C, 3, D, E, F, G. That is the management of your toxicology. Oh, sorry, there's. So further step following A, B, C, D, 3, E, F, G is that reassess, call the poison information center, obtain history from the family or bystanders. So what is the principle of toxicology? So 4 principles to consider with all ingestion. So any patient who has ingested whatever, first you need to resuscitate using your A, B, C, D, 3, F, E, F, G. Then screening. Try and get clinical clues. So check the skin, maybe for pricks, alright? Toxidromes, check. Next, decrease absorption of the drug. Okay, so you need to decontaminate. In no cases should this patient be having induced vomiting, right? Increase elimination of the drug. So obviously you want to make sure you call your poison center and then try and find ways of how to eliminate what antidote to give. So D1. Remember we had D1, D2, D3. So D1 universal antidote. You're going to use the mnemonics don't, remember? So treatment that will not harm the patient and may be essential. What is the mnemonics don't? Is dextrose, oxygen, naloxone, and thiamine. So must give before dextrose. Must give thiamine before dextrose. So dextrose give if any patient presenting with altered level of consciousness, measure blood glucose prior to glucose administration if possible. In adults, you want to give them 50%, 50 moles or 50% dextrose. Okay. In children, you want to give them 25% dextrose. Oxygen, do not deprive a hypoxic patient with oxygen regardless of the medical history, even if they are COPD or there's CO2 retention. So if depression of hypoxic drive, intubate and ventilate. So oxygen is very important. Next, naloxone. So it's an antidote for opioids. Okay, so administration is both diagnostic and therapeutic. Lesser than 1 minute onset of action. So it's very quick. So used for the undifferentiated comatose patient. So loading dose in adult is response to naloxone can be drastic. So stepwise delivery is recommended. So you're going to give them 0.05 to 0.1 milligrams IV with escalation of the dose as per needed. So naloxone administration during cardiac arrest. So if the patient has cardiac arrest, you first begin with ACLS protocol and then administer 2 milligrams IV or IM every 3 minutes. May increase the dose by doubling up to a maximum of 12 milligrams. In children, it's the dose is 0.01 per kg. Initial bolus. So children over 20 kg can receive naloxone 2 milligrams IV. Maintenance dose may be required because the half-life of naloxone is 30 to 80 minutes. It's much shorter than any opioid. So you might need to give the patient. So thiamine, you're going to start them. Remember, you give thiamine before you give dextrose. 200 milligrams IV or IM with IV or per-os glucose to all patients. So given to prevent Wernicke's encephalopathy as a necessary cofactor for glucose metabolism. So it may worsen Wernicke's encephalopathy if glucose given before thiamine. So, but do not delay glucose if thiamine is unavailable. Okay. So must assume all undifferentiated comatose patients are at risk. The thiamine is deficient in patients that are malnourished. Consider in patients with alcohol use disorder, anorexia, or malnutrition status. D, remember we spoke about, we said draw blood. When in an overdose patient, you would do your essential test. You want to do CBC electrolytes, iron R, ABG, oxygenation saturation. Check for your aspirin levels, your acetaminophen level, your alcohol levels. Potential useful tests are drug levels. So this is not a serum of drug screening. So e.g. digoxin or iron. So check for your calcium, magnesium, phosphate, protein, albumin, lactate, ketones, enzymes, CK, depending on the drugs and clinical features. So use drug screen. So urine drug screen is costly and generally not useful in the ED management of a poisoned patient unless suspicious of your aspirin, acetaminophen, or toxic ethanol ingestion. So usually you would do your IV blood, your IV bloods. So serum drug levels. So treat the patient, not the drug level. Okay. So negative toxicology screen does not rule out a toxic ingestion. Okay. Signifies only that the specific drug tested were not detected in the specimen. So specific drugs available in general screen vary in by institution. So check before ordering. And then urine screen also available. Qualitative only. Not often taught to change management. Okay. So next, we're going to look at the toxic gap. Again, at toxicology. So what is an approach to an overdose patient? First of all, you want to know the history, as we have mentioned earlier. Then you do a physical examination, right? And then how do you manage this patient? You have an A, B, C, D, 3, E, F, G. Okay, so that's the mnemonics that you can follow. All right. So starting with A, you make sure the airway is secure and consider stabilizing the C spine, breathing, circulation C, and then under D you have 3D. So you have D1, which is drugs, D2, which is draw blood, D3, which is decontamination, okay, to decrease absorption, and E for exposure. So you have to examine the patient. And F, it's for full vitals. E, it's to ECG monitor. Sorry, G is to give specific antidotes and treatment. All right. So what are the principles of toxicology? There are 4 principles to consider. Number 1 is resuscitation. How would you do the resuscitation? Using your A, B, C, D3, E, F, G. Then screening, and then decrease absorption of drugs and increase elimination of the drug. All right. So we have already spoken about A, B, C. Now D, we're going to go through D1, D2, D3. So D1, which means universal antidote. So what is the universal antidote? The mnemonics is D. Sorry, it's DONT, excuse me. So D for dextrose, O for oxygen, N for naloxone, T for thiamine. And you must give thiamine before dextrose. So these are actually treatment that will not harm the patients and may actually be essential. Okay, so for dextrose, try and get your blood glucose levels. You can do a finger prick just to get the patient glucose prior to administering the dextrose. So if it's an adult, you will give 50% dextrose, 0.5 to 1 gram per kg. If it's a child, it's dextrose 25%, 0.25 grams per kg. Okay, so oxygenation, make sure you give proper ventilation. And you might actually need to intubate this patient. Naloxone. So naloxone is an antidote actually for opioids. So administrations is both diagnostic and therapeutic at the same time. So it's used for undifferentiated comatose patients. So you don't know what's wrong with the patient. So it will not cause any harm, but actually be essential for these patients. So loading dose for adults, it's 0.05 to 0.1 milligrams IV, and you can actually escalate the doses as per needed. And then for a child, a 0.01 milligrams per kg initial dose. You can give it IV, IO, or via the endotracheal tube. Okay. So thiamine. So that's your vitamin B1. You can give 200 milligrams IV or IM with IV or glucose to all patients. So remember, you want to first give thiamine before you give glucose. So this thiamine actually is to prevent and as well treat Wernicke encephalopathy. All right. So a necessary cofactor for glucose metabolism. So may worsen Wernicke's encephalopathy if glucose is given before thiamine. So, but then if do not delay glucose, maybe there's no thiamine available. So thiamine is essential. Thiamine is deficient in patients that are usually malnourished. Also consider giving it in alcohol use disorder patient with a history of anorexia and malnutrition state. The second D, which is D2, it's draw blood. So you want to draw blood. Your essential test CVC electrolytes, glucose, your iron R, your osmolality. Do your ABG saturation. You check for your aspirin levels, acetaminophen levels, ethanol levels. And then, so it's the serum drug level. So treat the patient, not the drug level. Okay, so depending on how the patient presents, you're going to treat the patient depending on the patient presentation. All right. So this table 30 talks about toxic gap. So what are the causes of increase in iron gap? The mnemonics is gold mark, right? So G4 glycols like ethylene glycol, propylene glycol, and then O is for your oxyproline, like which is a metabolite of acetaminophen, and L is for lactate. D is for lactate, drugs such as acetaminophen, short bowel syndrome, propylene glycol as well infusion for lorazepam or phenobarbital. M is for methanol. A for aspirin. R renal failure will cause an increase in NI gap. And ketoacidosis, like in patient with DKA or starvation or ethanol toxicity, then they can also present with an increase in iron gap. So what causes a decrease in iron gap? Usually is your electrolyte imbalance, where you have an increased sodium or potassium or magnesium, or hypoalbuminemia, where 50% falls in albumin. So when albumin decreases, you're also going to have a decrease in your N-iron gap. What else causes decrease in N-iron gap? Your lithium, your bromide elevation, your paraproteins like in multiple myeloma, and in normal N-iron gap, usually renal bicarb loss. So due to renal tubular acidosis, hyperparathyroidism, and then or GI bicarb loss, such in diarrhea and fistula. So anything that causes bicarb loss. So next, how do you calculate your N-iron gap? So it's sodium minus chloride minus bicarb. All right. So normal N-iron gap is less or equal to 12. Okay. Anything above, it's high. Next, we're going to talk about your osmolar gap. So how do you calculate your osmolar gap? It's 2 times you multiply the sodium times 2 plus your glucose and plus urea, and you minus all of that to the measured osmolality level. So they usually give you the measured osmolality levels. So usually the normal osmolar gap is lesser than 10. So what are the causes of increased osmolar gap? The mnemonics is MADI. So number 1, M for methanol, A for acetone, E for ethanol, D for diuretics like mannitol, sorbitol, glycerol, I for isopropanol, E for ethylene glycol. All right. So note, normal osmolar gap does not rule out toxic alcohol. Only an elevated gap is actually helpful. So what is a decreased oxygen saturation gap? The causes of a decreased oxygen saturation gap are your carboxyhemoglobin, your metahemoglobin, and your cell metaglobin. All right. So what is oxygen saturation gap? So it's a difference between uh, the higher oxygen saturation measured by the pulse oximeter and the lower actual saturation calculated by the arterial blood gas. So basically, when you subtract the two, you actually see the gap. So if there's an increased gap between your pulse, the oxygen that you get from your pulse oximetry, and the oxygen that you get from an arterial blood gas, if there's a significant gap, this means that there's usually a carboxyhemoglobin level. So you have a very high level of carbon dioxide in the blood. Okay. So instead of oxygen being attached to hemoglobin, you have carbon dioxide attached to hemoglobin, for example, or metaglobin. Okay. So next we're going to talk about the table 31 use. So we are still under D2. So the use of clinical labs in the initial diagnosis of poisoning. Okay. So what are the initial labs that you can do? You can do your ABC. So ABG will actually show, is this patient hypoventilated or hyperventilated? So if they're hypoventilated, you're going to have a high carbon dioxide because carbon dioxide gets retained. If they're hyperventilated, they're going to have a low carbon dioxide. And then what could cause this? It could be central nervous system depressant like opioid, phenothiazide, ethanol, salicylate, carbon monoxide as well. And then what else are you going to check for? You're also going to check the electrolytes. You are checking for your N-iron gap, metabolic acidosis. You're looking for hyperkalemia, hypokalemia. Okay. You also check for your glucose, checking for hyperglycemia. You're looking for osmolality and osmolar gap. An elevated osmolar gap as well. Remember we spoke about it. This could be due to, you would think about ethanol. The patient could have had ethanol ingestion or acetone or methanol or diuretics like glycerol, mannitol ingestion or isopropanol or ethylene glycol. You also want to do your ECG, okay, because you could find a YQRS complex or prolonged QT intervals. You also want to do an abdominal X-ray because you can actually see some radio opaque pills or object that can be seen. Now, if you can actually see radio opaque pills or object, think about the selective causes of that could be using the mnemonics chips. So it could be calcium. Calcium will be radio opaque. Could be chloral hydrate. Okay. All right. It could be calcium chloride. It could be a heavy metal. Iron as well. You're gonna if the patient ingested iron, you could see it on abdominal X-ray. Let's say potassium and coated. If you have coated salicylate and some foreign body as well can be seen. Okay. So if maybe the patient has swallowed some pills and then they do not know exactly what they swallowed, and maybe you decide to do an abdominal X-ray, and then you see it radio opaque. So think about maybe it could be calcium or iron or potassium. All right. So you also want to do your serum acetaminophen levels. Okay. So the third D is decontamination and enhancing elimination. So how are you going to decontaminate this patient that has a history of overdose? So if it's ocular involvement, all right, maybe chemicals through the eyes, you're going to do a saline irrigation to neutralize the pH. An alkaline exposure requires an ophthalmology consult. So alkalines are very dangerous compared to acidic exposure to the eye. So first thing you want to use your saline to irrigate the eye until you have a neutral pH. So what about the skin? Contamination to the skin. So first thing you want to do, remove the patient cloth and brush off toxic agent and then irrigate all external surface. So example in the case of organophosphate poisoning. Okay, so how you do, let's say a patient has swallowed poison, how would you do a gastrointestinal decontamination? The first thing is that you can give a patient a single dose of activated charcoal. You can also do whole bowel irrigation, and you can also do multiple dose of activated charcoal or surgical removal in extreme cases. So what is a single dose activated charcoal? So basically it's a use of activated charcoal in a source of a much deep. So the use of activated charcoal, sorry about that, is actually there's still a high debate amongst toxicologists. So the evidence of effectiveness is not strong and the risk of aspiration is high. So it's considered if it is a recent ingestion. So right. So usually if it's recent, let's say patient has present 30 minutes, less than an hour or two after the ingestion of the poison, then you can start them on your single dose activated charcoal. So So actually, when is it contraindicated to use your activated charcoal? Is if there's an unprotected airway because of the risk of aspiration. There's higher risk of aspiration, and then if the patient presents late after the ingestion of the poison, let's say 1 to 2 hour post ingestion. If the patient has small bowel obstruction, if they have poor toxin absorption, then you don't want to give it to them. So what is the dose? Is 10 gram per gram of drug ingested, or 1 gram per kg of the body weight. So it may vary depending on the ingestion. Okay, so it's an odorless, tasteless, usually prepared as a slurry with water. So you mix it with water. So what is the other type of your gastrointestinal decontamination? You can do a whole bowel irrigation, which is occasionally used, where in children you will use 500 moles per hour, and in adults you can use up to 200 moles per hour of what you're going to use polyethylene glycol. Okay, so remember polyethylene glycol is usually given for constipation. So you're going to use the solution by mouth until clear, okay, until everything clears per rectum, okay? So you want to start with a slow dose, let's say 500 moles in an adult, and aim to increase the rate, okay, hourly as the patient tolerates it. So when is this indicated? Where you can use your polyethylene glycol is if the patient is awake, alert, and can be nursed upright. With you can also use a nasogastric tube if patient cannot actually tolerate drinking it, right? Or if the patient is intubated or the airway are protected. So first of all, also make sure to indicate if there is a delayed release product. If the drug or the toxin it's not bound to charcoal. So if charcoal cannot be used, then you can actually use your whole bowel irrigation. So if it's usually found if it's drug packages, so you have drugs that are in the patient swallowed, like maybe if a patient swallowed cocaine bundles, but there is no evidence of uh, breakage, you can actually use this. But then if there is evidence of breakage, emergency surgery is needed. If it's a recent toxin injection, you can use it. So what are the contraindication to this whole bowel irrigation? Is if you have evidence of an ileus or obstruction, if there is perforation. Okay. So another option for gastrointestinal decontamination is your multiple dose activated charcoal. So it may be used for drugs like carbamazepine, phenobarbital, quinine, theophylline, or for toxin which undergo enterohepatic circulations. So what happens? It removes the drug that has already been absorbed, right, by drawing it back into the GI tract. Okay. So there's various regimes where you have 12.5 grams. You take it as per oz. You have 25 grams, which is for half of a bottle, and per oz every 2 hourly until non-toxic. So you have single dose activated charcoal, or you have multiple dose activated charcoals. Then you can also do surgical removal in extreme cases. So under decontamination, you also have lipid emulsification. All right. So as you can see on the diagram on the right, so basically, it's actually you give a bolus of lipid solution, 20%, which is 1.5 moles per kg over 3 minutes. Then after giving the bolus, you can start the infusion of 0.25. So usually this is a new therapy used for cardiogenic shock due to toxins. So if it's a patient that had a history of anesthetics such as an overdose of lidocaine, overdose of beta blockers or calcium channels blockers, or your atypical antidepressant overdose, then cardiogenic shock. So this can actually be used. Okay. So urine alkalinizations can actually be used for patients uh, that have overdosed aspirin, methotrexate, phenobarbital, clopramapine. So basically, what happens is that weakly acidic substance can be trapped. So if this weakly acidic substances can actually be trapped in an alkaline urine, and then this can increase the elimination of this product via the urine. Then you can also do your hemodialysis. Hemodialysis indications and criteria for hemodialysis are toxins that have a high water solubility, a low protein binding, a low molecular weight, and adequate concentration gradient, small volume of distribution, or rapid plasma equilibration. So clinical deterioration despite maximum medical support. Then you can decide to give them a hemodialysis if they are still deteriorating after giving them all the medical support. So what is it useful for? It's useful in toxins such as methanol, ethylene glycol, salicylate, lithium, phenobarbital, right? Carbamazepine, valproate, methotrexate, geophylline. Okay, so E in the mnemonics stands for you need to expose the patient. If you have an overdose patient, you expose and examine the patient. So you want to do your vital signs. So you want to do vital signs including temperature. You expose the patient, you're looking for the skin, any needle tracks, any color on the skin. Check the mucous membrane. Check the pupils. How is the patient smelling? Check the central nervous system. Okay, so you do a head to toe survey, including to ensure the patient C spine is maintained. Signs of trauma or seizure, where there is check for incontinence, biting of the tongue. So basically, drugs misuse. So drugs misuse usually can see patient can present with nasal septum erosion, maybe if they've been overdosing cocaine or track marks. So if maybe they're using heroin or they're injecting, obviously you're gonna see needle pricks and stuff. So feel the patient axilla. So in the average patient, it should be somewhat moist. If dry, it may indicate an anticholinergic toxicity. Okay, so if you feel the patient axilla, it should be moist in most patients, but if it's dry, it may indicate an anticholinergic toxicity. Check the mental status of the patient. So now, what are we gonna do next? Is that we're going to look at drugs and the type of symptoms that you may have. So anticholinergics, before we go forward, what are anticholinergic drugs? So basically they act by inhibiting your neurotransmitter acetylcholine, okay, from binding to the receptors in the central nervous system and your peripheral nervous system. Okay, remember for the parasympathetic nervous system, it uses acetylcholine pre-synaptic and post-synaptic. Okay, so basically if you are inhibiting acetylcholine, you're actually blocking the parasympathetic system. So basically your rest and digest system. Okay, so basically when you're resting, what happens? That's when you are your organs, your GIT, you start having GIT motility. You have that's when you're having contractions of your muscles. So basically this will reduce smooth muscle contractions. It will cause reduce your glandular secretions and heart rate regulation. So anticholinergic, what are they going to present with? They're going to present hypothermia. Okay, so remember your parasympathetic nervous system. So let's just try and think about it. So anticholinergics, right? You are inhibiting your parasympathetic nervous system, right? So what will work more? It's your sympathetic nervous system. Okay, so if you see an object and you're running away from that object, how would you present? Because you're running, you're going to be hypothermic. Your pupils need to be dilated in order for you to see where you're going, so you don't fall. Obviously, your skin is going to be dry because you need to get all those fluid as much as possible. It will cause vasodilation. Okay. Obviously, you're going to have urinary retention because your smooth muscles are actually not going to be contracting right now. They're going to be relaxing. You're going to be tachycardia because of the sympathetic nervous system that is activated. You're not going to have any bowel movement, so you're going to have ileus. You're going to be agitated and hallucinations. Okay, so let's just think about it. Your parasympathetic nervous system is not working. Or it's reduced. So what takes effect if you are overdosing this medication? If you are overdosing this medication now, it means that the sympathetic nervous system takes over the moment you have overdosed the medication, right? Hypothermia, the pupils are dilated, the skin is dry, vasodilations, okay, because you need you don't have smooth muscle contractions. Okay, you feel agitated, hallucinating, you have urinary retention because now your bladder says this is not the time. Your ileus because your bowel is saying no, you cannot have any bowel movement right now. Then tachycardia because you've increased contractility of your heart. Okay, but you have decreased contractility of your of your peripheral smooth muscles. Okay, example of the drugs are your antidepressant. Example on a tricyclic antidepressant. Another one is your cyclobenzaprine, your carbamazepine, your antihistamines, like your diphenhydramide, your Parkinson drugs, your psychotics, your spasmodics, and then things like atropine. So any of those of this can make patient present with the signs and symptoms. Okay, so what about cholinergics? What are cholinergic drugs? So cholinergics actually mimic the action of your acetylcholine. Alright, so remember acetylcholine works more on your presympathetic and postsympathetic of your parasympathetic system. So here you have more activation of your parasympathetic system. Okay, so it's going to be the opposite of what we just spoke about. So your parasympathetic nervous system is more activated, okay, compared to your sympathetic nervous system. So what happens? You have the mnemonics dumbbells. So remember, this is your rest and digest, parasympathetic rest and digest. If it's overstimulated, what happens? So you're going to have diaphoresis. So your bowel movement is increased. Remember, you're going to have increase in your bowel movement. So what happens? You will have diarrhea, for example. Okay, so you're resting and you're digesting. You're going to be sweating, right? Resting and digesting, obviously, you're going to have a decreased blood pressure. Okay, decreased blood pressure because you have decreased contractility of the heart. You're not moving fast. You don't need to move fast. Okay, so decreased blood pressure. Now, your bladder can say it's going to be over contraction of your bladder. So they're going to be urinating. Okay, so you're sitting down. Your eyes doesn't need to dilate because you're not running any flight. So you're going to have meiosis. Okay. All right. Then bronchospasm, bradycardia, bronchoria. Okay. So you have over secretions. Okay. So vomiting because remember your GI system is overworking. Excitation of your skeletal muscles. All right. Lacrimation. You're producing more saliva than you need because remember it's a rest and digest. But because now it's overly stimulated, you're going to have lacrimation, salivation, and even seizures. All right. So what are the drugs that we're looking at? So remember dumbbells, D for diaporesis, diarrhea, decreased BP, U for urination, M for meiosis, B for bronchospasm, bronchoria, bradycardia, E for emesis, excitation of the skeletal muscles, L for lacrimation, S for salivations and seizures. So drugs, examples, could be natural plants such as mushroom, your trumpet flower, could be anticholinesterase. So drugs that actually inhibit your what? The enzymes. Your acetylcholine esterase. So acetylcholine esterase is an enzyme that actually breaks down acetylcholine, right? So if you have drugs that inhibit that, you're gonna have increased acetylcholine inside the subnautic cleft, right? An example of those drugs are your neostigmine, your physostigmine example. Another one is your insecticide, organophosphate poisoning, your carbamate toxicity. All right, so they act as your cholinergics drugs, so meaning more activation of your acetylcholine. All right, and last one is your nerve gases. Next, extrapyramidal. So extrapyramidal symptoms, how are they going to present? So dysphonia, dysphagia, rigidity, and tremor. They can present with akathisia. Akathisia is usually muscles. The patients are usually have motor restlessness. They're very restless, and then they have crawling sensation on the skin. Then that is akathisia. For dyskinesia, they have constant movement. For dystonia, usually they present with muscle spasm, laryngospasm, trismus, torticollis, your ocular gyricrisis. Example of the drugs are your anticholinergics, your antipsychotics, and your major tranquilizers, and your antipsychotics. So hemoglobin derangements. So if you have your carbon monoxide poisoning, all right, so what is it going to cause? It's going to cause something called carboxyhemoglobin, where your carbon dioxide carbon gets binded to hemoglobin instead of oxygen. All right, so that causes a patient to present with increased respiratory rate, decreased level of consciousness, seizures, cyanosis, unresponsive to oxygen, lactic acidosis. Other drugs are your methemoglobin and your surf methemoglobin. So basically, this would cause hemoglobin derangements, where you are, instead of having more oxygen that is bound to hemoglobin, you have the substances bound to hemoglobin. Obviously, if you're going to have decrease in oxygen, so obviously increased respiratory rate because your body is trying to compensate. You have decreased level of consciousness. You can even have seizures because now you have decreased oxygen to your brain. All right, you can present with cyanosis and then lactic acidosis. Okay, because now remember your muscles, your organs are now receiving oxygen. So what happens when there is decreased perfusion? You're going to have an increase in your lactic acidosis. All right, so the most common management in this case would be giving them oxygen, 100% oxygen or hyperbaric oxygen. So next, opioid sedative, ethanol. So patients who had maybe overdose alcohol, benzodiazepine, opioids like morphine, heroin, fentanyl, barbiturates, G, liquid gold, So how are they presenting? So hypothermia, hypotension. The opioid causes respiratory depression. They're going to have dilated or constricted pupils. So in opioids present with pinpoint or constricted pupils, okay? And central nervous depression, especially alcohol. So drugs such as amphetamines, caffeine, cocaine, phencyclidine, ephedrine, and other decongestant, thyroid hormones, sedative, or ethanol withdrawal. How do they usually present? They present with dilated pupils. So basically, this will cause increased sympathetic nervous system. All right. So what are the drugs that actually mimics the sympathetic nervous system? Let's just repeat that. Your amphetamine, if patient has an amphetamine overdose, caffeine overdose, cocaine overdose, ephedrine, or other decongestant, your phencyclidine, your thyroid hormones. Thyroid hormones, increased thyroid hormone will cause your sympathetic nervous system activation, right? Sedative or patients that have withdrawal, alcohol withdrawal. So this causes activations of your sympathetic nervous system. So that's where your flight and fight response, you're gonna have increased temperature, central nervous system excitation, including seizures, including your hallucinations. Hi, what? Sorry, nausea, vomiting, tachycardia, hypertension, diaphoresis, dilated pupils. All right. So serotonin syndrome. So drugs like MAOI, your TCL, your triglycerine, acetylcholine, SSRIs, your opioid analgesics, your cough medicine, rate reduction medicine, actually can cause mental status changes, autonomic hyperactivity, neuromuscular hyperactivity, hypothermia, diarrhea, and hypertension. Okay. So remember full vital signs for F and folate catheter X-ray. G, give a specific antidote and treatment. So for patients, you can actually give urine alkalinizations for treatment for a patient who has aspirin overdose. So basically, you're aiming to have a urine pH of more than 7.5. So how do you do this? You first fluid resuscitate the patient, then you give them 3 m's of sodium bicarb per liter of 5% dextrose. So in 1 liter of 5% dextrose, you're going to put 3 m's of sodium bicarb, and then you might add as well 20 to 40 KCl if the patient is able to urinate. Next, what is the protocol for warfarin overdose? So INR. So consider prothrombin complex concentration for any elevated INR and either life-threatening bleeding or a plan for a patient to undergo surgical procedure within the next 6 hours. So vitamin K actually takes 4 to 6 hours post IV administration to work. So if the INR is lesser than 5, so what do? Cessation of warfarin administration, observe, and repeat your INR or your PT levels. If INR is between 5.1 to 9, if no risk factors for bleeding, then hold warfarin for 1 or 2 days and reduce maintenance dose. Or you can give vitamin K 1 to 2 milligrams per ounce if the patient is at increased risk of bleeding. If the INR is between 9.1 to 20, want to hold the warfarin for some days, give vitamin K 2 to 4 milligrams per ounce, and then you want to repeat your INR levels, PT levels, and you might add additional vitamin K if necessary. If INR is more than 20, hold warfarin, then you're going to give them vitamin K, 10 milligrams IV over 10 minutes, and then increase vitamin K dosing if needed. All right. So now we're going to talk about specific antidote and treatment for common toxin. So a patient with a history of acetaminophen, which is paracetamol overdose, what are you going to give them? Decontaminate. So a patient presenting lesser than 1 to 2 hours, decontaminate with activated charcoal. Then you can give them an acetylcysteine. So consideration. So often clinically silent. So evidence of liver renal damage are usually delayed. For you to see signs of your liver and renal damage, you usually see it after 24 hours. So what is the toxic? The toxic dose is more than 200 milligrams per kg. All right, which is more than 7.5 grams in adult. So monitor drug level 4-hour post ingestion. Also check for your liver enzymes, your iron R, your PTT, your creatinine levels. Check the patient for hypoglycemic, metabolic acidosis, encephalopathy poor. If they have encephalopathy, it's a poor prognosis. Dialysis may be required to manage at very high doses. Okay. So what is the toxic dose? More than 200 milligrams per kg in an adult is more than 7.5 grams. What is the normal dose per 24 hours? 4 grams. Okay, so that's like double of that. So next, acute dystonic reaction. The patient presenting with extrapyramidal side effect like acute dystonic, what are you going to give them? You're going to give them benztropine, 1 to 2 milligrams IM or IV, then 2 milligrams per os for 3 days. Or you can give them diphenhydramine. So diphenhydramine is 1 to 2 milligrams per kg IV, then 25 milligrams per os 4 times daily for 3 days. So either benztropine or your diphenhydramide. So consideration, benztropine, also known as cogestin, has euphoric effect and potential for misuse. So you need to give a specific dose to the patients because of this euphoric effect. So patient might want to misuse it. Next, anticholinergic drugs. Remember we spoke about all of the anticholinergic drugs. They say example were antidepressant, your carbamazepine, antihistamine, antiparkinsonisms, antipsychotics, spasmodics. So for the management of anticholinergic drugs, you need to consider decontamination with activated charcoal and then supportive care. So special antidote are available, so you need to consult the Poison Information Center. For aspirin or ASA, consider decontamination with activated charcoal. Alkaline, you can alkaline the urine. Remember how do we alkaline the urine? You give the patient 3 m's of sodium bicarb in 1 liter or 5% dextrose. So because you want to have a urine of more than 7.5. So what are the considerations with aspirin toxicity? So monitor your serum pH and drug level closely. Monitor your potassium level. May require supplement for urine alkalizations. Hemodialysis may be needed if intractable metabolic acidosis, very high levels, or organ damage. Actually, may require hemodialysis. Okay, and always make sure you monitor your potassium levels. So benzodiazepines. To consider your decontamination, your activated charcoal. The drug for benzodiazepine overdose is your flumazenil. So flumazenil you only use in iatrogenic overdose, like operative over sedation, due to the extensive contraindications. Say if a patient was in theater or the patient was given an overdose of benzodiazepine, that's actually when the patient gets your flumazenil. Normal, if the patient just ingested, usually it's mostly decontamination with activated charcoal and supportive care. So next, beta blockers. So consider decontamination, activated charcoal, consider a whole bowel irrigation for extended release ingestion. You can give them an IV glucagon. So remember, glucagon helps reverse all of your beta blockers. Also give them IV calcium chloride to protect the heart. And then IV high doses of insulin with dextrose. And then IV lipid emulsifications. Because these beta blockers can cause cardiac arrest or even heart blocks. All right. So if you start with decontamination, you can actually give them bowel irrigation. Then make sure you give them IV glucagon, IV calcium blockers, IV high doses of insulin with dextrose, and also IV liquid emulsifications. So what about calcium channel blockers? So you want to consider as well decontamination with activated charcoal. Consider also a whole bowel irrigation. So same thing as your beta blockers. You want to give them IV glucagon, IV calcium chloride, IV high doses of insulin with dextrose, and IV intralipid. So same thing. And then order ECG. In both cases, you want to order ECG and check the electrolyte, especially your calcium, magnesium, sodium, and potassium. What about cocaine overdose? You first want to decontaminate the patient, activated charcoal if oral, say if it was taken already, then aggressive support. So remember that beta blockers are contraindicated in an acute cocaine toxicity, right? So an intralipid for life-threatening symptoms. Okay, so you can give them IV lipid emulsification. Consider benzodiazepine for any major side effect of cocaine overdose. Like if they are agitated, consider give them benzodiazepine. If they have hypertension, tachycardia, just for them to calm down. So consider giving them benzodiazepine. Never give beta blockers. Okay. Okay. So carbon monoxide poisoning. So for carbon monoxide poisoning, you're going to give them supportive care, 100% oxygen, and they may require your hyperbaric oxygen. So make sure you do your ECG, your VBG, you consider lactate and troponin depending on specific presentation. Okay. And then for your cyanide, it's gonna be management is gonna be a hydroxy cobalamin 5 milligrams IV, and then consider in all patient found to be in a fire. So if a patient has a history of being exposed to fire outbreaks, think about carbon monoxide toxicity and cyanide toxicity. Next, digoxin. So consider decontamination with activated charcoal, and then the digoxin specific antibody fragments. So you actually have digoxin specific antibody fragments so you're going to give them 10 to 20 vials IV if acute, and then 3 to 6 if chronic, and then 1 vial is usually 40 milligrams. So used for life-threatening dysarrhythmias unresponsive to conventional therapy. So just to recap, digoxin toxicity, you need to consider your activated charcoal and something called digoxin specific antibody fragments. So you're going to give 10 to 20 vials IV if it's an acute presentation, and 3 to 6 if it's a chronic. 2 to 6 if chronic, and then 1 vial is equivalent to 40 milligrams. And then 1 vial helps to neutralize 0.5 milligram of toxin of digoxin. Okay. So basically it's used for life-threatening dysarrhythmia unresponsive to conventional therapy. So remember, the common causes of digoxin toxicity are your conduction blocks, your AV blocks, your VTAC, ventricular fibrillation. So next, ethanol. You're going to give patient thiamine, 100 milligrams IV or IM, and then manage the airway and circulatory support. So patients, the mouthwash, so you need to order your serum ethanol levels and glucose level and treat glucose level appropriately. And then ethylene glycol or methanol. You're going to give them something called fomepizole. So fomepizole is also 4-methyl-parazole. So 15 milligrams of fomepizole IV load over 30 minutes, and then 10 milligrams per kg 12 hourly. Or you can give them ethanol 10%, which is 10%, 10 moles over per kg over 30 minutes, then 1.5 moles per hour. Alright, so if a patient had an ethylene glycol or methanol poisoning, so you can consider giving them something called your fomepizole, or you can actually give them your ethanol, so 10% ethanol. So at 10 moles per kg over 30 minutes, then at 1.5 moles per hour. So make sure you do your CBC's electrolyte, glucose, check the ethanol levels, and consider hemodialysis. So heparin toxicity, you're going to give patient protamine sulfate 25 to 50 milligrams IV. So this is only for unfractionated heparin overdose only. So insulin, either given IM, subcut, or oral hypoglycemic, you are going to give them glucose. You can give them glucose, per os or IV or nasogastric tube. If it's not working, you can actually give, if no access to glucose, you can give them glucagon 1 to 2 milligrams IM. So consider octreotide for oral hypoglycemics. Octreotide at 50 to 100 micrograms subcut 6 hourly. In these cases, consult your local poisoning center as well. So MDMA, consider decontamination with activated charcoal and supportive care. Monitor the patient's CK, treat your rhabdomyolysis and with high flow of fluid. So you will give aggressive external cooling for hypothermia, and then review medical history if possible for serotonergic use. Opioids, we already say we're going to give them your universal antidote. So dextrose, oxygen, naloxone, thiamine. So tricyclic antidepressant, you need to consider decontamination with activated charcoal, aggressive supportive care. Then you're going to give them sodium bicarb bolus for if they have wide QRS or any seizures. So consideration, flumazenil, antidote contraindicated in combined tricyclic antidepressant and benzodiazepine overdose. So if it's both benzodiazepines and tricyclic antidepressant combined as an overdose, if they ingested both, then your flumazenil is actually contraindicated. So for organophosphate, remember you're going to give them 100% oxygen plus endotracheal intubation. You're going to give them atropine or pralidosime. And consideration, succinylcholine. So alcohol-related emergency, so acute intoxication. How will a patient present with in an acute intoxication? They will have a slurred speech, central nervous system depression, disinhibitions, lack of coordination, nystagma, diplopia, dysarthria, ataxia, and may actually progress to coma. They actually can present with hypotension due to peripheral vasodilation. If they are obstinate, rule out head trauma, intracranial hemorrhage, associated depressant, any toxic alcohols. May also contribute to respiratory or cardiac depression. So make sure you check for your hypoglycemic and, importantly, hepatic encephalopathy, which will present with confusion, altered level of consciousness, and coma. Alcohol level correlates poorly with intoxication. So alcohol intoxication may invalidate informed consent. Okay, if they are alcohol intoxicated, they can't actually give. They're not at a state to give informed consent. So what about alcohol withdrawal? So be aware of withdrawal signs. So treatment of patient with alcohol withdrawal is going to be your diazepam, 10 to 20 milligrams IV per os, or lorazepam, 2 to 4 milligrams IV or per os. So basically, remember, for alcohol withdrawal, you want to give a long-acting benzodiazepine like diazepam. But then if they have maybe liver dysfunction or dysfunction, you might need to consider a short-acting benzodiazepine like lorazepam, so 2 to 4 milligrams IV or per os. So if you give it to them until 2 CWAS score lesser than 10. So frequency of dosing may have to be increased depending on the clinical response. So basically, what is your CWAS withdrawal symptoms? It's nausea and vomiting, tremor, paroxysmal sweat, anxiety, agitation, visual disturbance, tactile disturbance, auditory disturbance, headaches, disorientation. 10 symptoms, each score out of 7, except orientation, which is scored out of 4. So remember, you may actually use this CWAS protocol to give benzodiazepine as above. So until the score is lesser than 10. So you also want to add thiamine 200 milligrams IM or IV. Then, so initial dose of thiamine will be 200 milligrams IM or IV. Then you are going to give them 50 to 100 milligrams daily. Naltrexone and gabapentin if no improvement. So if you give thiamine, there's no improvement. you might need to give them naltrexone or gabapentin. So magnesium sulfate, 4 milligrams IV over 1 to 2 hours if the patient is hypomagnesiamic. Admit patient with delirium tremors. All right. So remember, delirium tremors is the last syndrome of patients with alcohol withdrawal signs. So if they have delirium tremors, they have multiple seizures, or there's a persistent high in your COS symptoms despite the high doses of benzodiazepine, make sure you admit them. So what are we looking at? Just to recap, alcohol withdrawal. What are we doing? We're giving the patient benzodiazepine. First line of treatment is your benzodiazepine. Then your timing. Then naltrexone or gabapentin. Your timing is not showing any improvement. Then magnesium sulfate. All right, if you have hypomagnesiamic. Now, alcohol withdrawal signs. So starting from your mild withdrawal symptoms to alcohol hallucination to withdrawal seizures to delirium tremens. So delirium tremens usually occurs a bit later, and that's the most dangerous stage, about 3 to 5 days. So 5% of untreated withdrawal patients would actually present with severe confusion, fluctuating level of consciousness, agitation, insomnia, hallucination, delusion, tremor, tachycardia, hyperparexia, diaphoresis, and they have high mortality rate. All right. So withdrawal seizure, which is the second danger stage of alcohol withdrawal symptoms, is usually occur between 8 hours to 2 days, and typically patient present with, that's where they have seizure, as it says, withdrawal seizure. They get tonic-clonic seizures and may have several within a few hours. So you need to do a CT scan if focal seizure have occurred. All right, then they can have 1 to 2 days. They can actually present with alcoholic hallucinations, where they have, it's usually visual hallucination than most common. They can have auditory hallucination, tactile hallucinations, and vitals are often normals. So early signs, what are the early signs of alcohol withdrawal? So usually after 6 to 8 hours that after the patient has consumed alcohol. Usually this is usually mild withdrawal, such as generalized tremor, they have anxiety, they have agitation, but no delirium. All right. And then autonomic hyperactivity, such as sinus tachycardia, insomnia, nausea and vomiting. All right. So remember, delirium tremens, as the word says, patients are going to have symptoms of delirium. Symptoms of delirium, they are basically very confused, they're agitated, they cannot sleep, they have they are hallucinating, they are fighting, they have tremors, they're sweating. All right. So what are the cardiovascular complications to alcohol? So alcohol can cause hypertension. Alcohol can cause cardiomyopathy, where the patient presents with shortness of breath and edema. Alcohol can cause dysarrhythmias. Like the most common dysarrhythmias caused by alcohol is your atrial fibrillation. Other ones are atrial flutter, SVT, VTAC, especially your TOSAD, if they're actually hypomagnesemia or hypokalemic. So always make sure that you're checking the magnesium levels and potassium levels. So one of the metabolic abnormalities that you can get with alcohol intoxication, it's alcoholic ketoacidosis. So patient can be in a metabolic acidotic state. They can have urine ketones, low glucose, normal osmolality, usually have a history of chronic alcohol intake with abrupt decrease or cessation. They're actually malnourished, presenting abdominal pain, nausea, and vomiting. And treatment of this alcohol ketoacidosis is usually a timing. You want to give them 250 to 500 milligrams IM or IV prior to dextrose. Then you give them dextrose, then volume repletion. Like you give them your normal saline or Ringer's lactate. And generally the alcohol ketoacidosis should generally resolve between 12 to 24 hours. Then other metabolic abnormalities with alcohol is your toxic alcohols. So such as your ethylene glycol, affecting your central nervous system, cardiovascular system, renal. Your methanol, early symptoms will be lethargy, confusion. Late symptoms will be headaches, visual changes, nausea and vomiting, abdominal pain, tachycardia. So toxic alcohol initially produce a high osmolar gap. As the toxic alcohol is metabolized, the osmolar gap drops and an anion gap develops, leading to severe metabolic acidosis. The goal of treatment is to block this pathway. So what would you do? What do we say the management is? Ethanol. So ethanol co-injection is protective. Okay, so what would be the treatment of this toxic alcohols? We talk about ethylene glycol, we talk about methanol. So treatment, urgent hemodialysis is required. Then we spoke about your we spoke about your fomepizole 15 milligrams per kg IV bolus is the treatment of choice, or you can give them 10% ethanol IV bolus and infusion to achieve a blood levels of 22 moles per liter. So ethanol loading may be done per os. Okay, so fomepizole or 10% ethanol, right? So consider folic acid for methanol and pyroxine and thymine for ethanol glycol. So both help reduce conversion of the to the active metabolite. So other abnormalities associated with alcohol are your hypomagnesemia, hypophosphatemia, hypocalcemia, hypoglycemic, hypokalemia. So next we talk about gastrointestinal abnormalities found with alcohols. It can cause gastritis, so common cause of abdominal pain and GI bleeds in chronic alcohol users. Can cause pancreatitis, where you're going to have elevated serum lipase if elevated serum lipase is diagnostic. Okay. Hemorrhagic form in 15% associated with increased mortality, and fluid resuscitation is very important. Alcohol can also cause hepatitis. In this case, you're going to have the ratio of AST to ALT ratio is more than 2, suggesting of alcohol as the cause. Peritonitis as well, or spontaneous bacterial peritonitis, can present in alcoholics, where you have your leukocytosis, fever, generalized abdominal pain, tenderness, occasionally accompanies cirrhosis, and your paracentesis for diagnosis. So you do paracentesis for diagnosis, and the common pathogens are usually E. coli, Klebsiella, Streptococcus. So albumin shown to improve outcomes in patients. So your alcohols as well can cause GI bleed. So the most commonly gastritis or ulcer, even if patient known to have varices. So consider as well your Mallory Weiss secondary to retching. Okay, often complicated by underlying coagulopathies. So if it's a minor GI bleed, then treat with antacid. If severe or recurrent, endoscopy. If viral bleed, then octreotide. Okay, so that is all for your alcohol-related emergencies. All right. So disposition from the emergency service. So upon discharge, if in a patient with alcohol intoxication, just make sure the vital signs are stable when they can walk unassisted and fully oriented. You might need to explore the need for social services, housing, addiction services, and detox program, and ensure that patient can obtain any medication prescribed and can complete any necessary follow-up. So for ethanol glycol, they might actually need admitted for dialysis. For tricyclic antidepressant, some might need to be monitored in ICU bed. If they're asymptomatic and they have no signs of ECG abnormalities, you can actually observe them in the ED. Sinus tachycardia alone with patients with tricyclic antidepressant toxicity, actually you need to actually monitor under observation in the ED in consultation with the poison center. So any hydrocarbons or smoke inhalation, they are at risk of pneumonitis, and consider observation for repeated clinical and radiological examination. So aspirin or acetaminophen, if borderline levels, so get a second level 2 to 4 hours after the first one. So for aspirin, must have at least 2 measurements showing decreased toxin serum concentration before discharge. So 3 levels minimum. So oral hypoglycemic, admit all the patient for a minimum of 24 hours if hypoglycemic, and 12 hours after the last octreotide dose. Observe asymptomatic patient for at least 8 hours. For opioids, consider you need to administer naloxone, a short-acting opioid antagonist, preferably IV, in incremental doses, so 0.2 to 1 milligrams. The patient in cardiorespiratory arrest following possible opioid overdose should be given 2 milligrams of naloxone minimum. If naloxone infusion is needed, admit in ICU, start infusion, and then you start with boluses, alright? Admit and observe for 24 hours for opioids and refer for rapid access clinic and offer naloxone kit. Psychiatric consultation. Once the patient medically cleared, arrange psychiatric intervention if required. In the setting of an intentional overdose, patient should be certified using the local mental health legislation. Be aware of suicidal ideations may not be expressed. So next we're going to talk about psychiatric emergency. Approach to common psychiatric presentation. So before seeing patient, ensure your own safety. Have security and police available if necessary. So what is the key function of emergency psychiatry assessment? So is a patient medically stable? Rule out any medical cause. Is the psychiatric consult needed? Are there safety issues such as brain injury, head injury? Is the patient certifiable? So must demonstrate risk, present or past tense, and apparent mental illness or future test. So try and get a history. You want to assess the patient's safety and assess for suicidality. Do they have any suicidal ideation? Is it either passive? Suicidal ideation can be either passive or it can be active. Intent. Do they have? What's the intent? What's the plan they have? What is the? Do they have any past history of suicidal ideations? Family history of suicide attempts? What protective factors do they have in place? Also assess homicidality. Do they have any homicidal ideation? Do they have access to weapons? Who are the intended victims? Do they have a history of violence? So assess the safety with driving and being around children, and assess for any hallucination. So identify any current stressors, mood in patient's own words, and coping strategy. Looking for psychotic symptoms, delusion, hallucination, disorganized speech, disorganized behavior, negative symptoms like affective flattening, alogia, avolition. So get a substance use history as well. Want to know what's substances, what's the most recent use, the amount, previous withdrawal reactions. You want to know their past psychiatric history, medication, are they adhering to medication and previous admissions. You want to do your medical history. Obtain collateral if available. Patient are unable to provide collateral if experiencing acute psychosis, so try and get collateral. So physical exams. So have emphasis on mental status. So on the mental status exam, so you want to know the general appearance, the behavior, cooperation, the speech, the mood, and affect, the thought content and form, the perception, disturbance, cognitions. What is their judgment? What is their insight? Alright, so you want to do a complete physical exam, focusing on the vital sign, neurological exams, signs of head trauma, signs of drugs toxicity, signs of metabolic disorder, and then which could actually be contributing or causing the psychiatric presentation. So what are the psychiatric review systems? Mnemonics is MOAPS, the M for mood, organic, anxiety, psychosis, and safety. So you want to investigate. Investigation varies with age. Establish psychiatry diagnosis versus is it a first presentation. History and physical suggestive of organic causes. You need to try and investigate depending on that. So as indicator, you do your blood glucose, urine and serum toxicology screen, pregnancy test, electrolyte, TSH, AST, ALT, bilirubin, creatinine, osmolality. So blood levels or psychiatric medications, you need to test it. If they are on psychiatric medication, you want to test the blood levels. For example, lithium level. CT head if you're suspected neurological etiology. LP if indicated. Alright, so acute psychosis. So what are differential diagnosis of acute psychosis? It could be primary psychotic disorder due to like schizophrenia. It could be secondary to a medical condition like delirium. So acute psychosis can be due to drugs, substance intoxication or withdrawal, medication like steroid, anticholinergics. It could be due to infection like meningitis, metabolic causes that could actually be hypoglycemic or have hepatic or renal or thyroid disease, and then now they're presenting in acute psychosis. Or it could be structural because now they had or have hemorrhage or neoplasm. Now they're actually presenting with acute psychosis. So how would you manage it? So first thing is violence prevention and treat the agitation. So violence prevention is try and remain calm. So try remain calm, be empathetic and reassuring, ensure safety of the staff and patient, and have extra staff and security on hand. Patient demonstrating escalating agitation or overt violence behavior may require physical restraint and chemical restraint. Okay. Then treat the agitation. So whenever possible, offer medication to the patient as opposed to administering it by force. So this helps to actually calm and engage the patient. So how would you treat the agitation with benzodiazepine, lorazepam, 2 milligrams either per OS, per IV, or sublingual? Sorry, I am antipsychotic. You can also give them antipsychotics like lorazepam 5 milligrams to 10 milligrams per also IM, or haloperidol 5 milligrams per also IM. So try and treat the underlying medical condition if there are any, and psychiatry or crisis intervention team, you might need to be consulted. Next, suicidal patient. How would you manage a suicidal patient in the ED? So the risk of attempted suicide is more in female than males, but a complete suicide attempt is more in males compared to female. So men tend to go through with their suicide plans compared to females. So the second leading cause is the second leading cause of death in people less than 24 years old. And then you have a significant increase amongst communities, particularly your indigenous people. So indigenous people at high risk of suicide, and your 2S SLGBT community. So management, the patient presents with suicidal patient. So make sure you ensure safety by doing close observation, remove potential dangerous object from the person and the room, assess thoughts, ideation. So means or action, any preparatory, did they have any action prepared, what practice attempts, any past history, family history of attempts, and then what are their protective factors. So admit if there is evidence of active intent and an organized plan. So if they actively intend to commit suicide, then if they tell you no, sometimes I think about dying, sometimes I just wish a car would just bump me and I die, that's actually passive. So that's not like active. So active intent or organized plan. Assess for lethal means psychiatric disorder, intoxication. In rare circumstances, active suicidal ideation may resolve with few days of abstinence. So in patients that are known to be intoxicated. So a patient may require certification based on the local mental health legislation if unwilling to stay voluntarily. Might need to complete Form 1. So do not start long-term medication in the ED. Psychiatry or crisis intervention team might need to be consulted. So what are the high risk of suicide? It's a sad person. So S, male. A for age over 45 years old. D for depression. B for previous attempt. E for ethanol. R for rational thinking loss. S for suicide in the family. O for organized plan. N for no spouse, no support system. And S for serious illness. Okay, so common pediatrics ED presentation. So this one is the modified Glycoma scale score. So any trauma or suspected trauma patient less than 1 year old with a large bulgy scalp hematoma. A bulgy scalp hematoma requires ultrasound or CT scan. So first, pediatrics ED presentation can be respiratory distress. So you want to take your history and physical exams. An infant not able to feed, older children not able to speak in full sentence. Think about respiratory distress. If they're anxious, irritable, lethargic, may actually indicate hypoxia. And usually tachypnea, it's more than 60. So if it's more than 14, it's usually more than 40 if preschool age, more than 30 if school age. So retractions, they will have tachypnea, retractions, tracheal tag. Alright, so pulse, they can also present with pulsive paradoxus. So rarely used clinically. They can also present with wheeze, vomiting, grunting. Alright, so yeah, you have differential diagnosis of Stridl's upper airway disease. So Stridl can present as croup, bacterium, tracheitis, or epiglottitis. So croup usually occurs between 0.5 to 4 years old. So patient between half an age to 4 year old. And usually they have a history of a viral infection. So mild for days, then acutely severe. Like there is they could, or a family who had a history of viral infection. Okay, because remember, croup is caused by a viral. It's a viral caused by a viral pathogen. Sorry. So temperature is usually low grade. On an X-ray, you have the steeple sign. Causes, most common cause, your parainfluenza virus. They can have a barking cough, and then they can occasionally have drooling. They usually do not appear that toxic. And usually they don't actually require intubation. There's no need for antibiotics because remember it's a viral infection, and just do your oral examination. So remember, group patient present usually has a history, or there's a family history of a viral infection in the family, and now all of a sudden the patient is presenting with fever. They're having a stridor, and then they're having a barking cough and a low grade fever. Okay. So what about bacterial tracheitis? So basically it occurs in patients between 5 to 10 years old. The prodrome is hours to days. All right. And then the temperature is high. Remember, bacterial temperatures are usually high. So when you check the trachea, there's exudate in the trachea. Usually causes Staph aureus or group A streptococcus. The patient presents with barking cough. Usually no drooling. They appear toxic, and usually they require intubation and antibiotics. So you were just doing oral exams. So it's a clinical diagnosis. Remember, croup as well is a clinical diagnosis. So remember, bacterial tracheitis. Patient presents with high-grade fever. You're doing oral exams, and then you see exudating in the trachea, and then they present with barking cough. This toxic appearance and management, you actually need to secure the airway. Epiglottitis, important one, usually ranges between the age of 2 to 8 years old, and this one is very quick, usually minutes to hours. Patient present very quickly, and they present with high temperature. And if you do an X-ray, so if you do an X-ray, you see a thumb sign. Remember, in croup you see a steeple sign, but in epiglottitis you see a thumb sign. It's really caused by a bacteria. So H. influenza type B is the most common cause. So they don't have barking cough, but they are drooling saliva. Okay, so they're appearing very toxic, and you need to intubate them, and you need to give them antibiotics. Usually, you don't want to do an oral examinations. You don't want to use your tongue depressor, because you're actually going to worsen the disease. So you need to consult ENT. So epiglottitis, remember, this occurs between a history of between minutes to hours. Usually clinical diagnosis. Patient is very high fever. They're actually presenting drooling saliva. They are leaning forward because the airway is obstructed. With high fever, they present all toxic. Then you suspect epiglottitis. You want to make sure you secure the airway and intubate, and then your antibiotics. So, but remember now, it's rare to find patients with epiglottitis, because now most patients are vaccinated for H. influenza type B. Okay. So remember, X-ray is rarely performed, usually clinical diagnosis. So management, how would you manage croup? All right. So it's usually known as your laryngotracheitis, and it's caused by parainfluenza virus. So what are you going to do? Number one, you're going to give them dexamethasone, right? 1 dose. And then assess the croup severity using the Wesley score. So in moderate croup, child may have stridor and sternal or intercostal injury at rest, and moderate difficulty breathing. In severe croup, child has stridor with sternal and intercostal injury at rest, and worsening cyanosis over time. So if moderate to severe, add a nebulize. So if it's just mild, it's just dexamethasone. But if it's moderate to severe, add a nebulize or MDI epinephrine, racemic. So racemic has limited availability, so you're going to give them nebulized epinephrine. So consider bacterial tracheitis or epiglottitis if unresponsive to croup therapy. Then give them humidified oxygen. They say humidified oxygen has no evidence for efficacy. So mild patients, dexamethasone. Moderate to severe patients, dexamethasone, nebulized epinephrine. Bacterial tracheitis. So airway maintenance, and usually requires intubation. Your ENT consult in ICU and start them on antibiotics, because usually it's mostly caused by your Staph aureus or group A streptococcus. So you're going to start them with cloxacillin, and then pending and then do your culture sensitivity, especially of the throat if you can. So epiglottitis, you have 4 Ds, right? Drooling, dyspnea, dysphagia, dysphonia, plus a tripod sitting. They're sitting in a tripod position. So drooling, dyspnea, dysphagia, dysphonia, right? So they're unable to breathe well, they're unable to swallow, they're unable to speak, and they're sitting in a tripod position, and they're drooling. So do not examine the oropharynx or agitate the patient. because you're going to aggravate the thing, so the condition. So you do not want to do tongue depressant. Immediate anesthesia, okay, and it's ENT call. You need to call them for intubation, and then IV fluid, antibiotics, and blood culture. So first way is secure the airway, ABC. So next we're going to talk about a febrile infant and a febrile seizure. So a febrile infant for fever more than 38 degrees Celsius without obvious focus. So if they are less than 28 days and the patient presents to the ED with a fever of more than 38 degrees Celsius, always admit. You're going to admit them first and you're going to do a full septic workup. And then you're going to start them on empirical with broad spectrum antibiotics, right? So what are the septic workup includes from CBC, differential CRP, blood culture, urine culture sensitivity, LP, stools, chest x-ray if indicated. Then after quickly you do your septic workup, then start them broad-acting empiric antibiotics, IV antibiotics, and ampicillin, cefazidim, or cefepime, or cefatazine if available, or gentamicin, and then add acyclovir or vancomycin when indicated. So usually it's ampicillin and gentamicin. So if they are between 28 days to 90 days, so depending how the patient presents, okay. So as above, unless the infant meets the Rochester criteria. If so, complete a partial septic workup, your CBC and differentials and blood cultures and urine cultures, chest x-ray if indicated. The next febrile seizures usually occurs in children between 6 months to 6 years of age. They usually have present with fever or a recent history of fever. And then usually have typical versus atypical febrile seizures. And after the seizure, they have a normal neurological exam afterwards. And then there's no evidence of intracranial infection or a history of previous non-febrile seizures. And often have the positive family history of febrile seizures. And usually they're well looking after the seizures. Okay. So what are we looking at? A child between the age of 6 months to 6 years presenting with fever or a recent history of fever. They have typical symptoms of usually it's a generalized tonic-clonic seizures. Afterwards, the neurological exam is normal. And then you need to check for the source, any other sources, rule out any other source. And there's no meningism, signs of meningism. There's no signs of or evidence of intracranial infections. All right. And the patients are well looking after the seizure. So it's more likely to be a febrile seizure. Investigation, if confirmed it's a febrile seizure, then treat the fever and look for the source of the infection. And if not a febrile seizure, treat the seizure and look for the source of the seizure. So the note may also have fever but may not meet the criteria for febrile seizure. So you might want to do is EEG, especially if the first seizure, or head ultrasound if the fontanelle is open. You might want to do a head ultrasound just to see if there are any bleeds if the fontanelles are still open. If they're closed, then you have to do CT scan. So typical versus atypical febrile seizure. So typical febrile seizure are less than 5 minutes. And usually they're generalized tonic-clonic seizures, and usually there's really one in 24 hour. So atypical one, the ones that you should be worried about, is if the duration is more than 5 minutes, and usually it's a focal features, so focal seizure. And if they get more than one in the 24 hour, then you should be worried. Next, abdominal pain in children. So try and get a history. You want to know neurological infections, autoimmune, hematological trauma, history of abuse as well. And the nature of pain associated, is associated with fever, any associated GI or urological symptoms, anorexia, decreased fluid intake. You want to know any history of stress or social issues, most common in the middle-aged children, especially those who go to school and stuff. So you want to do physical exams, respiratory, do your ENT exams, abdominal and testicular exams. So what are the red flags for an abdominal pain? So significant weight loss or growth retardation. So you need to plot them on a growth chart. If they have abdominal pain and a fever, red flag. If they have abdominal pain and joint pain with objective physical findings, if they have abdominal pain and rash, if they have abdominal pain and rectal bleeding, if they have abdominal pain and rebound tenderness and radiation of pain to the back or the shoulders or the legs, if they have abdominal pain with pain that wakes them from sleep, or abdominal pain with severe diarrhea and compresses, then you need to further investigate. So always remember to keep an index of suspicion for child abuse. Alright, so what are the common infection in children? The antibiotics treatment of pediatric bacterial infections for patient who has meningitis sepsis. So if their neonates less than 28 days, usually it's your group B streptococcus, the most common cause, followed by E. coli, your Listeria, your gram-negative bacilli, and you would give them ampicillin and cefotaxime and ampicillin. Either between 1 month to 3 months, same pathogens as the one above, okay? You would give them as well ceftriaxone or cefotaxime plus vancomycin plus ampicillin if they're immunocompromised. If they're more than 3 months, usually you're looking at your strep pneumonia, your H influenza if they're more than 5, your meningococcus, and then you're going to give them ceftriaxone plus vancomycin as management, empirical treatment. So otitis media. So first line, you're thinking about your streptococcus pneumonia, your H influenza type B, your M. catarrhalis, and the first line of treatment is amoxicillin. So amoxicillin 75 to 90 milligrams per kg daily, and you give it twice. And then if the first line, but then they are penicillin allergic to penicillin, then you give the cefprozil or cefirozim, or even ceftriaxone, okay, or clarithromycin if they're allergic to penicillin. So if the first line fails and then they're not allergic to penicillin, you're going to give them amoxicillin to clavulanic ratio, so augmentin, amoxicillin plus clavulanic acid. So if they're less than 35 kg is 45 to 60 milligrams per kg per day. More than 35 kg is 50 milligrams for us 3 times a day. So strep pharyngitis. So for strep pharyngitis, usually it's caused by your group A, beta hemolytic streptococcus, and management is your penicillin or amoxicillin, cefalexin or erythromycin can cause GI upset. Right, so the most treatment is your amoxicillin. UTI, usually most common cause is your E. coli, the Proteus, H. influenza, Pseudomonas, Enterococcus, group B streptococcus. Orally, if they're able to swallow, you're going to give them cefizim. If IV, they can't swallow, then you're going to give them aminoglycoside like gentamicin plus or minus ampicillin, or use cefotaxime or ceftriaxone. So for pneumonia, children between 1 to 3 months, usually you're looking at could be viral cause streptococcus pneumonia, could be chlamydia trachomatis coming from the mother, it could be a pertussis, could be Staph aureus, H. influenza. So management is ceftriaxone. 3 to 5 years, could be viral streptococcus pneumonia, Staph aureus, H. influenza, mycoplasma pneumonia. So if discharged, amoxicillin, and if admitted, ceftriaxone. More than 5, could be any of the above pathogens, and then ampicillin or amoxicillin or cefirozim can be given. So next, child abuse and neglect. So you have the obligation as a physician to report any suspected or known case of child abuse or neglect to CAST yourself. So you do not delegate somebody to report it for you, so do it yourself. So always document injuries and consider skeletal survey X-ray, especially in a non-ambulatory child. You should do ophthalmologist consultation, CT scan. So injury pattern associated with child abuse are what? Number 1, head injury. If they present with torn frenulum, a dental injury, bilateral black eye, they have traumatic hair loss, if they have diffuse severe central nervous system injury, if presenting with retinal hemorrhage, think about child abuse. Then shaken baby syndrome. If they have diffuse brain injury, subdural, or so think about shaken baby syndrome. If they have diffuse brain injury, they have subdural or subarachnoid hemorrhage, retinal hemorrhage, minimal or no evidence of external trauma, associated bony fractures. Right, skin injuries that can be associated with child abuse or bites, bruises, burns. So burns in shape of an object, a glove or stocking distributions of burns, bruises of various ages, bruises in protected areas like the abdomen, okay, or the back. And then bone injury associated with child abuse or rib fracture without major trauma. Right? There's no history of major trauma, but they have rib fractures. They're femur fractures. They're lesser than 1 year old, and then they're femur fractures. So they're not even walking, but they already have femur fractures. So suspicious spiral fracture of long bones in a non-ambulatory children. So a child is not walking, but then they present with a spiral fracture of long bones. Your metaphyseal fractures in infants, multiple fractures of various ages, complex or multiple skull fracture. So GI symptoms are associated with child abuse, chronic abdominal or perineal pain, injury to the genitals or the rectum. If they present with STIs or pregnancy, recurrent vomiting and diarrhea, think about child abuse. So presentation of neglect, they usually present as failure to thrive, developmental delay, inadequate or dirty clothing, poor hygiene. The child exhibit poor attachment to parents. Alright, so what are the common medications that are used in an ED setting? So number 1, acetaminophen is used for pain control. Maximum dose that can be given is 4 grams daily. Activated charcoal used for poisoning or overdose, and then aspirin. So maximum aspirin that can be given daily as well as 4 grams per day. Alright. So in patients who have risk of stroke or MI, just to give them prophylaxis aspirin, you're going to give them 81 to 325 milligrams per ounce daily. So the aspirin helps in pain control and prevention of adverse cardiac events, and also for patients presenting with acute coronary syndrome, okay, need to be given aspirin. Beta blockers, metoprolol. So rate control, okay, so beta blockers are important for rate control in patients with AFib. So AFib, patient presenting with AFib, they are elderly patient, they are maybe stable, then you want to give them a beta blocker as a rate control. So 5 milligrams slow IV, or if no contraindication. Alright, diazepam. Remember, it's long-acting benzodiazepine given in alcohol withdrawal and anxiety. So diazepam. So anxiety patient, you're gonna give them 2 to 10 milligrams per ounce TDS. Alcohol withdrawal patient usually get 10 to 20. So anxiety 2 to 10, alcohol withdrawal 10 to 20 milligrams per also IV. Okay. Next, enoxaparin. Enoxaparin is also known as Clexate. Usually you can give it in an acute MI. You can give it in DVT prophylaxis or treatment, PE or DVT in patient who cannot take your DOACs. So epinephrine, so it's going to be 1 milligrams per kg subcut twice daily. Okay, 1 milligrams kg subcut. Epinephrine is used for patient with anaphylactic shock. That's the first treatment when you give an anaphylactic patient, and then is in the ACLS cardiac arrest, ACLS bradycardia, hypotension. So anaphylactic shock doses of epinephrine is 0.3 to 0.5 IM. The cardiac arrest is a 1 milligram IV, repeating it every 3 to 5 minutes. Okay. So doses in the cardiac arrest is a full M. Okay, so 1 milligrams. All right. So bradycardia as well, you can give them 2 to 10 microgram per minute IV infusion. So you can give also epinephrine in a hypotensive patient that you have given fluid and they are not getting better. So you want to consider giving them an infusion. So maximum dose that you can give in a cardiac arrest, anaphylactic patient, so maximum dose 1 milligram per dose. I'm not too sure. So next, fentanyl. So it's actually for pain control and procedural sedation. So it has a short acting, and the complications it can cause apnea. Remember, it's an opioid. So furosemide is used in patients with hypertension and congestive heart failure. In congestive heart failure, you can give 40 to 80 milligrams IV. In hypertensive patient, you can give 10 to 40 milligrams per OSPD. So make sure you monitor your electrolyte imbalance. Also, at high doses can cause ototoxicity. So patient can present with hearing loss if they were given high dose of furosemide. So normally check your potassium levels when you're given furosemide. So glucose, given a hypoglycemic, haloperidol, acute psychosis. We want to give them in psychosis. Cannabis, a hyperemesis syndrome. So any nausea or vomiting, you can give them haloperidol. Sedation as well is also used for sedation. So monitor side effects if prescribing to patient with Parkinson's disease because of extrapyramidal side effects. And can also result in central nervous system depression. Right. Ibuprofen, usually used for mild to moderate acute pain, analgesic and anti-inflammatory properties. Insulin, used for hyperglycemic, or you also use for calcium channel blockers and beta blockers overdose. Okay, and always replace your potassium. Always monitor your glucose levels, and ensure you have measured your glucose level before you administer insulin. Ipratropium bromide is used in asthma and COPD, and then usually contraindicated. Contraindications include peanut or soy allergy, and caution with a narrow angle glaucoma. And then contraindication in patient who have peanut or soy allergy. Lidocaine with AP, usually used as a local anesthetics. Lidocaine without AP can also be used as a local anesthetics. Alright, but the dose is lower. So lorazepam is used for anxiety, status epilepticus, alcohol and withdrawal. So anxiety, patients use 0.5 to 2 milligrams, either per also IM and IV, 6 to 8 hourly. Status epilepticus using 4 milligrams IV, and repeat up to every 5 minutes. So depending if the seizure is still progressive.